Hello, Professor Kato. Good evening.
Hi, Raja.
Hi.
Thank you very much. So I'm so sorry because today is a Saturday.
That's okay, no problem.
Thank you so much for your support.
Most welcome anytime. We have few people joining in. You will be joining us soon, as I. And
Hi, Hafiz.
just promoting everybody to the panelist lists.
Hi, Hafiz. How are you?
Yes, hello.
Hi, how are
Good morning.
you?
How are you, everybody?
Hi. It's a good
I'm
afternoon.
so happy to be here. I'm so
happy to see
honored
you.
and happy
Thank you very
being
much for your
here. And
support.
thank you very much.
Thank you so much.
And thank you for Professor Liu and for Dr. Boone and everybody on the panel. Thank you.
Thank you so much. Thank you.
You're welcome.
Thank you.
Dr. Olaf has just joined us.
Hello, good morning.
Good morning, Doctor.
Hello.
Hi, good morning.
Good morning. Good to see you.
I think it's good afternoon in your part of the world.
Yes.
Yes.
Japan is almost 4 p.m.
All right.
Thank you, so Olaf, for your joining and dedication for YNS. Thank you so much.
Hello, Liu. Can you hear us?
Hi, Raja. I just unfollowing my
Hi,
video.
Liu. How are you?
Hi, Prof.
Thank you for everything.
No problem with the cam. Yes, we can see it.
It looks nice. Yes. Maybe very hot, I think. Over 30 degrees.
You are muted. Liu, kindly unmute yourself.
Yeah. Sorry, it's about 34 today, Prof.
Okay.
Professor Don.
Hello.
How are you? Hi,
Dr.
how are you?
Kato.
Hi.
Long time no see.
Yeah, nice to see you again.
Yeah, long time no see.
Yeah.
Yes, I work in Chirai Hospital.
Yeah.
Yes, long
Thank
time
you
no
so
see.
much.
Yeah, long time no
Thank
see.
Yes, long time no see.
It's
Yes.
nice to meet you
Hi.
again.
Yes, I'm so happy to see you again.
Yeah, very, very happy to see you again, Mr. Kato, Professor.
So, Professor Don from Hanoi, Don Hey.
Yes, Chan Huan Bin. My name, first name is Vin.
Hey. Okay.
Yeah. Okay.
Is there Dr. Hay is with us now?
Dr. Hiền,
Yeah, Dr. Hay. Dr. Hay.
Trần Minh Hiền.
I don't see his face.
Well, there is a professor who is in the attendees. I'm trying to promote him, but he is not accepting our request. Professor Tran Hoi, please click on accept. Do not click decline. Professor Tran Hoi, please click on accept when we promote you to the panelists.
And Dr. Raja, so can you see Dr. Andreas?
No, not yet.
Not yet.
Yes, sir. You can see Professor Karl Rosler. Professor Karl Rosler is here.
Yeah.
Welcome, Professor Karl.
Yes, hello, good morning, good morning. Thank you for inviting me.
Hi, good morning. How are you?
Thank you,
Oh,
fine.
Thank you so much for your dedication.
Thank you for inviting.
Thanks so much.
It's nice to meet you, Dr. Bun Sen Liu. We received all the mails from you.
Yeah. Yes. Thank you, Professor.
Bun Sen Liu. Yeah, yes. I'm Dr. Bean. Yeah.
So, Dr. Raja, so maybe should we
Nice to
start?
meet you.
Yes, of course. Liu,
Yeah.
please take over.
Yes, Dr. Liu. So you want to say something at the beginning? It's 4 o'clock in Japan time.
Good morning, good evening, and good afternoon to all our respected speakers. Today is the first time we're having ACNS-EANS-North Africa and Vietnam web seminar this year, 2023. We have many speakers, as you can see from the program. So without further delay, we would start with the opening speech from Professor Joko Kato, the president of the ACNS. Professor.
Okay, thank you very much. Well, thank you for everyone. Maybe good morning, good afternoon, and maybe good evening, everybody. So thank you very much for support the ACNS education in the world. Especially at this time, we focus on the some part of the Africa and also Vietnam, of course, and also the great teacher the EANS gathering. So I would like to start. Today that we have 18 talks, the EANS, the 5 talks, and Vietnam 5, and 2 from Myanmar, and 2 from Japan, and 1 from Taiwan. In Africa, the 3 talks. The Vietnamese are very much looking for your great lecture, and the talk will be covering all over the Zealand, I think almost all. So I think we should start. Maybe the Andreas will join later. He said he's on the way of the journey, so maybe once he joins us, maybe he will talk something. Thank you very much. Thank you.
Thank you very much.
Thanks so much. So should we start the first program? We don't see the Dr. Shakombi from Nigeria.
Shakombi is not here yet, and Professor Dong is not here yet, and also Professor Andrew is not here yet. So we may start with our first lecture first. Professor Muhammad Hafiz is here, who is the professor of neurosurgery from Cairo University, Egypt. Also the secretary of the Middle East Neurosurgical Society, and he will talk to us on thoracic outlet syndrome, diagnostic pitfall, anatomy, abbreviations, and outcome. Professor, are you ready, Professor?
Please unmute your mic, Professor Muhammad Hafiz. Your mic is muted, Professor.
Hafiz? Yeah, please unmute.
We cannot hear you.
Okay, can you hear me now?
Yes.
Hello?
Hello.
Yes, we can hear you.
Yes, perfect.
Well, Professor Andreas has
So
joined
thank you
us.
very much.
Andres,
Dr. Liu,
Yeah, he's joined us, Professor
oh,
Andreas.
he's on. Just can you, Hafiz, can you wait a bit? So,
I can start now if you like.
Yes. So,
Yes.
President Andreas.
Good morning. I'm trying my
Hi.
computer. It's not working, so
Yes,
I'm on the
yes.
phone at the moment. Good morning. How are you?
Well, how are you? Thank
Good
you very
morning,
much
everybody.
for your recommendation, the excellent the speakers from ENS. So just you can make some the short comment for ENS and also overview of our seminar, please.
It will be, yeah, very short. Yeah, I don't want to delay.
Would you like to say something, Professor Andreas?
Yes, please.
Yeah, when do you want me to do so?
Now.
Please.
Okay, great. Well, in that case, thank you again very much for involving the ENS in this initiative. It's an excellent opportunity to learn from each other and to exchange our experience, knowledge, and concerns for the benefit of our patients. Thank you again to Professor Yoko Kato for organizing this. And also thank you to all the speakers. It's Saturday and they're giving us their free time. So we're all very grateful and wish you all a successful day.
Okay, thanks. So you have some journey, so bon voyage. Thank you very much.
Thank you, thank you.
Thank you so much. So Kavir?
Yeah, so sorry, Professor Hafiz. We have Professor Dong here. We may start with a short speech and his lecture first, followed by yours, Professor. Thank you, Professor.
Okay.
Professor Dong,
okay.
Would you like to introduce yourself and start your lecture? He's the chief of a neurosurgery department of Vietnam University Hospital Hanoi in Vietnam. Professor Dong.
Dr. Hay? You maybe later, I think.
I think he maybe disconnected. Just now he was here. Okay. Then if there's the case, I will call upon again Professor Hafiz. You may share your screen,
I'm here.
Professor.
I'm here anytime. I'm here.
Thank you very much, Professor.
Okay. So first of all, I'd like to really thank you, Professor Yoko Kato, Professor Liu, all our distinguished professors for having me. And I will start straight away so that I don't waste time. So I will share my screen and start the presentation. It's on thoracic outlet. It's a very difficult subject. And I think that many people are underdiagnosed, and we see many people walking into our clinic and they're telling us that they're having cervical problems and arm problems, and we just don't know how to diagnose them. In many times, many a situation, we would have that patient coming in with a small disc and everyone is saying, okay, this is a cervical disc and treated as such, and the neck collar hurts them. And the different ways of treating cervical disc just affects them even more. They are not aware of posturing. They are not aware of anything to do with true management of thoracic outlet. I would treat those, first of all, conservatively, tell them how to sit and to do basic exercises and to practice more, on being not sedentary and walking around and doing different chores and straightening their back. That's a simple thing. Just straighten your back, you'll be better. So let's get started with our presentation. So, okay. We operated 39 cases, 34 were females, 5 were males, and they were selected for operation after, of course, failure of conservative management. And out of 216 cases, we had 39 operated because they were coming in really in agony and we had to do their thoracic outlet. You will see some examples at the end of the talk. So mostly were diagnosed, I told you, as cervical disc prolapse and neck collars, and very few have been told once, shyly because they don't know how to manage, that they had a possibility of thoracic outlet syndrome. So I would diagnose them as a very strange diagnosis as they come into the clinic. Their arm position is like Napoleon. They are stuck to as if they're having a heart attack. And the problem is that this is the best way they can hold their arms. So I call it the Napoleon stance. It's one nomenclature I've given to such patients. 39 came in with positional pain. When they change position, they are relieved from the pain. Some had dorsal scapular nerve pain. You know, the dorsal scapular nerve crosses the scalenus medius as it goes to its path to the rhomboids and to the posterior part of the arm. So sometimes they would come in with dorsal scapular, and I see it invariably. So in about 29 of the 39 cases, they came in with dorsal scapular nerve. Sometimes it will have a vague numbness in the front of the chest or the back of the chest, and very much resembles an anginal pain. So you should really diagnose those. That's a very important, controversial part of management of such cases. We had some cases with muscle weakness. Some were mild, only 2 were severe. And we had one case of a double crush syndrome. Double crush meaning it was affected once in the cervical disc and then in the thoracic outlet. We had to operate the 2 at the same time. And one, we had it at the ulnar nerve at the elbow. So by examination, we found the best tests we can do was the Roos-East test and the compression test. The Roos-East is like this, opening and closing with extension and abduction at the shoulder. And we do it under a minute. They cannot keep their arms up for a minute at all. And sometimes we had severe swelling, and venous element was big. And in 6 cases, in 2 cases, we had an arterial element as well, and there was pallor and definite signs of arterial problems. The history of such a condition goes back to the 2nd century, while Galen Vesalius described it, and Sir Astley Cooper. We have tests with every single name of those in St. Bartholomew's Hospital, and this was Coote talking about excision of exostosis of the transverse process. And we will know later that this is the most common bony compressing element of that research. So over the years, they have been describing Pete in 56, Adson in 27, and he named the test after him, and Schroeter, the Grotter-Schroeter test as well. So now we talk about clinical presentations. Sometimes it comes with the upper plexus, mostly in the shoulder, around the shoulder, maybe some numbness, some weakness in the deltoid. And then the lower plexus, we will have pain, paresthesia, weakness in the hands, and the hand grip will be affected. Sometimes we will have muscles that are weaker. Arterial symptoms such as pallor, cyanosis, paresthesia, venous such as swelling, heaviness, and redness. Maybe with the upper, we can talk about the upper. The upper has the anterolateral part of the neck and the clavicle, and that part can be a little bit numb, and it is aggravated by tilting the head to the other side or to the same side. So it differs. The tests are very fallacious sometimes. The predisposing factors, maybe we talked about that. That's postural, sitting forwards with drooping shoulders. It happens more in females, probably because their sedentary life entails that they have drooping shoulders, and maybe in some cases the weight of the breasts, of course, and without proper exercises and information to those females, we have a lot of thoracic outlet occurring. In the literature, it's 4 to 1. We have seen it as 6 between 5 and 6 to 1 between females and males. So this is very rare. The Gilead summer hand is very rare. The pulsatile, in one case, we had an aneurysm of the subclavian artery, and this was the shape of her hand. And venous signs, of course, you know, intermittent edema, cyanosis, unequal arm measurements. You will have swelling that is on and off. It is intermittent. Sometimes it is completely swollen and is not intermittent when it's been going on for a longer time. So these are provocative tests that we can do. These are the most important ones that I found that were positive. The Morley compression test, you just compress in the supraclavicular region. The Adson test and the Roos East test, which is the extension objective. I found this to be the most significant. So a thoracic outlet is a diagnosis of exclusion, meaning that you have to exclude cervical disc prolapse, because in 2 cases of my thousands of cases that were operated for cervical disc prolapse, they were coming in with that same, like sciatica sort of stance, the flexion attitude of the nerve. They cannot extend. When that happens, the nerve is retracted and hurts a lot. So let's see what the differential diagnosis is a big list. So one of them is brachial neuritis. And of course, brachial neuritis, you can see in different types of, let's say, herpes zoster, neuropathies in general, in syrinxes, in Raynaud's disease, of course, vasculitis, peripheral nerve compression in other regions, local shoulder pathology, because sometimes fractured clavicle can have its impact on the brachial plexus. Apical lung tumors, I've operated 1 or 2 of them. So it is very important to team up with somebody from the chest so that neurosurgery and chest surgery will produce the better product and the better patient, the long-lasting patient. We go all the way to Simpson's fascia. You can imagine how dangerous that is. And so at the beginning of my paper, I forgot to introduce, but I must introduce a good friend from the Cancer Institute that we have done this paper together, Dr. Abdurrahman Mohammed, and he is an expert at chest surgery in oncology. The diagnostic workup includes symptomatology, motor defects, provocative tests, such as Morley's and Roos East, plain X-rays, CT root of the neck, MRI sometimes. It's very difficult to interpret the MRI sometimes. And EMG and nerve conduction studies are not significant. Very few positive results. And so we must rely mostly on the clinical aspect. So as you can see, this is the cervical rib. In a few cases, not many. I think we saw them in about 4 cases. A true cervical rib. A fractured clavicle. I had 1 case diagnosed as she also had a cervical disc prolapse and this fractured rib, and she had a red, almost discolored upper limb. So we diagnosed her as such, and we found a severe compression. She was, I think, 12 years out of misdiagnosis, and a bullet injury. Reconstruction angio can help. And remember to know that it's not just the subclavian and its tributaries, it's also going up to the vertebro-basilar system. So the symptoms are not just numbness, weakness, and geographic findings, or arteries and veins compressed. It's also going up to vertebro-basilar system. Some people can come with vertigo, and it will be the cause would be down in the subclavian vessels. This is MRI. We can do abduction and adduction and see the difference with 3D reconstruction. Arteriography, you can see the skip lesion in one of our patients because she had an arterial graft and it was occluded. So we had the vascular come in as well, and they reconstructed that graft and made a new system. This is the reconstructed graft. Color Doppler could help. Neurophysiological studies. Surgical anatomy. This again, we have 3 compression sites that are mostly important and can the 2 bigger ones could be approach from a supraclavicular approach. So 2 fingers above the clavicle, and we make our incision. We can address the interscalene triangle. The anterior scalene is just behind the subclavian vein and in front of the subclavian artery, and between it and the medius lies the brachial plexus. Remember that the dorsal scapular vein, dorsal-thoracic vein, will traverse the scalene medius and will go all the way to the rhomboids, and this is the most pointing point when they have the pain syndrome. So you can address this triangle and also the one between the clavicle and the first rib. So these are the 2 most important places where it will be impacted or compressed. Again, this is a representation of the anatomical structures in the scalene, interscalene triangle, and the one between the clavicle and first rib. Of course, the third one is the between the coracoid and the pectoralis minor, but it's not as important. Some people say it's important. Here it is. Sometimes it's strapped here, but it's of lesser significance than this one. We had only 1 case that was strapped also in this subclavicular area. Yeah, these are the 3 compression points that you can find. So again, the presentation, and this is the brachial plexus. Of course, we find the trunks that are available for decompression. This is the first strip. The trunks become divisions after the first strip. So this is the place where we find compression most. So it is a space problem. It occurs because of insufficient space for neurovascular structures. The etiology is immense. It's everything in this area. It's bony, it's muscular, it's tendinous, it's arterial, and it's venous. Anything can compress. So if there's a true bony cervical rib, which occurs in about 10% of cases, so type 1 is a complete rib. Type 2 is an incomplete rib with some fibrous tissue connecting it to the costoclavicular junction. And this one is just an increased, or let's say an enlarged transverse process, and a true cervical rib that does not continue to the first rib. Otherwise, there's elongated processes with tendinous intersections, small tendinous and large tendinous. They named every type. So you have a bigger scalonus medius, fibrovascular muscular band from the neck of the first rib to the scalene tubercle, and a bigger anterior scalene muscle with scalene minimus, which is another accessory muscle that can occur with that will compress the lower trunk, of course. Band from the scalene to the costochondrial junction. Every type, they have named a lot of types. We have seen about 5 or 6 of them, and we can't name them because they're full of everything. When you open up, it's full of all types of these mixed together. So I don't think we can think anymore of fibrous bands and muscles, thickened scalene medius, and scalene minimus. So it's just a mix that you see intraoperatively. So of course, number one, and the bigger type of treatment, in almost 60 to 70% of cases, we need pain control, exercises, postural exercises, and the patient will be better. In many cases, most of these cases. Surgery for TOS is transaxillary, subscapular, and supraclavicular. We found the supraclavicular approach to be the most significant and salient of them all, and they can get two compression areas easily. And this is exactly what we do intraoperatively. So we draw at first the clavicle, the sternomastoid, anterior scalene, and middle scalene muscles. And this is the scalene triangle. This is our incision, almost 1 to 2 fingers above the clavicle. Of course, we do it with the skin lines. So first of all, we separate the platysma and the supraclavicular nerves, and we make sure that we keep them so that the patient doesn't have numbness of the neck. These are the supraclavicular nerves, and they're branched from the external jugular. And here we go deeper. And here we see the phrenic nerve overlying the scalene anterior muscle. And here are the 3 main trunks of the brachial plexus, separated and away from this is the first rib. Maybe you can see it in the background. This is separated to show you the rib. This is another case. These are the most illustrative cases, so I haven't put them all, of course. Supraclavicular nerves, you can see the inside of the lung now after separation of the brachial plexus from the deeper structures. And maybe this is the first rib here, right here. Yes. And this is the completed surgery. And you can see the Simpson fascia and the lung in the deeper structure. This was a 50-year-old female. You can see the elongated first rib right here, cervical rib. And this is the completion of surgery. And you can see the fine, and this here, yes, this here is the first rib, and it was actually compressing the neural structures. And this is very clear. The lung can be well seen here. And this is after completion of surgery. And this, of course, is the phrenic nerve right here. This is before and after removal of the first rib and the transverse process. We had the grafting of the vascular surgeon had to come and help us with this operation. So clinically, we had one intraoperative injury, and we brought the vascular in to come and help us with it. We had a subclavian muscle tear, and we had a lymphoria in 2 cases. They were treated conservatively, by the way, and they went well, but it was very burning and swollen at the beginning. So we had neuropraxia in 3 cases. We had improvement in pain in 37, that was direct improvement, and a delayed improvement. 5 were directly getting better, and the rest took some time. Improvement of weakness in 3 cases. They were 3 cases. The severe ones did not improve straight away. They took about 2 to 3 weeks to improve. We had no deterioration of function, and we didn't have a loss of function in any of our cases, thanks to good dissection, of course. So this is the phrenic nerve. These are just illustrative cases. And these are the trunks of the brachial plexus, well preserved and can be seen to pass to the upper limb. So again, the anatomical variants we saw: 15 elongated transverse processes, 6 cervical ribs. The first rib was anatomically different than normal. It was looking up, so it was the sharp border was hurting the emerging nerves. There was no bony element at all in 15 of our cases. There was a large fleshy scalenus medius in most cases, maybe 2/3 of our cases. The vascular element in one case with a subclavian aneurysm and one for recurrent grafting in the subclavian. These are some interesting readings. Maybe you would like to review and see in the future. So thank you very much.
Thanks so much. Look at you.
Yeah, thank you, Professor Hafiz. We have, can you unshare your screen, Professor? We have
Yes,
a Professor,
of course.
he is here. We will leave the Q&A later after the 4th or 5th speaker. Professor, if you can stay on after this. May I call upon Professor He? I saw him just now. Yes,
Yeah,
okay,
hi.
thank you, Professor.
Hi, hey. How are you?
Hi. Thank you, I'm fine.
Hi.
Hi. How are
Hi.
you?
Good evening. How are you? Thank you very much for organizing this webinar.
It's me. Thank you very much. I have a little bit connect now. May I can share my screen now?
Yes.
Yeah, sure, Prof.
You see my screen?
Yes.
Okay.
Yes.
Ladies and gentlemen, I would like to share the current Vietnam neurosurgical situation and the future. Vietnam is located in the East Asia, and you can see here the China, the Japan, Indonesia, Vietnam is here. Yeah, this is in Southeast Asia, and Vietnam is here, and it's not so. It's too close: China, Cambodia, Philippines, Singapore, and Malaysia. And in Vietnam, there are a very beautiful place like Ha Long Bay. Did you see in the on the picture? Please welcome to Vietnam. This is a very beautiful place and famous place in the world. And Vietnam is a developing country with a lower median income. We have already 100 million people. And Hanoi is capital, and the largest city is Ho Chi Minh City in the south. For the training program in neurosurgery, we have 6 years in medical school. And for become the neurosurgeons, they have to do 3 years for level 1 in neurosurgery. After finish level 1, they can do trauma on emergency in neurosurgery. And for become being neurosurgeon, they need to do 3 year more for level 2. And sometimes they either do the fellowship for 1 month, 3 months, 6 or 1 year. Nowadays we have 785 neurosurgeons in Vietnam, but a half neurosurgeons work in 2 big cities, in Hanoi and Ho Chi Minh City. That means a half the neurosurgeons work in the other province, 61 other provinces, like rural and remote area. And that means there's a big difference between neurosurgery in the big city and the province. The big city, we can get the microscope, endoscope, navigation, and sometimes robotics, the modern facility. But in province, they have a very limited facility. in Vietnam, there have been a growing demand for neurosurgical care, increases the number of patients with TBA, stroke, and brain tumor, and the others. And we have several challenges facing the neurosurgical community, including indicated infrastructure, limited access to care, shortage of trained professionals. Yes, there are 5 big challenges in neurosurgery in Vietnam. Accessibility. Many people still lack access to quality neurosurgical care, especially in the rural or remote area. This is a significant barrier to receiving timely and appropriate treatment. Affordability. The cost of neurosurgical care is expensive for many patients and their family. Infrastructures. There are shortage of trained staff, outdated equipment, and limited facility. This can, of course, impact the quality of care provided to patients. Medical malpractice. Even we have many highly skilled neurosurgeons, but there have been several cases of medical malpractice and negligence in recent years. And the other problem is training and education. There is shortage of trained neurosurgeons and healthcare professionals. We need more comprehensive training and education program. And that's why we need to increase the number of trained staff, training and education program, and we need cooperate between government, non-government, and non-profit organization. And we need to increase the quality of healthcare facility, investment in facility, expanding access to specialized equipment. And that's why our society, from 2 years, we organize the weekly webinar. Up to now, we organize 88 webinars. Every week, we organize a webinar on Friday evenings. Average participant is 120. It's from 100 and sometimes 350 participants for one webinar on Friday night. And now we start to organize a webinar in English from 6 months, 1 webinar a month. The topic is for everything in neurosurgery, like TBI, traumatic spine injury, brain tumor, malformation, hydrocephalus, scan-based, pediatric, everything. And for the future, we would like to improve our situation in neurosurgery. And first, I think we need to increase the training and education program. And when comes to all the neurosurgical society from the world, and we would like to organize the webinars, online or offline meetings. This is very good for our society. And we would like to improve to expand access to advanced technology and equipment, improve the quality of healthcare facility, and improve the telemedicine technology, especially in the rural and remote area. For conclusions, even there are still many challenges facing neurosurgical healthcare in Vietnam. There have also been many positive developments from some years, and we can focus on trainings, education, investment in infrastructure, equipment, and technology. And we hope we can do more for our patients in neurosurgical fields. That is first things. And the second thing I would like to share today is the lesson from endoscopic endonasal transmission approach for scan-based lesions. Everybody knows that we can treat the scan-based pathology by traditional approach or endoscopic endonasal transmitted approach. From 2008, I start to do the first endoscopic endonasal approach. And up to now, I do almost more than 800 cases, including pituitary adenoma, blood gases, cranopharyngioma, meningioma, chordoma, and the others. And this is 5 lessons I would like to share with the young for the EETAs. First, how to open. Everybody knows that we can open by creation or dream. It is important for scan-based surgery. And after that, we open the diameter and remove the tumor. But I see some young, some beginner, is open is not enough. It is some pictures show that they open the scan-based is not enough. It's too small. This is one case. Is a patient is operated by the other doctor from other hospital. And the patient transferred to me, and on CT scan of control, you can see the sella fossa, the bone is open, is very small, too small. And that's why we cannot control the tumor, and we cannot remove the tumor as we can. We need to remove the bone as big as we can. We need to remove big enough. This is very important things. This one case, I remove the bone. It is easily with dream, fast, safe, and big enough. It is very important thing for the scan-based surgery. With microscope or endoscope is the same. We need to open big enough. It's very important. You can go around. And when we open the bone is enough, can open the diameter, and we can control around the tumor. It is cranopharyngioma. When we open the diameter enough, of course, the bone is already removed, and we can control around the tumor like that. It's clearly, safely, and we can remove totally the tumor. And that's why I think the first lesson we can learn, it is open big enough. It's very important things for endoscopic endonasal approach. And the second lesson is how to stop bleeding. Of course, sometimes we can see the bleeding, and this is important bleeding from the platine artery. We try to stop bleeding with microscopic bipolar. We don't have a endoscopic bipolar. We use a microscopic bipolar. It's difficult to stop bleeding. Sometimes it's difficult. We cannot. Take some time. But in the end, I use monopolar to stop bleeding. And it's good. Sometimes it's like that. And the second case, another case, the bleedings during openings. In this case, more dangerous, more important things. I remove the bone by creation, and it's the bleedings from the ICA injury. In that case, ICA. I stop bleeding. I use 2 respirator. I try to stop with surgical, Martian, surgical Martian. First, I use cottonoid, and after that, I replace cottonoid by Martian, surgical Martian, and aponevrose. And in the end, I use a Foley balloon to compress. I have 3 cases like that. 1 case dying, 2 cases alive. And I do the GSA after surgery. That is so good. No pseudo aneurysm, especially is good. For the ICA injuries, I think we always prepare everything for ICA injury. We need to discuss with anesthetist, assistant, and we prepare aspiration and prepare to take the muscle. And sometimes, and after to stop bleeding temporarily, we need to do DSA after. Sometimes we need endovascular intervention. My lesson for the ICA injury is we need to have a good team, assistant anesthetist, and we have prepare muscle and multi-layer clothes and to DSA control after temporary stop bleeding. And the third lesson is how to remove the tumor. And in this picture, you can see the doctors use aspirate or curette to remove the tumor. But you see in the picture, the opening is not big enough. And we can see in this picture, you can remove the tumor by the curette, but the curette sometimes is dangerous because sometimes you can, during curette, you can remove the tumor, just sometimes it's brighter, it's dangerous. And that's why I don't like to remove the tumor by curette. I prefer to dissect the tumor, dissect around the tumor. In that case, we need to open big enough and don't pull the tumor. And in that case, it is soft tumor. It's easily to remove by aspiration. You can use aspiration. You can see the CSF leak. You can see the arachnoid. This is in the end of the surgery. And another case, it is epidermoid cyst, endoscopy, endonasal approach. When you open enough, you can go around the tumor, you can dissect, you can aspirate the tumor. Of course, it's a soft tumor, it's very easy. We can remove the tumor. It's no bleeding because it's epidermoid cyst. It is a very easy case. It is a very, very good choice for the young if we start to do, but it's not so frequent in this case. Another case, this is trigeminal neuroma. I do endoscopic endonasal approach. I do debooking inside the tumor, and I dissect around the tumor. And we need to repeat that big enough and opening enough is very important. You can dissect the tumor around. And the fourth lesson is how to close. There are many techniques to close. We can make a suture, we can use a balloon, we can use a multi-layer fat and bone graft and bioglue. And I prefer the technique with facilita and fat and balloon before I use bioglue, but it's very expensive. And now, from 5 years, I never use bioglue. Never use, expensive even in Vietnam. We can use aponephros and suricel, fat, 60 cell, and another player. Fat 60 cell, fat 60 cell. And another case, this is glyphosate in the end of the surgery. You can see the vertebral artery on the left side, right side, basilar artery. And now I close. I start to close with aponevrose. Aponevrose is very important in that case. I prepare the aponevrose big enough to start closing. This is very important technique. And multi-layer, fat, 3D cell, fat 3D cell, and mucosa flap, and in the end, Foley balloon. This is important technique to reduce the CSF leak. And another technique, this technique I learned from Japanese surgeon. I try to make some suture on durometer. For some first case, it takes a long time, but now I spend maybe 5-10 minutes to make some suture. It is important and it is effective to reduce the CSF leak. And when I make some suture like that, it is more effective for stop CSF leak. And for the last 85 cases with EETAs, I have only one CSF leak. It is very, very good techniques. And in that case, how we can treat, we can see the CSF leak. I always start with consecutive treatment with number puncture or number danglings. If it didn't work, I do reoperate with multi-layer. For conclusions, this is 5 big lessons I learned from my experience. We need to opening enough and prepare for ICA injury and dissect the tumor, good punch the tumor, and close with multi-layer and treat the CSF leak by consecutive treatment first and do reoperate if it didn't work. Thank you, everybody.
Okay.
Yeah.
So, Dr. Liu? Unmute, please. Dr. Liu, unmute, please.
I'm sorry. Thank you, Professor Dong. Hello, hello. Can you hear me?
Yes.
Yeah, yeah.
Okay. So sorry. Professor Dong, thank you for a very nice lecture. I would like to request Professor Hafiz, are you still here? We probably can take 1 or 2 questions before we move on to the next lecture. Is there any question from the audience? And also, yes, Professor Hari, you may ask your question, Professor. Please unmute yourself, Prof.
Yeah.
Yes, you may ask.
Thank you, Professor Hafiz, for your
I can't hear. Is everything all right with you?
For our country. Hello, can you hear me now?
Yes, now it's okay.
Yeah. Thank you. Thank you for your lecture, Professor.
Thank you very much.
Yeah, I would like to ask you a question. Like when there is a thoracic outlet syndrome and along with the cervical disc, so how to proceed in that setting?
Well, actually, I had to do both, and they were from 2 separate incisions. And surprisingly, she was much better after the operation, and she had a very bad thoracic outlet syndrome as well. So I had to do one, close up, and then do the other one.
Oh, so when you have both, is it best to do both of them?
Very rare. I did it only once. And that's out of many cases. That's, you know, after the 39 are the ones really well studied. But we've done a lot before. So we said we must do a series. So we did a prospective series.
Thank you. Thank you very much.
You're welcome.
Dr. Joe? Sam?
Hi, thank you, Prof. Kato. Professor Dong, I'm Sam from Malaysia, a young neurosurgeon. I would like to ask, how did you manage to stop the bleeding using muscle? Meaning, where did you get the muscle from during this kind of ICA injury? Thank you.
Yeah. I take the muscle from the first. I take from fasciolata, and after that I take the muscle from the leg. Yeah. Okay. I usually when I prepare for my operation, I usually prepare somewhere to take fat or muscle or aponevrose for closing. If I cannot see the CSF leak during surgery, or I cannot see, I don't have any injury, an artery injury, I don't need to, but I prepare everything before to start.
All right. Thank you. Thank
every
you.
case. Yeah.
Maybe I think Dr. Zoli, are you with us now? Hi, Zoli. Hi,
yes.
how are you? No, thank you very much. So maybe you can make some comment for Dr. Hay.
Well, I'm impressed with the amount of endonasal surgeries that you have done so far. And I agree upon a lot of things that you have said. But what was the amount, or at least at the beginning, how much did you use the image guidance? Because this is something that a lot of people do debate. I prefer up till now to do each and every case, whether fresh, whether redo, whether a lot of anatomical disruption. I do them all with image guidance. What do you think about that? Because of the safety.
I don't understand that. Can you repeat your question?
My question is, how often do you use image guidance while doing endonasal endoscopic surgery?
Endoscope for
image guide. Image
guidance, with image guidance.
Image guides. Now navigation, right?
Yes, yes.
I usually use navigation during surgery. I do every time.
Every time. I agree.
Every time. Yeah.
I agree very much with you. For the safety of the patient, it takes 5 or 10 minutes more, but it's definitely more safe. Thank you.
Thanks very much. Sorry. So maybe Dr. Lee.
Yeah, thank you very much for the discussion. We may move on to the Professor Shokumbi, who is with us now. Professor, are you online? Can you on your camera? He's a professor of anatomy, consultant neurological surgeon from the Department of Surgery, College of Medicine, University of Ibadan, campus of Queen Elizabeth from Nigeria. He's also one of the co-chair for today's session. We may hear some remarks from Professor, and also if Professor could give us a short introduction on the current neurosurgical services in Nigeria and the future. Professor, please.
So thank you very much for asking me to be part of this program. I think I'll just share my slide first. Okay. Right. So I hope you can I hope you can all see the slides on the screen.
Yes, yes.
Okay.
Okay.
So I'm delighted to make this presentation. My name is Temitayo Shokumbi. I've been working in Ibadan since 1987, approximately 36 years ago. And just to tell you briefly, the neurosurgical vista in Nigeria, which is reasonably typical of what you see in sub-Saharan Africa. For the purposes of context, Nigeria is on the west coast of Africa. It's above the Gulf of Guinea, has a very large population, 200 million people, and over a land mass of about 923,000 square kilometers. And in the southern part of the country, it's fairly densely populated, and the population density decreases as you go higher in the country. I work out of the University College Hospital, which was established in 1957, 5 years before neurosurgery started in Nigeria. And the commencement of neurosurgery in Nigeria is credited to the massive efforts of late Professor E. Latunde Odeku, who trained in Howard and at Ann Arbor, Michigan, under Edgar Kern, and who brought neurosurgery to Nigeria in 1962. At the time that Odeku came into Nigeria in 1962, the tradition of medicine in Nigeria and in most Anglophone West African countries is British. So he was a rare American-trained surgeon in the midst of majority British establishment. And there was a little bit of difficulty in getting going, but eventually succeeded. So he's rightly the pioneer for neurosurgery in Nigeria. But he was assisted by a number of other people. Professor Adeloye, who joined him 5 years later in Ibadan. Professor Lumide, who also joined him, all of them are of blessed memory. Shortly after Professor Odeku started neurosurgery in Ibadan, Professor Nasiru Ojikutu, helped by Dr. Colin Da Silva, started a program in Lagos. And in 1972, Professor S.C. Ohagulam set up the first neurosurgical center in southeastern Nigeria. There was also Professor Idrik Elams in Jos, and this was up to the early 80s. In the late 80s, Professor Aribabu joined the Lagos team, and I arrived in Nigeria in 1987 to join Professor Adeloye and Professor Lumide in working in Ibadan. So prior to 1992, most of the neurosurgery conducted in Nigeria was purely for service and research purposes. There were no dedicated trainees for the propagation of neurosurgery in Nigeria. There was no program. A few people went abroad to train, and the vast majority of them did not return. But following the establishment of the West African College of Surgeons in 1977 and the National Postgraduate Medical College of Nigeria shortly thereafter, the training of neurosurgeons began in earnest. Although a few people would still train overseas and come to Nigeria, but most of them actually hardly ever stay. And there are a few hybrid trainees combining training in Nigeria with training elsewhere. And as a result of these two major catalysts, that is the establishment of the two colleges, neurosurgical training actually took off. And to see on this table, it's responsible for the rise in numbers of neurosurgeons in Nigeria. From the solo Professor Odeku in 1962 to currently a number of about 140. Of these 140, about 135 of them have the fellowship of either the West African College of Surgeons or the Nigerian Postgraduate Medical College, or both. So despite this reasonably high number compared to the past, Nigeria's ratio of neurosurgeons to the population we serve is only closely approaching the African average. The North African neurosurgical community and the South African neurosurgical community are still a lot better than we are. And we're nowhere what you have in the Americas. Of all the 140 neurosurgeons that we have in Nigeria, 5 of them are females, and they're located in approximately 26 separate centers, 20 of which are public institutions funded by federal or state governments, and 16 of these training centers have university affiliation, but only 10 of them have met the requirements for certification and accreditation for training by either the West African College of Surgeons or the National Postgraduate Medical College. 6 of the centers where neurosurgery is practiced are privately funded. By the large numbers, the distribution of neurosurgeons is unsatisfactory. As you can see from this cartoon of Nigeria, the vast majority of the neurosurgeons we have in the country are located in the southern part of the country, especially clustered around the commercial capital of Nigeria, Lagos, and being more sparsely distributed through the north central and northwestern part of the country. Neurosurgery presence in the vast swath of the northeastern part of the country is almost silent. And that is one of the challenges that we have, that of spread and clustering. In Ibadan, where I work, there are 6 of us. I trained in Canada with Dr. Charles Drake and Dr. Sidney Peerless. Next to me is Professor Malomo, who was the first certified neurosurgeon trained in the West African College system. Following the completion of his training in Nigeria, he went to Glasgow to work with Graham Tisdale. And then we have Professor Adeolu, who also trained in Nigeria and spent a year in Calgary with Dr. Garnett. Amos Adeleye also trained in Ibadan and spent 2 years at Hadassah in Israel. James Balogun trained in Ibadan, spent time in Toronto and in Manchester. And Kemi Badejo is our most recent member and the first female in our program out of the 5 that we have in Nigeria. I think I want to especially acknowledge Professor S.C. Ohayagbalam, who established the first neurosurgical center in southeastern Nigeria in the public sector. He was a professor of neurosurgery at the University of Nigeria and Teaching Hospital, Enugu, and left the country briefly to work in the Middle East during Nigeria's period of economic downturn, but returned in the late 90s to establish a private neurosurgical center in Enugu, which actually carried on the task of providing neurosurgical services, even when the public hospitals were not functioning properly. In addition to providing this service, Professor Ohayagbalam also has his institution is accredited and recognized for training of neurosurgeons. I just feature a few of the other members in the major centers. Dr. Bankole is a fellow of the West African College. He is located at the Lagos University Teaching Hospital. All of us do general neurosurgery, but in addition to that, have special interests. Professor Bankole specializes in pediatric neurosurgery and does microscopic pituitary surgery. Part of his team includes Dr. Tayo Ojo, who does spine, vascular, and pituitary work. In the northern part of the country, a regional center was established by Dr. Bibi Shehu, who is currently the second vice president for Africa in the World Federation. Bibi Shehu was actually responsible for bringing neurosurgery to the north, and he's contributed substantially to the growth of neurosurgery in Nigeria. Professor Uche worked at the public hospital in Enugu at the University of Nigeria Teaching Hospital and has interest and practices in pediatrics, spine, vascular work, and endoscopy. In the north, in Kano, we've got Dr. Misbah, who is located at the Aminu Kano University Teaching Hospital, and in addition to general neurosurgery, does pituitary work. Working with Professor Bello in Sokoto at the Usman Dan Fodio University Teaching Hospital is Dr. N. Gingery, who has special interest in endoscopic spine work. And relatively new at the National Hospital, new in the sense that it's been there for about 15 years, at the National Hospital Abuja is a training program that is headed by Dr. Mahmoud Raji, who also doubles as the chief executive of the hospital. Despite the recent growth in neurosurgery in Nigeria, we've got some challenges. The most pressing challenge is that of the economy, which has actually oscillated substantially over the last few years and is currently in trouble, to be honest with you. Inflation is double digits. Inflation rate is double digits. Our unemployment rate is about 40%. The poverty rate is quite high. And there is a lot of other competing priorities that prevents the allocation of resources to health, not to talk of neurosurgery. And this is compounded by frequent work stoppages and labor unrest, generally providing an unsatisfactory job atmosphere that has encouraged young professionals, including neurosurgeons, some of whom we have trained in Nigeria, to actually emigrate out of the country. Currently, there are 5 of the 140 people that we trained have recently left Nigeria. And we really run a big risk of depleting human resource if the economy is not reversed. Well, there's hope for the future. We've just changed our government. There's a new administration in place, and we hope that every administration would like to endear itself to the public and to the population and would pay more attention to the health sector. Hopefully, neurosurgery would benefit from that. One of the problems with poor public health spending, particularly combined with absence of wide coverage of health insurance, is that most patients have to do spending for healthcare out of pocket. And this actually reduces the number of patients who are able to benefit from care at the tertiary level. What that also means is that the number of patients that are available for training would be reduced, and that will have an impact on skill acquisition. The future requires that both in the public and the private sector, that there will be greater investments in the existing facilities with consolidation of facilities that have lasted, with public-private partnership in a mutually beneficial way. I think the future will see regionalization of neurosurgical practice at tertiary level so that the limited resources can be concentrated in a few centers who can therefore, where many more patients can be seen, greater opportunities will be available for training, data will be available for research and publishing, and we would then have an opportunity to strengthen and expand subspecialties. We would not be able to do this without international collaboration. One of the reasons I'm particularly delighted to be on this program. We'll be quite excited to collaborate with people to help us strengthen our program. There's a lot that we can learn from others, but there's also a lot that others can learn from us. Neurosurgery is organized in Nigeria. There's the Nigerian Academy of Neurological Surgeons, which is a derivative of the surgical section of the Nigerian Society of Neurological Sciences. It was established in 2006 by late Professor Adeloye, and its pioneer president was Professor Aribabu, who recently retired from the Lagos University Teaching Hospital. The goal of our academy is to foster the neurological health of Nigerians in particular and humanity in general through the advancement of all aspects of neurological surgery. And we do that largely through annual scientific conferences to bring neurosurgeons from different parts of the country together to exchange ideas and to collaborate. Our current president is Professor J.K. Emejulu, a very dynamic neurosurgeon based at Nnewi in Enugu in Nigeria. The recent conference took place in 2022, the first post-COVID physical conference in 2022. There's a picture from that meeting. And you can see from this picture that the vast majority of neurosurgeons in the picture are young people, which is really a cause for hope for the future of the profession in the country. Our next meeting takes place in Kano. The theme of that meeting is public-private partnership as a potential catalyst for the growth of neurosurgery in Nigeria. conference takes place 20th and 21st of, between 22nd and 23rd of November this year. Kano is a great place. It's probably the most densely populated part of the north. It's a cultural and trade hub. It's the commercial center for northern Nigeria. And it's a cosmopolitan area, famous for its Durbar Carnival, which is shown in this picture. And we'll be delighted to invite you and to have you join us and to see what we do and for us to learn from your experience. Thank you very much.
Thank you, Shakombi.
Is there any question for Professor Shakombi?
So
If not,
just Shakombi, maybe we can restart the collaboration and continue to support your country in education. Thank you very much.
That would be most welcome. Thank you.
Yes.
Thank you, Professor, for great information regarding neurosurgery in Nigeria. We shall move on now to the next lecture by Professor Ahmad Zodi. He's a Professor Emeritus of Neurosurgery, Honorary President of ACNS, and former Vice Dean of Postgraduate Study and Research of Carl El Aini School of Medicine, Cairo University, Egypt. And Professor will be talking on mainstreamization of endoscopic procedure into neurosurgical practice. May I call upon Professor Ahmad Zodi? Professor?
Yes, very good morning, good afternoon, whatever, wherever you are. Yoko, thank you for inviting me to share with you my experience throughout the past 3 decades using the endoscope, at times to the utmost, and now carefully selecting the cases and merging endoscopy with microneurosurgery. Well, let me share my screen. Is my screen shared?
Yes.
Yes.
Yes, sorry.
Just remove all these bars that are. Okay. This is where I come from, Cairo University Medical School, Qasr Al Aini Medical School. It's mounting to about 150 years now, or in a couple of years, in 2 or 3 years from now. And this is the dome of the Dean's office. These hospitals were built back in 1932, and these are the new hospitals, even with the fisheye effect, and they were built about 30 years ago. Talking about our subject now, current intraventricular neuroendoscopic procedures are actually a versatile technique. What you can do is all known to us: the fenestration, the restoration, the excision, biopsy, endoscopic shunt procedures, and others, especially now the endonasal procedures. Integrating endoscopic techniques into the standards of neurosurgery is a major subset of minimal invasive neurosurgery. Very important to know about the neuroendoscopy, and I guess most of you do know that, it has a very steep learning curve, and without the morbid anatomy and the total command of it, you are lost. So endoscopic anatomy of the cerebral ventricles is a morbid anatomy, is a mixture of displayed, outstretched, and dysplastic abnormalities. Well, it is not as many advocate that endoscopic surgery is a 2D X and Y dimensions. No, it is, you acquire the third D through a tedious learning curve, through illumination intensity and the shades. And you even go a step further, the fourth D that you achieve with the motion parallax and the different telescope angles and changing the telescopes, achieving different views. And even still a fifth D And that is how do you get this 50 is from the degree or the severity of the hydrocephalic changes and even the chronicity with the level. And I will be showing you why and how can you use this 50 while doing your surgery. Now, the visual and range of your lens mandates a good anatomical knowledge because you don't see behind your back. So you have to anticipate and be very careful. Expertise, armamentarium, and methodologies are ongoing, will optimize your understanding to this kind of extremely variable surgical anatomy. The better we see, the more we know, the more we know, the more we see. Now look at all, these are very important views. This is the foramen of Monroe, which is the key corridor or passage to most of your procedures inside the ventricle. This is your target area, which you do most of your procedures, mainly ATV. And this is, again, very important, the Liliequist membrane and the anatomical variations in the Liliequist membranes and where it can take you to, and when to stop and when to continue. Mainstreamization of endoscopic procedures into neurosurgical practice is a real paradigm shift. Endoscopy in intraventricular lesions mandates the tedious learning curve, the total command of morbid anatomy. Your only concern or main concern during endoscopic procedures are the tools, namely the bipolar forceps and being able to work with both hands and use sort of endoscopically tailored instruments. And of course, having a holding system apart from a trained assistant. The port technique, the cylindrical one that you can use, transparent conduit. And remember always, it is a straight trajectory. Bimanual dissection is a dream. And hemostasis has all its variations, mainly the profuse irrigation is number one, the balloon pressure, and the small chamber irrigation technique, and even if you have to empty the whole ventricle and use the dry feed technique. Of course, selection of cases is very important. The size in and around 2 centimeters, preferably always with hydrocephalic changes, and the consistency is important. Better soft, and if solid, better not vascular. Main anatomical considerations, the potential midline cavities, because they help you and they guide you what you can do, what you cannot do. Now, the cavum septum pellucidum and the cavum septum virgin and the cavum velum interpositum are the 3 main potential midline cavities that you can use during your surgeries, and explains actually a lot of the morbid anatomy and the extent of the tumor expansion or the cyst expansion, where it can go into where and what it will cause. And I will show you all that. One of our recent published papers is the EMF, the endoscopic Monroe foraminoplasty, through restoration, through excision, through dilatation. And apart from that, you can see in the upward picture the normal anatomy of the foramen of Monroe. Of course, a little bit dilated than normal, but nevertheless, with all the veins, subepidermal veins, or the choroid plexus, and the fornix, and the structures within. Now, mind you, we've set a relative operative safety zones. Far from what all surgeons do believe, this is the safest area, in and around or above or within the choroid plexus, because this one is not safe. It's intimately related to the thalamus and to the thalamus striate vein, very painful aftermath and sickly if you do injure it. And then we have the sort of intermediate risk, because here we have a single forniceal lesion. And then this one is the most serious part, because here you will have the body of the fornix affected, and you lose both vortices. Standalone procedure, endoscopy, or the pendulum taking you to endoscope assisted, endoscope controlled, microneurosurgery, or even you can sort of convert back to microsurgery. It's a pendulum that you have to outweigh, and whether to stick to the stale incisors or you start innovating, and according to the level of expertise that you have reached. The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So persevere, hope for the best, yet don't be too stubborn, convert, and plan for the worst. Now, this is my mentor. I learned from him a lot, late Professor Dunetsky, and he had always the concept of tailoring for each and every lesion its own approach. So this is a right foramen of Monroe approach, as he showed in his publication or in a book, 1993, for the operative procedures and how to tail each and every approach. And he considered the Kocher burr hole one of the major burr holes that I'm going to show to you now. And the variables affecting the strategy when you use the Kocher burr hole, and you can consider it your keyhole, whether you're doing endoscopic surgery alone, endoscopic assisted, by manual, the port of entry and the corridor and your trajectory that you have planned is according to your Kocher burr hole, always able to modify. So you aim always at radicality, yet putting the safety of the patient first. It's a minimal invasive concept, yet a tailored approach. Now take this as an example of the 5th D. This is the inclination with the lateral side, with the medial side of with the lateral side of the foramen of Monroe higher up than the medial side, because the third ventricle is not too much wider, not too much ballooned. This is what happens when you have a long-lasting hydrocephalic changes and ballooned third ventricle. You get a reverse of the inclination with the medial side, with the lateral side now lower down and the medial side higher up. This is why we insist always when we do an ETV, you can never predict this inclination. You see it as you go in. So this is why you should not fix the head while doing an ETV, to be able to reverse the inclination accordingly by tilting the head to the lateral side or contralateral side and keeping the foramen of Monroe horizontal or parallel to the floor, of your surgery, of your OR. And these are the options that you might improve or even do a better or a wider procedure or approach by doing a mini craniotomy, inch-sized, either anteriorly, you're still safe, posteriorly, you're still safe, 1 inch, and even have your burr hole in the middle. And these are all decided after doing your Kocher burr hole and after going into the ventricle and seeing how far you would like to go, anterior, posterior, or stay in the middle. An example, I mean, these are interesting video films to show you what kind of tumors, what they do intraventricularly. This type of tumor was arising from the lateral wall of the lateral ventricle and had a pedicle and sort of built a hole and socket valve to the foramen of Monroe, and hence caused these hydrocephalic changes, mainly asymmetrical. And while doing it endoscopically solely, it took a lot of time. So I turned into, or I shifted to microsurgery and shaved the tumor from the lateral wall of the lateral ventricle, and then used the endoscope again and went in to see. And this is how you merge and you integrate both together and use all your armamentarium. And you go in and you find a sort of ulcer in and around the floor, which changed actually your adjuvant therapy thereafter. This was a young boy, 10 years old, and astrocytoma grade 3 was the pathological, but yet with seeding or whatever, an ulcer, and he had to take adjuvant therapy. This is just a velum interpositum cyst and how you can deal with it, and just go with the endoscope solidly and sort of marsupialize it and do ventricular cystostomy, and the job is done. And always you can use this Kocher-Burr hole to widen or reach furtherly anterior or posterior structures that you need to deal with. This is another example of what you do. You go in, you do your job, and your job was here to aspirate the cyst content and take a biopsy. And this is an actual 10 years follow-up of this case, and how just a minimal usage of your armamentarium, your endoscope, and then using the adjuvant therapy. And this is your results. Another option for this case, this is a velum interpositum cyst again, and how to deal with it. And we've already discussed that, so we can move on. Neuroendoscopic surgery for colloid cysts. Now, these are the options that you can use. You do foraminoplasty, of course, by excising the cyst, and you do entailed with this excision. You, of course, will take a biopsy, and you do thereafter an ETV. I insist on that. Others do not, but I always do an ETV if doable after excising the colloid cyst. Our prime purpose in this life is to help others, and if you cannot help them, at least do not hurt them. Origin and extension of the colloid cyst. We go back now to the slide that I've shown you before. This is one type of extension downwards and filling up the anterior part of the third ventricle. Another one is an upward extension of the colloid cyst into the cavum septum pellucidum, and this is called the tucked up colloid cyst. And this close that I will show you now, the variations and understanding the anatomy and the possible extension and expansion of these lesions and what they cause. These are the options, again, going downwards, going upwards and downwards, transgressing even into the lateral ventricle. So the site and the size and the contents and the capsule and the ventricle all affect your strategy and affect the way that you have to deal with all these different kinds, as I'm showing you here, a tucked up, a solidly third ventricular, a transgressing. The site of the colloid cyst, as mentioned. Now, this one is a tucked up, totally blocking the foramen of Monroe. Okay, and here is another small one, not sizable, but in a, again, ball and valve, but from within, ball and socket, but from within technique. It's a valvular mechanism that causes extreme hydrocephalus. Okay, yet the size is quite variable, and you can find more or less 1 to 2 centimeters. I mean, this is a 1.5. This is less than 1 centimeter. Yet both have hydrocephalic changes. Now this one is around 1 centimeter and practically no. And again, this one. So actually, I could not find a real relationship between the size, the site, and the ventriculomegaly. And this is why I always insist on going first through a Kocher-Burr hole, seeing with your own eyes where we stand, what will we do? Will it suffice to do with the endoscope, or will you have to move to the microsurgery? The Kocher-Burr hole is rightly so a key Burr hole for all the maneuvers and the endoscopic procedures or endoscope assisted procedures within the ventricle. Endoscopic maneuvers while dealing with a colloid cyst. I mean, there is a film here that we can show when you're talking very quickly. What you can do, actually use your balloon catheter, even push it behind the colloid cyst and squeeze out the contents if they are not easily suckable, and you remove them by suction thereafter. Here you push the Fogarty catheter and you start ballooning it, and once it balloons, it sort of squeezes out the contents. And once you're in and you're capable of doing an ETV with a stretched, of course, and not a parapet floor of the third ventricle, you can safely do your ETV and have a good night's sleep. And of course, the patient will be safe from any hydrocephalic changes, because it's not the residue you should dread, but it is the spillage that happens during the surgery of the irritant fluid contents, and the fluid or the contents of the cyst into the aqueduct and causing acute hydrocephalus, and you lose the patient overnight. Being within the minimal invasive neurosurgical subset, this is another example how you deal with it. You go in with a single burr hole, cochlear burr hole, you have a look at the actual condition of your colloid cyst, and you decide, well, this is not doable with the endoscope alone, so you do your mini craniotomy, just 1 inch or less, and this is after removing, and you put an EVD, and this is a 3D to show you the small mini craniotomy that was done, and this is a 1 week post-operative and a later MRI showing the complete excision of the mass. A capilloma and how you can solidly deal with it endoscopically and remove it piecemeal, and using your balloon catheter also to for tamponade and your ball electrode, and you can actually do your job only with the endoscope, solely a standalone endoscopic procedure, and this is what you achieve. You did a foraminoplasty, and the tumor is excised, and the hydrocephalic changes more or less restored. Another type of capilloma that you might be facing, which is lower down, as you can see here, and here, of course, you're not advised to do anything but an ETV and go for adjuvant therapy thereafter. And the patient is okay, in a good condition with your correct decision. A lot of other films, because of the time, we can't go through them all. The triventricular hydrocephalus, pioneer surgery, and I prefer always just to do a fluid biopsy or and an ETV, and then go and do an interhemispheric tailored approach supratentorial through the you go through the tent and as much as you want, and you remove the tumor totally in a tailored fashioned approach for each and every case accordingly, and the trajectory and the corridor are being chosen according to the inclination of the tumor, anterior extension, posterior extension. Biventricular hydrocephalus like this one, you go in through your cochlear burr hole, and you find that what you're dealing with is a choroid cyst that can be excised and the problem solved. Other things are like this one. This is an aftermath of posterior fossa tumor excision with spillage, a lot of blood spillage, and proximal intracisternar obstructive hydrocephalus as a sickly. And you do for both of them an ETV. If we had time, I could have shown you all the films, but unfortunately, I just move on. Management of fourth ventricular tumors. We do each and every case we leave an EBD, tumor removal, intracranial pressure monitoring through the EVD. If you need to do an ETV, you do it, and BP if ETV fails. Craniopharyngiomas from Indonesian approach, this is how you deal with it, with image guidance, and you go in and you remove the tumor, you call the craniopharyngioma, and you get good results. At the end of the day, it is a set of mind, set of skill, and set of tools. Take home message, prepare yourself for a tedious learning curve, focus on command of morbid anatomy and anticipate anatomical variations, expect limitations, do's and don'ts, doable or not, convey and share valuable knowledge. Patient safety comes first. Thank you very much.
Thank you, Professor Ahmad Zodi, for a very nice lecture on endoscopy in neurosurgery. Now we open for questions. You may ask just ask your question either by the chat box or online.
Maybe Sam.
Thank you, Prof. Ahmad Zodi. That was a beautiful lecture. I'm a young neurosurgeon from Malaysia. I would like to ask about any tips on how you stop bleeding, because I think endoscopic removal of tumors, I think one of the most dangerous things is IVH and then leading to hydrocephalus, infection, and so on and so forth. And how do you stop major bleeding, which you cannot stop endoscopy?
Well, you start first by profuse irrigation, and I mean profuse, tens of liters, as much as you need. And if it's still not functioning, of course, while doing your irrigation, you try to do some kind of balloon tamponade. You inflate your balloon and come near to the bleeding point, and you just press on it, and it solves the problem. Well, if it still continues, you can use this technique devised by Manwaring and Damati, who's a colleague at Heidelberg now. This is the small chamber irrigation technique. And the small chamber irrigation technique is a sort of chamber that you create by pushing backwards your telescope and having the area that is bleeding in focus, and it will not blind you. You'll be able to pinpoint it and coagulate. And if still you have a problem, you go back to your microscope and you just empty the ventricle, and you'll be amazed. It's just a very small bleeder that is causing all this trouble. And you finish it and you go refill the ventricle again and continue your endoscopic procedure.
Right, thank you, Prof.
We have a question from our attendees, Dr. Monira. Dr. Monira, you can unmute yourself and ask the question. Can you hear us, Dr. Monira? You can unmute and ask question now. Hello? No, I think she couldn't. Any other question from our panelists?
No. Do you hear us? Hi, how are you?
I'm good. Thank you, Professor.
Yes.
Yeah, thank you, Professor Zodi, for this interesting lecture, as usual. Would you like to comment on the use of endoscope in the craniopharyngioma cases? Any input in this?
Well, it is also, again, a very, very tedious learning curve. And dealing endonasally with all these, I mean, now the extended or the expanded endonasal approaches, you have to be very well trained, and you have to anticipate a lot of complications. It's always better to have a more fluidity part than being all solid, to be able to dissect from below upwards. And again, you have to know your limits because you cannot pull. This is a major disadvantage. You cannot do endonasal surgery and start pulling the tumor out or the cyst out. You have to deliver it. And hence, I used to do a lot of things. Growing older and wiser, I always like to use the pendulum. And I'm always towards the safety of the patient. And if it cannot be totally removed without any complications, then I leave it as such and go for another transcranial. So put in mind always to have a contingency plan and not be dogmatic.
Thank you. Thank you. I was mostly asking about also endoscopic, microscopic assisted transcranial craniopharyngioma excision, like the use of endoscope and
the use of endoscope will aid in seeing some leftovers, hidden corners, and I always advise to do that. I mean, it is by far more safer than going from having been through both ordeals. I would prefer both transcranial with the endoscopic assisted.
Yeah, thank you so much. Thank you for the lecture.
Thank you for the question, Dr. Heba. And thank you, Professor Ahmad Zodi, for a very nice lecture. If you still stay online, sometimes questions may come up in the chat box. I would request all the speakers to look at the chat box and answer the question according to your lecture. Thank you, Professor. So it gives me a great honor to introduce our next speaker, Professor Ahmad Samad El-Hobi, Professor and Chairman of Neurosurgical Department, Hospital of Specialized Ibn Sina University Medical Center, Rabat, Director and Resident Training Program in Neurosurgery, Faculty of Medicine and Pharmacy, Muhammad V University, Rabat, Morocco. And a professor will be talking to us on towards the collaboration integrated model of education and training in neurosurgery in low and middle income countries. Professor, the floor is yours.
Thank you very much, Dr. Yu. Hi, Professor Kato. Thank you for the invitation.
How are you?
Yeah, thank you. I will go for my my slides. Do you have my slides?
Yes.
Yes, Prof.
Okay, thank you. So thank you once again for the invitation. I will speak during my presentation on the education and training in low and middle incomes country. I am Abdel Samad Wahabi from Rabat Neurosurgical Department, Ibn Sina Hospital. And I have been working with other colleagues on the education for last two decades. And we can see that despite the many efforts that has been done by many individuals, many institutions to improve the situation of neurosurgery in the world, and particularly in the middle and incomes country, inequity in neurosurgery is still striking. And you can see that worldwide, there are 5 million essential neurosurgical cases go untreated each year in these countries. And we need more than 23,000 additional neurosurgeons to meet the current demand. These needs are greatest in low and middle incomes country, and particularly are in sub-Sahara Africa, Southeast Asia, and Latin America. These countries, in addition to this problem of number of neurosurgeons, are facing many challenges. First of this is they need to train sufficient number of neurosurgeons in a very short time to reduce the gap in neurosurgeon to population ratio. And for example, in sub-Saharan Africa, we need more than 1,400 to 1,500 additional neurosurgeon by the year or 2030. The second challenge that face this population, these countries, are the continuous and rapid population growth. And for example, in 2030, African population will reach 1.4 billion people, with 1.1 billion in sub-Saharan Africa. And there is an explosion of young population in low and middle income countries. The third challenges is the neurosurgical spectrum in these countries is changing, and mainly due to the industrialization, to the adoption of Western life, the population, the improvement of life standard. And now we are dealing with new pathologies that 20 years ago were not very common, but now the incidence of major surgical conditions are higher in low middle income countries than in high income countries. For example, for traumatic brain injury, pediatric hydrocephalus, epilepsy, C. infection, subarachnoid hemorrhage, and we are facing more and more cases of aneurysm. So the challenge for these countries in the low and middle income country, not only to train basic neurosurgeon, but they need also to train in parallel specialized neurosurgeon in this different pathology to meet their needs. So how can we bridge the gap in this problem of education and training between high income country and low and middle income country? It is clear that only through education and training, the gap of neurosurgeon to population ratio in this country can be reduced or even completely closed. How can we go through this education? There are many type of education, and you can see here that we review the literature the last 2 decades to see what kind of education protocol and model are available. And we can see here that there are 3 main educational models that are being used for the last 2 decades. The first one is the national residency training in some low and middle income countries. Then the full residency training in high income countries. The residency training program in WFNS training centers in regional low and middle income countries. Of course, there are also some short-term visits with boot camps, missions. Online education has been very useful, especially in the period of COVID, and of course, fellowships or observations from young neurosurgeon coming from low income country and going to high and income country. So all this model exists and has been very efficacious during the last 2 decades. But still, to be sure that this model of education are efficacious, you have to evaluate them. And this evaluation is based on 4 items. First, role training. The second is sustainability. The third one is the cost. And of course, the last one of effectiveness. Because the goal of this model of training is to develop an independent and self-sustaining neurosurgical education program and practice locally in these countries. And this is very important to achieve if we want to reduce the gap between high income countries and low income middle income countries related to the number of neurosurgeons and the standard of neurosurgery. Let's go through all this different model. And we start with this first model that trained young neurosurgeon coming from low and middle income country in centers of high income countries. There are many advantages of training this young neurosurgeon there. First one is they have been trained in high volume neurosurgical center with high standards of neurosurgery, of course. They will exposed to new techniques and advanced technology. They will see and may be pre-trained in neurosurgical subspecialties. But there are some disadvantages of this model. The most important is for me, and for also it was being seen in the literature, is the problem of brain drain phenomena. The second is that these might be inappropriate training because they will be trained in very sophisticated department. And when they go home, they will have problem to see and to apply what they have learned. There is also different neurosurgical spectrum from home countries. And training in these high-income countries will be focused on advanced technique and technology they will never find when they go home. So there is also some challenges facing the neurosurgeon when they are back home. Shortage of resources, and all know that the problem of resources is worldwide, mainly in these countries, higher work load and inappropriate environment. So most of these colleagues that has been trained in high-income country just stay there and never come back because they can't go to the new environment that for them is very different from those who has been trained. And also there is a considerable loss of investment. And we have reviewed the literature that has many publications that have shown us the shortcoming of this model. And you can see in these different papers how the authors point out this problem of a problem of migration, a problem of financial cost. So this model has many shortcomings. The second model of training is the short mission, the boot camp. This is the most common model of international neurosurgical collaboration the last 15 years. Many institutions has been, foundation also has been involved. FNS, END, WHO, WFNS, ENS, and these, we have to recognize this is a big and tremendous effort that has been made, and this has been to be recognized and to be appreciated because a lot of colleagues has been participating in this model of training. There are organized like a short-term visit, 1-2 weeks, repeated 2-3 times a year, and with the participation in healthcare assistance, surgical training, boot camps, clinical research assistance. There are many advantages, of course, of this model of training. This mission provides service to patients and education to local neurosurgeons and nurses. There is an increased awareness of global burden of neurosurgery diseases, enhanced international collaboration, and this is a very gratifying activity, especially for the colleagues who come from high-income countries to assess the one who are in low and in middle-income countries. But still, there are some limitation and drawback of this model. There is no significant transfer of knowledge, no long-term sustainability, and it has been mentioned by many colleagues that has been trained by this model. There is also higher pressure on local faculty. When the group of colleagues just leave, there is a lot of patients waiting for the mission, and the mission has just finished, and they go to the hospital, they don't find the colleagues from high-income country. So there is a problem for the local neurosurgeon. There are some ethical challenges that has been also pointed out by some authors. And the question is, this model, there is a risk that this model go for a long-term assistance and has been interpreted by some African colleagues like new colonization. Also, this is very important, the cost effectiveness. If you can see here, for example, over 250 million US year for limited numbers of surgeries. And this is has been reported in neurosurgical focus. So it's costly, and there is no significant transfer of knowledge with the problem of sustainability. Now, training neurosurgeons and regional WFNS centers in this, there are many advantages. This program provides 5-year full training program in basic neurosurgery, but also in some subspecialties. There is a high retention rate. That means that all who has been trained in this regional WFNS center, just when they finish, they go back home, and nobody stay in, for example, Morocco, in Algeria, or in other centers. This is a very cost-effective model, and this costs just for 5-year training. For example, in WFNS Rabat Training Center, where I am working, $30,000 for 5 years. They could also have help from scholarship from WFNS Foundation for some institution for their home countries. And this is very important because that they have reduced the gap in neurosurgeon to population ratio when we compare the data before establishing this program and currently. And this model can be duplicatable. It's easy to have it established in another country. There are also some limitations. There's insufficient number of WFNS reference centers, just 4 in Africa, none in Asia. Limited number of scholarship. We have to help this young neurosurgeon for scholarship. And there's also some lack of collaboration and information sharing between centers, and lack of organization of training program between centers. There are some has been trained from French-speaking countries, the other from English-speaking countries. There are some difference in program, but in general, the result is very good, and this is a very good cost-effective model for training. And this is just an example of the WFNS Rabat Center. In 20 years, we just celebrate last year the 20th anniversary, and you can see here that in 20 years they have been more than 80 residents from Sub-Saharan Africa. They have been enrolled in this training centers from 21 countries. This is a very, very good results. And this is the reduction of the number of, the gap between 1998, where the number of neurosurgeon per population ratio was 1 per 8 million, and 2016 the ratio is 1 to 2 million. That's a very good improvement in the number, but still you have a lot to do in this situation. There is also other model of education, mainly the online education that has been very efficacious. Lastly, there are many advantages. The low-cost, widespread neurosurgical education, online education can be integrated in a standard curriculum, promotes the dissemination of knowledge in low and middle-income countries. There are some disadvantages. Of course, there is limited interaction between participants. There are mainly student engagement, maintaining student engagement in these webinars is sometimes difficult, but can never replace standard neurosurgical education. And of course, it has been widely used during the COVID-19 pandemic, so it was very efficacious. Many committees and neurosurgical societies webinars have been reinforced during this to replace the traditional mode of teaching during the period, and you can see there some continue now, like the webinar we are doing today, and it's very important to continue in parallel with the traditional education and training system. The neurosurgical simulation is a good way to educate and train young neurosurgeons, but we need some means. We have some center for simulation. It's very important that that we develop in low and middle income country, but simulation and web-based education model, didactic lectures alone will never replace the opportunity experience and guidance by a seasoned surgeon. So still, these are just something adjuvant to basic training and learning from directly from a teacher. So how can we go to move forward and to improve the situation? We have been analyzing different model of training. Each of this model has its own advantage, its own drawbacks. Can we group all this model in a collaborative one that might be very efficacious? Because even when applying this different model separately, we found that the evolution, the progress, and the situation of neurosurgery in low and middle income country is not so good. And speed of producing neurosurgeon and training neurosurgeon is really not very fast. And this is because there are some difference in these models. So you have to go for a model that may group all these possibilities. We know that the inequity of neurosurgery in the world is still striking, due mainly to the lack of cohesive global strategy in education and training in low and middle income countries. Global neurosurgery continues to face tremendous challenges no single individual, organization, or university is able to solve. This is a global problem that requires global solution and global strategy. Global strategy requires international multi-institutional collaboration to make all efforts to converge on the same goal. And this is why we need to develop a cohesive and integrative global strategy is essential to speed up the process of closing the gap in neurosurgery and low and middle income country. And in this program, we have to separate two things: the continuous medical education and the basic training. The continuous medical education should be reinforced in parallel to the basic education for neurosurgeon, and all the efforts have to be combined to converge on the same target. And this is what we propose as a model of education that on globe and collaborate with other institutions. If we have countries with no residency training program, we know that now there are 12 countries worldwide, 7 in Africa, 4 East Asia, 1 Latin America, have no single neurosurgeon. The priority in this situation is to train neurosurgeon in essential and basic neurosurgery in WFNS accredited centers, and not send them for 5-6 years abroad. They should not come at home. But of course, this program needs the financial support either by scholarship coming from WFNS Foundation, from local hospital support, other institution. And it's very important to invest to ask high incomes country to invest to strengthen health system in low and middle incomes country to avoid the brain drain. In countries with already local residency training program, we have to encourage the recruitment of young neurosurgeons from the medical school to increase numbers of positions for training in basic neurosurgery, and to set up additional local training centers in the country. Now in Sub-Sahara, there are more than 16 countries that have already their own training program, which is excellent. And in that situation, we can develop in these countries with already their training program, neurosurgical specialties and cost-effective techniques. Why we are asking for that? Because there are many young neurosurgeons that are asking for subspecialties. And in this program, you have to reinforce formal training in standard neurosurgery. This is to increase the number of neurosurgeons in low and middle income country, and development of cost-effective technique in these countries, like stereotaxy, TV for hydrocephalus, anterior lobectomy for epilepsy, wake surgery for glioma, many invasive technique, very important. And these subspecialties can be developed by the aid of short surgical mission in low and middle country and boot camps, and of course online education. The development of a specialty, for example, like pediatric neurosurgery, neuro-oncology, vascular neurosurgery, also we can, in this situation, have young neurosurgeon for fellowship in high income country for 1-2 years. Then when they come back, they can be followed by boot camps for implementation in low and middle income with their teacher from high income country. This is the only way to develop subspecialties in these low and middle income countries. So this is the form of the model we propose And these, of course, need some financial support, either for developing a new training program and locally, or for developing subspecialties. And we are asked all the actors to participate in this collaborative program. And this has been, we published this in recently in a journal showing how we can move forward to improve the situation in this neurosurgery in low and middle income countries. So in conclusion, training neurosurgeon from low and middle income country in local and WFNS reference centers is very cost-effective solution to close the gap in neurosurgeon to population ratio. But surgical camps are essential to improve care, develop skills, and to introduce new techniques or technology in these countries. Development of neurosurgical subspecialties in low and middle income country is best achieved through short-term fellowship in high-income country, followed by surgical camps in this country for implementation. Online education is still valid support, but can never replace traditional neurosurgical learning. And very important thing is that the international coordination and cooperation between WFNS, continental, regional neurosurgery association is very important to for this model of training. Thank you very much.
Thank you.
Thank you, Professor. Is there any question from the floor? Any question?
Others,
Yeah.
Yeah, Professor Dishot. Yeah, please.
Thank you so much, Professor, for interesting presentation. Actually, this is a very demanded and actual subject of our nowadays neurosurgery, especially for the low and middle income countries. Like confessing that fact that I'm also from one of these countries. I'm also interested. Actually, I'm from Uzbekistan. My interest is about that. You have mentioned about long-term fellowship programs, long-term training programs for young neurosurgeons, especially for African or sub-Saharan regions. In WFNS provided fellowships or training programs. Is that programs only for African countries, or that can apply for other low and middle income countries also?
It's a very, very good question. So far, this is reserved for African countries, for sub-Saharan African countries. The idea was first is to start in the WFNS to create one center, regional center in Africa, and then thinking to do the same in Asia or Latin America. This is the idea. And I think Professor Kato can maybe try to go this way, because it's very important. But it's not exclusive. I mean, it's not, this is something that we can accept a colleague coming in this program for outside Africa. There is no problem there. But initially, the idea was to train in the regional area this young neurosurgeon coming from Africa. But we can accept you. There is no problem.
Thank you so much.
Thank you, Professor Dishot. Is there any other question? If no, I would like to express our sincere appreciation to Professor Abdul Samad for very extensive discussion and lecture on how to improve education, especially in neurosurgery in a low and middle income country. Thank you, Professor. And we shall move on to the next. I also would like to remind the speaker, if there's question for you in the Q&A, kindly please answer the question in the Q&A box. Next, I would like to call upon Professor Andreas Rabe, Chairman and Professor of Neurosurgery at the Inselspital University of Bern, Switzerland, and he'll be talking on challenges of management of patients with unruptured aneurysm. Professor Andreas.
Hello. Can you see my slide?
Yes.
Yes, Prof.
Thank you. So it's a great pleasure to be invited and to present here. And I'm going to talk about the changes in the management of patients with unruptured aneurysms, coming from some new findings, but also evolving over time in the Western countries. So the prevalence of unruptured intracranial aneurysms, if we look at MRI findings of screenings of patients with other diseases, it ranges between 2 and 3% of all the investigations, of course, also depending on the age of the patient, and a higher prevalence in older patients. What we want to prevent is basically not the rupture. Of course, we want to prevent the rupture, but that's not the main question, because preventing a rupture also involves treatment, and treatment has a risk. So basically, it's better to say we want to prevent the risk of poor outcome, because sometimes the treatment is very invasive, sometimes the rupture rate is low. So the risk of poor outcome, that's what we are addressing, and not the rupture of the aneurysm. And the risk of poor outcome basically can also be transferred in quality adjusted life years. So how many years of good quality of life can we save for the patient if we either do nothing or treat the aneurysm? There are 3 factors, basically, if we break it down into the main components. One is, of course, the risk of rupture. The other question, of course, is the remaining life in good quality. So if a patient's 84 years old, multiple metastasis, so the risk of rupture may be high, but the remaining life with good quality is also very low. And the third factor is the risk of treatment, of course. And this is different from the risk of observation, because over time in observation, the risk is adding and slowly increasing, while in surgical or endovascular treatment, the risk is immediately there and immediately present after surgery, or maybe in the first 30 days by definition. So why the risk of rupture? We are not talking about the big one, with those who are larger than 7 or 10 millimeters, and everything that is beyond 1% per year is regarded to really fulfill the indications for treatment. The most difficult decision is because they are the most often in the MRI and the most often incidentally found are the aneurysms between 7 and 10 millimeters. It's a little bit depending on what definition we use, but we are more reluctant and more unsecure, uncertain when we are talking about aneurysms with size of less than 7 millimeters. Before ISUIA, which was the largest study, prospective study on the treatment and the rupture risk of aneurysm, before ISUIA, we all thought it's about 1% per year for all the aneurysms. And this is because we saw that all or most of the ruptured aneurysms were small ones. So we didn't think there was a difference between the small and the big aneurysms. But the ISUIA, the prospective study, surprisingly showed us a very low risk of rupture for the small unruptured ones. And probably this is because they have a different timeline of development, and probably they are rupturing within a few weeks. So what we can observe on MRI findings are basically the one who stabilize. So this is one of the explanations, but I cannot talk more about this because of the time constraints. Of course, after ISUIA, a lot of studies were performed because we were not happy with this number of 0%, which is not true, because this was also fitting of data after you see the data. They didn't specify all the categories of size, of location, and so on. So a lot of studies were done, but most of them in Japan and in Finland, which might have a different behavior of these aneurysms. Many meta-analyses were done and scores were developed, and we are ending up with a huge spread of rupture risk between 0.1 and 1% per year. The second problem, of course, is the risk of treatment. So we have an uncertainty on the side of the rupture risk, but we have a certainty on the risk of treatment, and the treatment of aneurysms is not zero. Of course, we can distinguish aneurysms in good ones and bad ones, also for the surgeon. The good ones are the small neck and the easy aneurysms. The bad ones are the giant and the big and the calcified, whatever. So it's naturally, although many studies are only giving one number for complication rate, which is not correct. We have those who are easy and those who are difficult. So we have to give different numbers for the treatment. And still, also for the good aneurysms, we have a mortality which is below 1%, but still it's there. And for those having a prospective database, you will find them. And we also have morbidity, which means patients who cannot later on continue with a good quality of life, have to change their profession, whatever. So this is still, it's there. We cannot ignore it. So that's the second problem. We have uncertain risk of rupture and a certain risk of treatment. So why not predicting the risk of rupture according to aneurysm parameters? There are a lot of different scores, and I have collected here 6 different studies or scores that people are using. Size is most consistently used, age is used, and then maybe previous SAH, but then a lot of different factors. And while in some of them, like population, hypertension, face aspect ratio and different size parameters did not make any difference, and other they were important. So it's quite difficult to really find some pattern here, except of those major parameters like size and age and previous SAH and location. So many of these schemes, and most often the FACES score is used to predict the rupture. You can read it here. The population goes in, but the Finnish now say they have no longer an increased risk, and you see the SAH rate is going down in the country. They are not smoking and drinking as heavy as before. So this parameter gets off. Then smoking is not inside, familiar is not inside, and so on. So basically the FACES score has also a lot of disadvantages, but it gives a nice number over time and over these risk categories. But of course, you can also select what you want. I mean, ISUIA and FACES have different findings. For instance, in this category, nothing ruptured in ISUIA, but in FACES you have some ruptures. The anterior cerebral artery was no risk factor in ISUIA, but it's a big risk factor in FACES. Previous SAH, no risk factor in ISUIA. A risk factor in ISUIA. In FACES, only 1 point. And an 8 millimeter PCOM has a risk of 3% in ISUIA, but only 0.5 in FACES. So you see there are a lot of discrepancy, and you may change whatever you want. So still uncertainty. So, and this is why we should rather stick to some principles. And then there are some recent changes, I think, towards a certain direction, which is the risk selection-based management, focusing on those factors who really increase the risk and relying on, factors where you don't find it, that these aneurysms have less risk of rupture. So you can basically really spread these by the risk factors. Decision makers to really decide to do treatment with a hazard ratio of more than 10 is size, of course, size more than 10 millimeters. It's aneurysm growth. It's true familial aneurysm where more than 2 relatives of first grade are suffering from an aneurysm or SAH. And of course, those where you have a symptomatic intracranial aneurysm. Decision modifier, and I would not recommend jumping on the first or jumping on the second. So maybe use them together or some of them together. But the decision modifiers are those who increase the risk by 2. And these are locations like posterior circulation, PCOM, ACOM, the shape. Of course, if you have an irregular aneurysm or an aneurysm with size ratio or aspect ratio larger 1.5 or 3, multiple aneurysms, prior SIH, and a simple family history, which means only 1 or 2 and not only having first grade, they may modify the decision towards treatment. Smoking, hypertension, alcohol are also very often mentioned as being risk factors. That is true, but they are modifying. So if somebody stops smoking, if somebody has a treated hypertension, thoroughly treated, and reduces alcohol consumption, it may really change the risk of rupture. So I wouldn't put them in the bowl for the factors you decide on treatment. Growth is very important. 3% of aneurysms grows per year. And if an aneurysm grows, you have between 3 and 80% risk of rupture per year. And this is a game changer. The numbers are different, but it's huge, a hazard ratio of 30, odds ratio of 4, 55, 80% per year. So this is, if an aneurysm grows, we should take this seriously, and most of them fulfill the indication for treatment. Another new parameter is a gadolinium enhancement of the wall of the aneurysms. It has been shown that patients with multiple aneurysms, the ruptured one was more often gadolinium enhancing. And if we compare ruptures and unruptures in general, the ruptured ones are enhancing. The size correlates with gadolinium enhancement, but also some locations like posterior circulation and MCA. But the point is, we should not say this aneurysm, which is enhancing, is now the one we should treat, because only 20% of those with gadolinium enhancement, they grow, and some of them ruptured in the study. But it's more important to know those who are positive, they grow. And the interpretation is better to say nothing, no aneurysms of those who were gadolinium negative grew or ruptured. So if you have a gadolinium negative aneurysm of 6 millimeters, maybe, I think you can stop discussing about if you should treat it or not. They are not growing, and if they are not growing, they have an extremely low risk of rupture. So arguments to change management towards a more conservative approach, and that's the message that I want to deliver, is that we see a higher incidence of small aneurysms like 3-4 millimeters in modern MRI studies. There's a Tromsø study coming out, or has been published, showing that about 5% of these MRAs had small aneurysms. There is a very low rupture risk. There are studies showing that if you exclude only those who are increasing in size, who are gadolinium positive, and having all the risk factors that I showed before, from the entire cohort, you end up having a very low risk of rupture. It is possible to monitor those factors if you do a yearly MRI, if you do gadolinium enhancement, and you stop smoking, and so you can pick up those risk factors. So basically, you are not urged to do a treatment. You can observe the patient and monitor the patient. Aspirin and risk factor management may lower the risk of rupture, and the time to benefit is longer than assumed, and we refer this to the interventionalist's thinking error, which I will refer to in a minute. But first, it's the rupture rate of the small aneurysms. This is a nice study from 2021 in patients with stroke, where small aneurysms has been detected for treatment, and they had aspirin or not. And you see with aspirin, they had the rupture rate of 0.06% per year, which basically is nothing. And without aspirin, of course, higher, because the mean rupture rate was 0.2.7%. And there is another study, a different one, aspirin versus no aspirin and hypertension controlled or not. So there is a possibility probably to decrease the risk of rupture by these measures. And now the interventional mathematical thinking error. I'd like to explain you at the end of my presentation. Of course, the treatment risk is not linear, so the rupture risk, if you have a higher rupture, like 2% per year, is exponentially, because there might be patients still surviving. It's not that, after 50 years, everybody had a rupture. So this is an exponential curve, but you can neglect this, the smaller the numbers. So you have almost a linear curve if you have 0.2% per year or 0.5%. So, and that's the formula to calculate. Remaining life quality is usually depending on age, and it's set that it's now higher than with the coming years. I'm not quite sure if this is true, but the remaining number of life, of course, decreases over time. So the life expectancy is another an important factor. Okay, so now the usual mathematical calculation of a surgeon is, okay, let's say the patient has a 1% rupture risk per year. Okay, and the patient has 5 years life expectancy. So this makes up a 5% rupture risk. And let's say the poor outcome of patient is also 5%. Okay, so this is draw, and I think that's the same. So we can treat the patient with a life expectancy of 5 years or longer than 5 years, maybe 6, 7 years, and the patient will benefit from treatment. And this is not true. If you look really at the numbers of quality of life years that you are losing, if you treat patients, let's say we treat at the same day 100 patients surgically, we treat them, and we have a complication rate of 5%. 5 of these 100 patients will die or have a poor outcome. Let's say poor outcome. And then over 5 years, we have 25 lost quality of life years. But if a patient has a rupture rate of 1%, it's not the same. You have one at the beginning, and a second one in the second year, and a third one in the third year, and a fourth one in the fourth year, and so on. So this number is much lower than this number. And only over time, there's a crossing of lines, and basically the conservatively treated patients are catching up and now having, after 10 years, so doubling the time, we originally think, it's now switches towards treatment. So basically, let's say if a 60-year-old healthy patient has an assumed rupture risk of 0.2% per year, and a 2% poor outcome, we would conventionally think after 10 years, we make the patient better. But that's not true. It's after 20 years for the reason I explained you before. So you have to double the time that you are originally thinking of. The summary that I want to deliver is that the modern management of aneurysms changes towards a little bit more towards the conservative side because of this risk factor relation. You also have to know your own complication rate in your own department. Don't overestimate the risk of this small aneurysms without risk factors. They probably are very stable as long as they are not growing, not enhancing, and not having many deficits. And really don't operate just because you are a surgeon. This is more for the Western countries where there's plenty of surgeons and everybody wants to be a hero, but I pledge to progress and pay attention to the modern data, and then we fulfill our aim. Thank you very much.
Thank you.
Thank you, Professor, for your very insightful lecture. Now we open the floor for questions. Yes, Dr. Hari, you may ask your question, then followed by Dr. Joe and Dr. Gisha.
Hello, Professor. Thank you for your lecture. Yeah, I would like to ask you one question. In your clinical practice, if there are multiple risk factors like smoking, hypertension, and more than one aneurysm, how do you keep them in follow-up? Like after how many months do you repeat the MRI, and how do you proceed with the follow-up?
We try to instruct the patient and really involve them to show them that they can reduce their risk of rupture by changing their life and reducing the risk factors. And we would do every year, we would do an MRI. So we still stick to the yearly MRI. We are discussing after 5 or 10 years if we should change, but there is no linear risk of growth. And if you want to depict the growth, you have to make a yearly MRI imaging, which is quite a lot, we know, but this is sort of a dilemma we have.
Thank you.
Pleasure.
Professor Andreas, I'm Sam from Malaysia. That was a fantastic lecture. I know it may be a bit difficult, but in your practice, after all this, what do you suggest and how do you manage these patients? Do you have a protocol in which when you decide to clip, or most of the time it's more of a conservative until it grows? Thank you.
Yes, for those aneurysms being less than 7 millimeter, we look at these risk factors. If we have a growth, of course, we trigger treatment. If we have family patients, it triggers treatment. But if we have, of course, we are balancing. So if you have a 6 or 7 millimeter aneurysm of the posterior circulation, we also treat, because these are relative risk factors. They were on the other side. But patients not having risk factors, a 5 millimeter MCA, no risk factor, as smooth, looks smooth, no bubbles, no daughter blebs. We keep for every year. We do an MRI.
Right, okay.
Without gadolinium, just the top, the time of flight, you see very nicely if it's getting larger or not. You don't need to measure 0.5 millimeter, but you will see after 1 millimeter if it's growing.
All right, understood. Thank you.
Thank you.
Professor Dishot.
Yes, thank you so much, Dr. Rabe, for interesting presentation. My question is, do you, in Switzerland, do you have any kind of screening program for diagnosing of unruptured aneurysms, like some kind of routine examination methods, or you just follow the risk factors, the groups of the people who has the risk factors, or there is some kind of genetic tracing method, who has in their families aneurysms ruptured, or who is prone to cerebrovascular disease? You just pick up these family members and check them up, or any kind of diagnostic methods?
Yeah, we do not actively screen patients. We explain, we only screen when the patient's family wish to screen family members, relatives, if they have a true familiar situation with aneurysms and ruptures. So if you have somebody who had an aneurysm and you have a relative, you would not recommend screening, because only that's a relative for one, incidental rupture of the patient. So there is no screening program except of those with families and patients with polycystic kidney disease where the family has aneurysms and they want to be screened. We are not actively pushing other groups. We are now doing a study including female smoker beyond 40, because we saw in a Finnish study that the number of patients with aneurysms is much higher, and also the growing aneurysms, but this is only a study. So we are only, if we have an incidental aneurysms, we do a yearly follow-up depending on the age of the patient.
Thank you so much.
Thank you for your question.
Dr. Atik, next.
Oh, thank you, Professor. I am a neurosurgeon from Bangladesh, now doing my fellowship in Fujita University. My question is just continuation of Dr. Dilshad. In my country, we get the most of the aneurysms are ruptured on. We rarely get any aneurysm that is unruptured. So how can we get the benefit from the study you are doing in developed countries, or how we can implement this type of study in our country? considering the economic condition of our poor patients?
Yes, I'm aware of this discrepancy and this gap. I think if you have let's say a ruptured aneurysm and these patients are coming in, I think one of the consequences that you can learn is, okay, if the other aneurysms, if patient has multiple aneurysms, for instance, it's really only a few aneurysms that should be treated in the same patient. And I think the situation is in your country is even more difficult. So treating only the ruptured one is absolutely good balance to do so, because it's for many aneurysms the risk is quite low. On the other hand, I think you are going to develop, and maybe you will also see unruptured aneurysms in some patients with brain tumors, or maybe in some patients who had an incidental headache, whatever. And then I think you could learn that aneurysms are not aneurysms. So not every aneurysm has to be treated. So stay on the conservative side more.
Okay, thank you. Thank you very much.
Thank you, Dr. Atik. And the last question, Dr. D, can you ask your question?
Thank you so much, Mr. Liu, and thank you, Prof, for your insightful lecture. I'm curious on the follow-up for MRI surveillance in countries where resources are limited. For how long would you suggest the annual surveillance to be continued? Is it lifelong, provided the patient still remains risk factor free? Or would you suggest us that perhaps after 5 years of annual surveillance, can we extend the surveillance period to perhaps 18 months or 24 months due to the restricted resources most of the developing nations have?
Yeah, I would even say that with restricted resources, I would exclude these aneurysms who have no risk factor from further surveillance. It's a very likelihood that these aneurysms, start growing, and we do it. Of course, we do it every year because we also want to learn. And for us, the consequence, if you see a growing aneurysms, of course, this is larger. But if you just look at aneurysms smaller than 6-7 millimeters, and if they are not fulfilling risk factors, in restricted resources, you have your resources differently. And I would not even do follow-up in these cases. In the other ones, I would do yearly. So if you have an aneurysm that is maybe not smoothly configured, or it's around 7 millimeter, or you have, the patient has a lot of risk factors, then it might be sensible to do it, the first follow-up after 1 year, and then maybe after 2 years, and then maybe after 5 years.
Thank you so much, Prof.
Thank you. Thank you to all the audiences or panelists for the question, and thank you again to Professor Andres for a very nice lecture and a nice discussion. We move on to the next lecture by Professor Olaf Schinch, a consultant neurosurgeon from Maastricht University Medical Center, Maastricht, the Netherlands. And he'll be talking to us on SEEG radiofrequency thermocoagulation in patients with epilepsy and nodular heterotopia, the first result in the last series. Professor, please.
Thank you very much for your kind introduction. Good morning, good afternoon, good evening, everybody. Thank you, Professor Kato and Demetriades, for inviting me also on behalf of the EANS. I'm the chair of the section of functional neurosurgery. And I really realize very much that we go from global neurosurgery to a very specific team indeed. And that is the stereo EEG minimal invasive treatments in a selection of patients who have drug-resistant epilepsy. And as you see, I talk also on behalf of my epilepsy surgery working group. Well, the SEEG, this talk will be divided in 2 parts, the technique and the thermocoagulation and the first results in our academic center for epileptology, the patient cohort with heterotopias. As you know all, I think the SEEG technique and the implantation of the depth electrodes started at the end of the 50s, beginning of the 60s. And the pioneers were neurosurgeon Jean Talarac from Paris, Sainte-Anne, and Jean Banco, he was the neurologist. And as a team, they developed this technique and described it also in their first paper in '62. Well, essentially, they already at those days saw that it is important that you consider epilepsy as a network disease, not only as a focal disease. So, and with the implantation of the depth electrodes, they could detail and detect the spatio-temporal distribution in epilepsy and correlate this to the semiology. As I visited, among others, Lyon in France, I saw their technique, the original technique with the Talarac frame. You see it here. And besides the head of the patient, you see the raster, and that you can introduce the different stylets and depth electrodes only in an orthogonal way. Well, in Maastricht, we adapted this technique in order to also implant depth electrodes in an oblique way, not only orthogonal. So we use the Lexel frame, and we make before an MRI, a 3T MRI with double gadolinium contrast. So we do not do an MRA or an DSA, only a double gadolinium MRI. On the day of the surgery, with the frame mounted on the head of the patient, we make a CT scan, we fuse both scans, and then since 2014, we use the iPlan software of BrainLab to, see the trajectories which we plan and the coordinates. That looks like this screen. You see in the three directions, the MRI scan of the patient, you see the head of the patient, and you can plan different electrode trajectories as indicated here in color. In the screen right below, you see a software package we developed in our epilepsy center to see in 3D where the electrodes enter, where they go to their target, and which is the trajectory. We use the Dixie electrodes. So Dixie is the French company which developed the electrodes, but also the screws and the stylets to introduce the path and the measurements instruments. Here I prepared a small short video of our technique. I try this video. I hope you see it. Well, we have here the patient. The patient is awake. We fixate under local anesthesia the Lexel frame on the head of the patient. So we do this together with a colleague and some nurses. It's tolerated in general well by the patient. So of course he feels that we are doing something, but it doesn't hurt. Afterwards, we go to the CT scan. Here you see we mount up the frame of the coordinates on this Lexel frame, and the patient is fixated with his frame and the coordinate box into a frame on the table of the CT scan. And afterwards, when everything is fine, we check if he's lying well and the CT is made. This takes normally 1 to 2 minutes. And afterwards, we are planning together with our neurologists the different trajectories. Here you see still the stealth station we used before from Medtronic. Now we use BrainLab. Well, then we transfer the patient to the OR. The patient is under general anesthesia and in supine position in this case. The scrub nurse is disinfecting the head of the patient and draping. And then we mount the Lexel frame, as you see here. We arrange the different coordinates. Here we introduce the stop and guide for the twist drill. And when this is fixated on the arc of the Lexel frame, we introduce the drill and we make a tiny burr hole, 1.2 millimeters in diameter through the external and internal layers of the skull. We take out the twist drill, and then of course there is a necessity to coagulate the dura. We do this with this coagulation probe. It's a monopolar coagulation, as you see. And with this technique, you can open the dura. Then there is the insertion of the screw. As you see here, the screw will be fixated on the tabula externa of the skull. And then the distance is measured from the top of the screw when the stop and guide is on 0, as to know the length of the electrode and stylet we have to introduce. This is the stylet. This metal stylet prepares the trajectory till we are from entry to target, carefully introducing it. The electrode has the same length. We all write those lengths down. After taking out the stylet, you will see a bit of sanguinolent CSF coming out, and then the electrode is introduced again. And this electrode can be fixated on top of the screw. And at the end of the procedure, it looks like this. You see orthogonal and oblique or electrode insertion in one patient. After this, the Lexel frame is removed. And the head of the patient is bandaged. You should be very careful with all those cables. And the day after the surgery, the patient goes again in the CT scan and MRI scan, just to see if there are complications and the electrodes are well. And then he is going by ambulance to our epilepsy center, where the patient will be for 2 weeks for a registration period. Here are the technicians fixating everything to their registration machines, our neurologists for the first registration, and also stimulating certain brain areas. And here are the technicians seeing a first seizure of the patient. As you know, as you can see, this is a patient with frontal lobe epileptic seizures. At the end of the 2 weeks, the patient is transferred back again to our hospital, and one of our physician assistants on the left side, he removes the electrodes. It's without any pain. You take out the screws and stitch the opening. The patient can go home 1 day after explantation, and 3 months later, we will see if there is a reason for resection. Well, now we start with the part of the thermocoagulation. Marc Guénaud from Lyon, our neurosurgical colleague, he described it for the first time in 2004. And the years after, there were multiple other publications about the conversion of the SEEG from a diagnostic into a therapeutic technique. And this as a real minimal invasive alternative for drug-resistant focal epilepsy in patients unsuitable for resection. Different kinds of lesions are included in these procedures. And you see here in bold, the first one, the periventricular nodular heterotopias. We started in our center with this selection of patients because from the sparse literature, especially the French literature, we saw that the best outcome results were in this group. But of course, you can also include patients with MCDs, malformations of cortical development, like the focal cortical dysplasias, hippocampal sclerosis, the hypothalamic hematomas, and even MRI negative cases. You need specific machine. This is our power generator, our Cosman machine. And you see the parameters we use. The temperature raise, you cannot measure directly in the patient, but from animal studies, we know the temperature raises till maximum 82 degrees Celsius. And when the lesion is made, you see an abrupt current decrease, which indicates the tissue coagulation. Well, where do we coagulate? We coagulate in areas where you see the LAFA pattern, the low amplitude, fast activity of epileptiform activity, or spike wave discharges at seizure onset. The targets first are functionally tested, so we have to know that there is no important neurological function, and we do this with the 1 and 50 Hertz frequency, with a pulse duration of 0.5 milliseconds and an amplitude of 1 to 3 milliamps. And only the targets without any clinical response are selected for the thermolesion, and no thermolesion within 2 millimeters in distance from the vessels. So this lesioning is always bipolar between two contiguous contact points, and it is placed without any anesthesia. So we know what the patient feels. So we find it important to have the clinical monitoring at that time. You have to realize that after coagulation, we have a lesion of about 5 to 7 millimeters as a maximum. And you cannot measure, as I told you before, the temperature in situ. After each coagulation session, we do again a recording with the depth electrodes in situ to confirm if there is absence of focal epileptiform activity. And then the electrodes are explanted within 24 hours after the coagulation procedure. This is not evidence-based medicine. We have this information from our French colleagues who have a lot more experience with this technique. And but for example, animal studies or something like that were never performed. So it is a gut feeling, as to say, to explain them within 24 hours. In our cohorts, we started the SEEG, introduced it in the Netherlands. I did this together with my neurologist in 2008. And till present, we implanted 213 patients. And this was the diagnostic cohort. So the total cohort of SEEG in our center, as you see, more adults than children. And actually, we implant more or less 25 patients a year. In 2016, so 12 years after the first report by Marc Guénaud, we started with coagulation. And now we have coagulated 136 patients. And especially the patients with the heterotopias, I would like to show you here. It's in a pilot single center study, started in March 16. We selected 28 patients with heterotopias, and in 25 of them, we could do a coagulation. You see the reasons of not coagulating in between parentheses. It were all focal lesions. So in 15 patients, unilateral, and in 13 patients, bilateral. And we report here only the patient with a follow-up of more than 12 months, as we do in open surgery. So you see we have a mean follow-up of 38 months. Well, here you can see some demographic and statistics from this specific cohort. You see that the epilepsy duration as a mean is almost 16 years. Patients have a lot of seizures per month. And as a mean number of electrodes, we implant 11 electrodes in this group. Some patients needed a second and even a third SEEG to come to a conclusion. The mean number of RFDC lesions is also 16, and we use more or less 2 to 3 sessions to coagulate. Here you see the location as you see, almost half of the implanted depth electrodes and the coagulation is in the temporal occipital region, but it can also be in the other brain regions. It's 50-50 sites, so we coagulated in unilateral cases, but also in bilateral cases, and you see the number of heterotopias. Here is a classical 3T MRI flare image with a heterotopia located in the left occipital horn. And here you see a flare MRI 3T between 1 and 2 months after the coagulation, where you see on below the occipital horns the coagulation effects in the flare. Well, interesting is the outcome, of course, in this patient cohort where open surgery is not the first choice. And as you know, the seizure outcome is classified due to the ELAE classification, meaning that the number 1 class is the seizure-free class. At 12 months, that's an important follow-up date, I would say. You see that in our cohort, we have 52% seizure freedom. So patients who did not have any seizure at all. And this percentage drops a bit to 48% at last follow-up. As you know, the mean follow-up was 38 months. We did a statistical analysis to see if there are differences in different parameters between the seizure freedom class and the patients who are not seizure free. And the only thing we saw is that the more SEEG procedures you do, that is correlated with a worse outcome. As you can understand, this is quite logical. Well, not only the seizure freedom rate is important, but also the responder rate. That means all patients who will have less than or more than 50% seizure reduction. And we saw in our cohort 18 patients, or 72%, who were responders. And this is quite important because you can plan a second procedure or even open surgery when you would like, and the patient also in your shared decision making, because you know that the responders do well in a second procedure or with open surgery. The complications also important. We had 2 permanent complications in 2 patients, so 8%, and those were visual complications of the visual fields. The lesions in these patients were in the temporal occipital region, 1 low parietal, heterotopias in the trigonum area of the brain. And of course, we canceled the patient before that after the coagulation, there could be a kind of visual field deficit, which will not be, which you cannot rehabilitate, of course. We had in 3 patients, 12% transient complications and vertigo, and patients who called us 1 week after the explantation and getting home that they had a fever and headache. Well, they came back to our hospital. We did an analysis of the blood and the CSF, but didn't find any indication for an infection. And there was a spontaneous recovery in the hospital after 3 days. So our theory, we consulted our French colleagues and asked them for their experience, but they said, well, yes, we see it, perhaps a bit more in the patients who have more coagulations. And we interpreted this as a kind of aseptic meningitis. So the denaturated proteins are coming into the CSF, and this can provoke symptoms like fever and headache. So when we started the coagulation series, of course, there came up different questions, and still we have many questions. So should all patients with heterotopias get an SEEG and an RFTC? Well, this is a very complex group of patients with focal drug-resistant epilepsy, a high SUDEP risk, so sudden death in epilepsy, and in general, not suitable for open surgery because there are tiny lesions in the depth of the brain, and especially in the left side, in the dominant side, you would not like to make too much damage. So what to do if the first RFTC procedure does not result in seizure freedom? Well, we now are adapting the procedure to repeat. So as we see that some patients really benefit from a second procedure where you can fine-tune the electrodes in your seizure onset area. Do we actually need to prove seizure onset in the heterotopia? Are there indicators for the epileptogenic paths? Well, there are several reports coming up, and they say the overlying cortex is more important than the heterotopia itself, and that also incomplete lesioning is not fruitful. Well, our experience is not like point 2, because we saw in many seizure-free patients, 7 out of 13, that they have on their MRI rest lesions, so rest heterotopia. And that led us to the hypothesis, perhaps that we need to destruct only the critical hub in the heterotopia or the overlying cortex as part of the epileptogenic network, and this can be perhaps sufficient. So Bourdillon, our colleague from France, he did quite amazing work with a systematic review and meta-analysis. He showed us there were no prospective studies, but only 6 quite large retrospective studies. And they showed a pooled seizure freedom rate of 23% and a responder rate of 58%. So we had in our series a larger seizure freedom rate, as you saw, but this can be perhaps explained because many studies indicate and include a mixed bag of patients, so not only the heterotopias. Well, about the safety, you see also the pooled rate of permanent neurological complications was 2.5%, more or less the same as in our study. So the summary of advantages of this technique is the target choice of your coagulation is based on real-time SEEG data. You can do a functional mapping in situ while the patient awake. Your diagnostic electrodes are the therapeutic ones, so you do need another procedure, not need another procedure. And multiple electrodes, of course, mean multiple possible lesion sites. So you are not dependent that a patient should have only one lesion. So 2, 3, 4 heterotopias, you can do it also. It's a real-time monitoring of the patient, of course, and of your clinical symptoms. You don't need anesthesia. It is prognostic, so it's curative, but also prognostic for even future other procedure or even resective surgery. It is perfectly possible. So among 3/4 of our patients we operate, and the resection surgery in cases after only a diagnostic SEEG, that's not more dangerous and not more complicated. And also after coagulation, some patients I have operated, and there is the same risk as in normal resective surgery. Electrode explantation is good possible without additional bleeding risks till now. Well, disadvantages you also have. It's, of course, I realize in the LMIC countries, it's quite an expensive technique. There is no visual and anatomical control at insertion of the electrodes. You have a diameter, well, I wrote down here 3 to 5 millimeters. There are literature reports 5 to 7 millimeters. So, but you have to realize the diameter is quite small. So this will not be very efficient in large lesions. When you have, for example, a large hypothalamic hematoma, this technique will not be indicated. And yeah, well, I told you, I talk about a technique in a team setting. So you need a team of neurologists, you see here in the middle, and the neurosurgeon besides. So we have developed quite a big team right now. Of course, it's open for questions and answers. I don't know from the organization if that can be now or later. So I'm happy to give you answers. And I also want to express you that on behalf of the section of functional neurosurgery of the EANS, we are very happy to start collaborating with for global neurosurgery, especially epilepsy surgery. Thank you for your attendance.
Thank you, Professor Olaf, for the nice presentation. I think before we proceed to Q&A, may I call upon Professor Joachim Ortel? I would like to apologize to Professor because we are 1 hour behind time and you have a train to catch in the next 5 minutes. He's a professor and medical director of neurosurgical department, head for Neuro-Oncology Center, University of Saarland, Germany. Professor, would you like to say something? Later we will play your video, Professor. Professor Ortel.
Okay, thank you so much. Unfortunately, I have to leave. It's a very interesting morning. I just recorded the lecture, so just if you have any questions, I think the best way is you just send the questions by email to you, and you can forward them to me, and then we can have a discussion by email later on.
Yeah, sure.
Okay.
Thank you very much,
Congratulations
Professor.
for the nice event, and yeah, you play my lecture in the lecture after the next one.
Sure, Professor.
Thank
Have
you
a safe
so much.
journey, Professor. Okay, bye-bye. Let us call Professor Olaf back. Is there any question for the lecture given just now by Professor Olaf?
Thank you, Professor, for a very informative report about heterotopic lesions. And have a question about after this thermocoagulation of these lesions, was there any post-coagulational recurrent seizures, or it was 100% curative method, or was there any like scar tissue dependent seizures after thermocoagulation?
Thank you for your question. Yes, no, this is not a 100% curative method. So we have, as you saw, quite a high percentage of patients becoming seizure-free 12 months after the procedure, 52%. That's higher than in the French series, but you have to realize we have a very selected group of patients, only the patients with heterotopias. And those patients were also reported in French literature as the best ones. So we wanted to start with this procedure, and also recommend other centers who want to start with this procedure, start with this group of patients, because those will have the best outcome. But when you say you have 52% seizure freedom at 12 months and 48% at 38 months, there are also 52% of patients not seizure free. But then we classify those patients if they are responders or not responders. And when they are responders, so meaning more than 50% seizure reduction, then you can select those patients for a second procedure, or discuss in your epilepsy surgical team if perhaps an open resection would be also an option. Of course, especially when these lesions are deep-seated in the dominant side, you should do a very good shared decision making together with your patient and their caregivers, because there can also be morbidity from this procedure. So, but to answer your question, it's not 100%, but you can have quite a good percentage of seizure freedom and a responder rate in a group. Perhaps 10 to 20 years ago, you would not treat and let them on anti-seizure medication.
Thank you so much. So that means it's kind of first step, half diagnostic measurement.
Yes, you start with a diagnosis, then you do the stimulation to see if there is a function in the brain area you want to coagulate, and when there is not, and you have more than 2 millimeters distance from your vessels, you can do the coagulation.
Thank you so much.
Thank you for the question, and we need to move on to the next lecture. Thank you, Professor Olaf. There's also another question in the chat box. We hope Professor can type in your answer for the chat box. I would like to call upon Professor Kars Rossell, a professor of Department of Neurosurgery, Department of Surgery, Medical Science Cluster, Medical University of Vienna, Australia, who will be talking about MRI guided laser interstitial thermal therapy for epilepsy. Professor, please.
Yeah, thank you very much for having me. My name is Karl Rössler. I'm working at the Medical University of Vienna, and I'm also part of the functional section of the EANS, and also talking in behalf of the EANS. Congratulations for this wonderful program. My topic for today is the MRI-guided laser-induced thermal therapy for epilepsy, and I can share with you mainly pediatric epilepsy cases. The laser-induced thermal therapy is also a minimal invasive therapy for all kinds of procedures, also for brain tumors, epilepsy, and also reports about cavernomas, which were treated with LIT reported. We in Vienna are an epilepsy center, and we are doing all kinds of epilepsy procedures, mainly temporal, but also extratemporal. And we are also using deep brain stimulation for treatment of refractory seizures. And we have also the possibility to use gamma knife for lesioning. So because in the literature, the lead therapy for most of the epilepsy procedures is still inferior, the outcomes are still inferior to open surgery. So we are losing lead very restrictive only for those cases where we can't offer an open procedure to the patient. So I have nothing to declare. As you have already seen, thermal coagulation has the disadvantage that you can only apply small lesions, and this is the Japanese study for hypothalamic hamartomas with refractory epilepsy treated by thermocoagulation. And what you can see also for only disconnection, you need multiple trajectories and multiple lesions so that it could be quite cumbersome to treat these patients by using thermocoagulation. So laser fibers were invented for inducing much bigger lesions, like this kind of lesions from this kind of fibers from the Medtronic company, where they have designed two fibers. With one fiber, you can create the lesion up to 2.5 centimeters or even 3 centimeters in this ellipsoid shape, and a smaller fiber where you can create a lesion, a globe lesion with a diameter of 1 centimeter. Laser-induced thermal therapy was first reported in the literature by a German group, Kahn et al., published this paper 96, and they used it for treatment of cerebral neoplasms. And for epilepsy surgery, Daniel Curry, who is really a pioneer in the field of laser ablation for epilepsy, reported this kind of treatment for children in 2012. And for him, the advantages were that this is minimally invasive. It can be used for deep-seated epileptogenic lesions. In his hands, it had better morbidity rates, and it was possible to have a real-time visualization of creating the lesion compared to the thermocoagulation with radio frequency and a direct ablation control via scans, via MRI scans. So it was proposed as an alternative to conventional surgery for intractable epilepsy. And indications for epilepsy in the pediatric population might be also hypothalamic hematomas, as we have already heard about periventricular heterotopias, tuberous sclerosis, and in fact, the first patient Curry treated was a child with tuberous sclerosis, but also focal cortical dysplasias. And in the United States, it is very much used for as a real alternative in temporal lobe epilepsy, also for hippocampal sclerosis. But as I have stated, we are not using that because the seizure outcome is reported still inferior. There are also reports of having used lid for corpus callosotomies. There are two main systems at the moment on the market. The one is the NeuroBlade from Monteris. It's only available and certified for use in the United States. And we in Europe are able to use the Visualase system from Medtronic. The Monteris system is a CO2-cooled neodymiac laser, and the Medtronic system is a saline-cooled diode laser. The laser fiber is inserted in a watertight tube, and this tube is constantly rinsed with cooled saline, so that the laser fiber cannot exceed the pre-planned temperatures. And what maybe is a big advantage of the NeuroBlade system is that within this system, there's also available a fiber with a side outlet of the laser so that you can use it for side outlet treatment. Principally, you have to introduce the laser fiber to your target, so you can do that either frame-based with conventional frames, as you have seen it from Olaf at the presentation before, or frameless systems, or you can also use robotic systems. And we in Vienna use all kinds of these systems. We have a Vertec arm system from Medtronic. It is very versatile. We also use the VariGuide from BrainLab, and we are also able to use the AutoGuide mini robot, also from BrainLab. Here you can see the bolts. You have also to use a bolt. You implant the bolt according to the pre-planned trajectory in the neural navigation system. If you have seen it for the depth electrodes before, you have to do a small skin incision, borehole drilling, and you have to implant this bolt, and then you can introduce your laser fiber into the bolt according to the distance you have measured in your planning. And here you can see the two bolts and two laser fibers in place. And we in Vienna have the advantage to have a brain suite, a two-room concept with intraoperative MRI scanner, so that we can implant the fibers and also depth electrodes in the OR part of these two rooms. And after having implanted it, we shift the patient on the carbon table of the OR table onto this transport trolley. And with the transport trolley, the patient is then brought into the OR and placed in the scanner. The advantage is that if you see that your laser fibers are malplaced, if you want to correct it, you can just come back to the OR and do the correction. And also the anesthesia equipment and all things can be transported smoothly, and you don't have to change different levels from your OR to the operating room. And if you are now in the scanner, you check the placement of the fiber, and after you have checked that, you can start with the thermocoagulation, with the laser-induced thermocoagulation, and you can watch this with these heat maps. You see where you apply the heat, and you have also a second map where you have the lesion model and where you can estimate which tissue you have already lesioned. And you can use the fiber trajectory by pulling back the fiber and doing lesions along the fiber trajectory for building up your lesion volume. And I want to show you now a few examples. This is also a case of superinvestment of PVH. It is a 28-year-old male. He had a very long seizures. He has a focal epilepsy, and the seizure origin from the PVH was already confirmed by phase 1 monitoring. And the PVH is located along the ventricle, and it showed also a hypermetabolism in the PET images. And this was the 3D reconstruction of the PVH. And these are the two fibers which we planned and which where we did the coagulation. This patient had temporarily hemianopia after the laser coagulation, but this resolved, unfortunately not completely, but it resolved within the last 3 to 6 months. But unfortunately, the patient didn't become seizure-free completely. He had less seizures and less severe seizures, but didn't become seizure-free completely. And a very, very attractive and very interesting field is the tuberous sclerosis complex in children. You know that they have many tubers in the brain, and most of them have seizures. And of course, you can resect it by open resection. But the problem is in these very small children, this was a child with 2 months of age, you can get complications. This child needed a shunt. And so the community, the epilepsy community, I think is quite thankful for having MR-guided LIT as an additional treatment option in tuberous sclerosis children. What we do in them is we always do invasive monitoring. We implant depth electrodes in all kinds of tubers, and we check for the most active tubers. And if we find an active one, we implant the lid and do lid coagulation. And this is our first case, lid case. This was a 6-year-old girl. She had seizures since her 4 months after birth, and she had a genetically verified DSC. We found 2 active tuber complexes by invasive monitoring. This was the invasive monitoring, And we did 2 lid procedures, one in the precentral region and one in the temporal occipital region. And what you can see is that the EEG changed dramatically. This was the pre-op and the post-op EEG. She got seizure-free, and what we found was that she made a steep progress in speech and motor function, was first ambulatory in her life, and the EEG was very much better. And another case is this MRI negative case. She was a 23-year-old woman. She had many seizures, refractory, and she had this extensive SEG study. And what we found was one electrode which was spiking, and for this electrode we did a lid. And what you see here is a large vessel, MCA vessel, which cools itself by the blood flow. So there is not so much a danger to injure vessels by heating up. And this is the kind of lesion we created, and this patient became seizure-free. Altogether, since January 21, we did 14 procedures, 13 were for epilepsy. We did 1 tumor case, a pilocytic astrocytoma in the brainstem. And what we found was that our grade 1 angle outcome was about 50%. And what might be a challenge after applying lid is if you have to come back and to do a surgery. This was also a tuberous sclerosis patient child. She had an invasive monitoring, and we did a lid with this dorsal trajectory along the temporal lobe and the mesial structures. She didn't become seizure-free. We did an invasive study again, and we found that still the temporal lobe is the problem. And then we decided for surgery. I did this temporal lobectomy, but what I found was large scarring even in the direction of the cisterna of the mesial cistern, so that it is quite dangerous to do these kind of procedures after you have done lid surgery, which you have to consider for your indications. And to conclude, we in our institution think that a lid is not for common, for straightforward epilepsy cases where the open surgeries are still the gold standard and have the best seizure outcome. We think lid is in epilepsy surgery mainly for these multifocal cases where you don't have an alternative and where you can maybe have an outcome of 50% seizure freedom. So, of course, this is a very interdisciplinary work, and I will also thank all my co-workers. Thank you very much for your attention.
Thank you, Professor Rossler, for a very nice lecture. Hello.
Yeah.
Now we open the floor for question. Yes, Dr. Atik, you may ask your question. You are muted, Dr. Atik.
Thank you very much, Professor. Basically, this is a new learning for us. Really interesting. And my question is, after doing the procedure, what is the protocol of withdrawing the anticonvulsant drug? You do directly withdraw the anticonvulsant drug, or you taper the drugs, or what is your suggestion?
The medical management is like in conventional epilepsy surgery. You don't stop with the drugs the first 6 months in children and even the first year in adults. And we are we are starting tapering drugs only after this kind of period, because the epilepsy is a network disease, and you have to wait till the brain cools down, the epilepsy activity cools down, and you are not able to stop the drugs immediately after epilepsy surgery.
Yeah, thank you.
Probably one more last question from Dr. Hari. Hari, please.
Thank you, Professor, for your lecture. Hello, can you hear me?
Yeah, I can hear you.
I just have one question. In tuberous sclerosis, you mentioned you will insert in all the tubers for the laser guidance. So what is there any size criteria which you consider while inserting between the microsurgery and laser ablation?
In tuberous sclerosis children, we are only able to use the laser fiber, the laser coagulation, the lid, when we find 1 or 2 very active tubers. Normally, these children have many, 10, 15 tubers, and you never know what is the most active tubers. You do your phase 1 investigations with the surface EEG, and you have your one hemisphere maybe is suspicious where the seizures come from. And when we have this one hemisphere, we are implanting depth electrodes in these tubers where we think the epilepsy comes from. And when we find 1 or 2 very active one, then as a third step, we use the lid. And according to the size and shape of the lesion, we plan the lid so that we maybe can lesion the whole tuber.
Okay, interesting. Thank you, Professor.
Thank you, Professor Rossler, for a very nice presentation and discussion. There's one more question for you to answer in the chat box. Hopefully, Prof can type in your answer.
Thank you very much for having me.
Thank you, Prof. So, as you all know, Professor Joachim Otter is supposed to be the next speaker, but is in his train journey now. He's a professor and medical director, Department of Neurosurgery of the Hospital Saarland, Germany. I'm going to play his video on his behalf. Later, I will share his email address if there's any question and answer question for him. So let me share my screen. Do let me know if you can hear.
So, ladies and gentlemen, it's a pleasure for me to be part of this ACNS-EANS event. And the topic of my talk is about cerebellopontine angle surgery. My name is Joachim Oertel. I'm from the Department of Neurosurgery, Saarland University, Hamburg, Germany. This is my disclosure. I used to act as a consultant for Stotz Company and hold patents with them. This is Europe. This is where I'm from. So Southwest Germany, a very small city, 1 hour from Frankfurt, Luxembourg, and Strasbourg. And this is our university department. So we do like 300 to 400 endoscopic procedures per year. We have 4 theaters and 2,000 to 3,500 procedures. What are modern trends in skull-based surgery? Well, endonasal endoscopic surgery, I think, is a very frequent task. However, we don't want to do anything endonasal today. We would rather focus on transcranial procedures. And the aim of transcranial procedures is the minimization of craniotomy, reduction of surgical trauma of the approach, and additional information at the target. And then there's a new aspect, and this is about rendering the image, digital image use for molecular imaging, like contrast enhancing, fluorescence positive, ICG, whatever. So these are different indications for endoscopy, and I will focus today on transcranial endoscopic assisted surgery. The difference here is that we don't have a preformed cavity, so we need to create sufficient space to maneuver our instruments. And frequently we use this for endoscopic inspection, and rather assistance is rare. In screening procedures, they have the opportunity with using the endoscope for better illumination. You can use it for look around the corner, for reduced invasiveness, and for improving surgical results. We have done in about 11 years, close to 3,200 endoscopic procedures. And I will focus today on vestibular schwannomas and some other rare indications of the cerebellopontine angle. The surgical technique is, except for very few cases like the general neuralgia and small acoustics, always microsurgical surgery. A technique is applied. If potentially helpful, we use the endoscope, and indication is usually to look around the corner to gain more information. So is there a tumor behind the vessel or nerve? What are the perforators? Are those in the clip or not in aneurysm surgery? In this cerebellopontine angle, we have done close to 550 cases, and the majority of these are vestibular schwannomas. Technique was used if potentially felt to be helpful. Almost all procedures in the cerebellopontine angle are done in semi-sitting position, and we use in general bayonet-shaped optics. This is either from the Quevo, from the Kinevo endoscope, or 30 to 45 and 70 degrees optics with a bayonet shape from Storz. Microsurgical instruments and technique are the most crucial part. The endoscope is used for inspection and sometimes for assistance. This is such a setting and the semi-sitting. When we analyze the schwannomas in this series, we have done the majority of vestibular schwannomas, some trigeminal schwannomas, and hypoglossal schwannomas. The indication you see here, it's a deep meatus here in the lower part, a high jugular bulb. So you have limits with the drilling of the procedure, and these are the indications when you need an endoscope to look around the corner. Here, for example, you see the vestibular schwannoma, which is extending into the meatus, and then it's very helpful to have a look around the corner to analyze the structures. Typical video here, if the drilling is limited because of a high jugular bulb, you can limit the drilling. Then you can use the regular microsurgical resection, and then you go in with a 30-degree scope, and then you actually have the opportunity to see almost down to the funnel. Here you see such a video of such a procedure. 30-degree scope, we go in and then we gain additional information just by using the 30-degree scope and the high magnification to resect the remnant deep in the internal meatus. Here, complete resection. Another example, trigeminal schwannoma. It depends a lot on your surgical technique, so we prefer usually to use a retromastoid approach, retrosigmoid approach. And then you need an angled endoscope for the exposure of the tumor and the Meckel's cave. Might be different if you do a subtemporal approach, but most of the time we prefer this retrosigmoid approach. With a 30-degree scope, you have a wonderful image down into Meckel's cave. This is like a 70-degree scope on the second one, so upper left is 30 degrees and 70 degrees. You can see everything in Meckel's cave, including the trigeminal nerve, and you can achieve with this technique, with the endoscopic assistant technique, you can achieve a complete resection of the tumor, even down to Meckel's cave, to the tip of Meckel's cave in the anterior area. So we have done about 221 schwannomas in the cerebellopontine angle, mainly with 30 degrees, some with 45 and 70 degrees scope. The endoscope was used in 181 cases, so 82% for inspection, and in 37 For assistance, so about 4 out of 5 we use it for inspection, and 1 out of 5 we use endoscope control, so manipulation under endoscopic view. Was considered to be indispensable in 15% of the cases by the performing surgeon, and we had 1 or 2 cases with side effects in the beginning of the series, where we had no LED light source, but rather a cold light source, so it's a xenon light source. There we had some deterioration of acoustic evoked potentials during the endoscopic inspection. But since the LED light sources were introduced, we haven't observed this problem anymore. Here's some images now from other procedures on the cerebellopontine angle. Typical application is frequently discussed trigeminal neuralgia. I personally think trigeminal neuralgia, it's not that helpful because in most of the time you actually see the situation, the anatomy with a straight microsurgical approach. But very different from trigeminal neuralgia and hemifacial spasm, I think the endoscope is almost indispensable. You can use it with a 30-degree scope to identify not even the compressing the nerve vessel conflict, but also to mobilize the vessel with preservation of even smallest perforators at the brainstem. And I think this really gives a lot of support to be sure to avoid complications by microvascular decompression and hemifacial spasm. We have done so far 7 hemifacial spasms with this technique, and it was considered to be helpful in all of them, indispensable in 43%. I think it's a very good indication. Unfortunately, with the Botox injection, very few patients are referred to us. So when I conclude, the endoscopic inspection and assistance particularly helpful in high jugular bulb, cystic tumor, deep intramedullary location. An aneurysm, I have not talked about this today, but it's very helpful to exclude compromise of perforators. And I think hemifacial spasm is an ideal indication for endoscopic application. In all, it's a valuable tool for us, but it's just a tool. So it doesn't change much the surgical technique, it just gives you additional support for most of the skull-based procedures. It's indicated when there's a look around the corner, is expected to be helpful, and it can help to reduce the surgical trauma as a surgical risk. And if you're interested, our endoscopy week is in the beginning of September, so we cover skull base, interventricular, and spine. You're welcome to contact me. Thank you for listening. Unfortunately, I have to leave for traveling now, so then we had to record the lecture.
So thank you for the presentation. I shall share the email so you can ask questions. Yes, Professor Ahmad, anything you want to say?
If Ertel is still there, Joachim, are you still there or you left?
Yeah, he left, Professor.
Was it recorded? Okay, thank you. I wanted to ask him some questions. Okay.
You shall email him, Professor. So we move on. We move on to the next lecture. It gives me a great honor to call upon Professor Florian Ringer. He's the chairman of Department of Neurosurgery, University of Medical Center Mainz, Germany. He'll be talking to us on modern management of spinal metastasis. The floor is yours, Professor. Thank you.
Well, thank you very much. Thanks for the invitation to speak here during this joint online meeting. It's a pleasure for me to be here. Thanks for the introduction. And as already said, my topic for today is modern management of spinal metastasis. So I'd like to give you an overview where we stand for the time being, what certain things, what happened in metastasis treatment for spinal metastasis, where we're going on. Now, these are there are no disclosures. First of all, talking about general spinal metastasis, it's a very common problem where we look at spinal tumors overall, and more than or about 97% is spinal metastasis. It's the most common malignant bone tumor. So this shows the relevance of spinal metastasis. And we have an increasing incidence. There's numbers given with an incidence from the 70s to now that there's a plus of 500%, but this is certainly due to better imaging, but also to the higher survival rates of patients with cancers. So there is this deeply increasing incidence and necessity to treat spinal metastasis. Where those metastases from? It's mostly breast, lung, and prostate. These are the most common tumors. Those three types of tumors are responsible for 60% of spinal mats. Below there in the diagram, you see that there's a bit of a difference whether you look at UK, mainland Europe, Asia, North America. This is due to the different incidences of cancer diseases, but still 60% of spinal mats is breast, lung, and prostate. And when we look at the whole of spinal mats, there's about 10 to 20% which do get an epidural symptomatic tumor, which means they do get potentially neurological deficits and need treatment for those neurological deficits and not only for instability. Location, most of the spinal mats are in the thoracic spine, 56%, lumbar spine, 30%, and cervical spine, 12%. And when we look in the location within the vertebral body, it's 85% of those spinal mats are in the anterior part of the vertebral body. And you get the typical image of those from anterior coming tumor parts compressing the spinal canal, leading to reduction of the cross-section of the spinal canal. Now, the clinical symptoms are quite clear. It's either pain, 90% is pain, mostly from instability, but it can be as well from the affection of local tissue from the dura. And then there's about 10 to 20% of patients with neurological deficits, which can have any degree of neurological deficits from sensory deficits to bladder, bowel dysfunction, or paresis, paraplegia of patients losing ambulation. And most of the studies differentiate two groups. These are ambulatory versus non-ambulatory patients. Now, the treatment options we have is different. We have best medical treatment, which is pain therapy, bisphosphonates, best supportive care, chemotherapy, targeted therapies, which are rapidly evolving for certain types of tumors. We have radiation therapies, different forms of radiation therapy, whether it's conventional external beam radiation therapy or stereotactic body radiation therapy. And we have different sorts of surgery coming from cement augmentation surgery to posterior stabilization, decompression, or complete 360-degree reconstruction of the spine. And the major question is, which type of treatment do we need for which patient, which is adequate for which survival time, general status of the patient, extent of instability, neurology. And there has been a very helpful framework published in 2013 by the New York group by Laufer, the so-called NORMS framework, which considers 4 factors for treatment decision-making for spinal mats. The first one is neurology, standing for the N. Then O is for oncology, well, that's a radio-sensitive or radio-resistant tumor. M is mechanical aspects, which is a stable or unstable spine. And S is systemic aspects, where the patient is able to tolerate surgery, unable to tolerate surgery, which means the general systemic disease status of the patient, including also the prognosis of the patient. And all these factors contribute to treatment decision, whether this is conservative only, whether this is surgical stabilization, separation surgery, and then some sort of external beam radiation therapy or stereotactic radiation therapy. And I'd like to go over those different aspects of the NORMS framework in my presentation. Now, looking at the first one, neurology, there's this one publication from Pachal, the Pachal study published in the early 2000s, which was a randomized controlled trial comparing surgery plus radiation therapy into radiation therapy alone for patients with spinal metastasis and neurological symptoms. And in this study, 50 patients were randomized per group. Then, after an interim analysis, the study was stopped because the surgical arm was so superior to the radiation-only arm that the study was stopped. And when looking at ambulation, recovery, and maintenance of ambulation, the surgical patients were superior to the radiation-only patients. And when looking at the 30-day mobility, there's not a big difference or not the expected higher mobility in the surgical arm than compared to the radiation arm. So surgical therapy from that time on was the #1 treatment here for a patient with neurological deficits. And this has been proven by several studies showing that surgery is superior to either maintain or recover neurological function. Just looking here at non-ambulatory patients versus return to ambulation. This is surgery plus radiation therapy, this radiation only. So you see surgery is superior to radiation only. This is paraplegia, return to ambulation, surgery is superior to the radiation only group. And when we look at pain relief, both treatments are equally effective. Now one major question is, what are the predictors of neurological outcome when we look at those patients with a neurological deficit from a spinal metastasis? And there has been several studies now collecting those typical predictors, and of course it's duration of symptoms, which means the earlier we treat those patients, the better. There's this question what the time window is, but there's we do not expect that there is a certain time window. There's a let's say a continuum of the earlier treated a neurological deficit, the better the outcome of those patients are. Severity, of course, makes a difference. The more severe a deficit is, the less likely the recovery of this patient is. Level and type of spinal cord compression, whether it's a cervical, thoracic, or lumbar level. Thoracic level is the worst chances of recovery from a spinal cord compression, and when you have a vertebral compression fracture in comparison to soft tissue spinal cord compression is worse, the prognosis is poorer, and aggressiveness of the tumor growth speed of this tumor does matter for the neurological outcome of those patients. So it means looking at the neurological deficits, what we need is a circumferential decompression, and this was what was asked for in the surgical group of the PET-CHALT study. It's not sufficient due to a posterior only laminectomy. It is necessary to do a laminectomy plus a pediculotomy to get a 360-degree decompression of the spinal cord in those patients which do have a neurological deficit from an epidural spinal cord compression from metastasis. So which means 360-degree decompression and early decompression as early as possible to restore neurological function of patients with a deficit. Looking at the second point, oncology. Does it make a difference whether it's a radiosensitive or radioresistant tumor? What means radiosensitivity versus radioresistancy? Radiosensitivity is a tumor which is sensitive to the standard external beam radiation therapy, which is 10 times 3 gray to a sum of 30 gray. And there are several of our standards tumor also already considered as a radioresistant tumor, which is lung and breast. They are intermediately radiosensitive tumors. Now, what has been invented in the last decade is stereotactic radiation therapy for spinal metastasis, and this is a game changer. As we see that stereotactic radiation therapy is so much superior to control tumor, to control progression-free survival of spinal metastasis in comparison to the standard external beam radiation therapy, even for those patients which do have very radioresistant tumors as renal cell carcinoma, thyroid carcinoma. So this has been a real change in the treatment modalities of spinal metastasis, the invention of stereotactic radiation therapy. But what we need for stereotactic radiation therapy is protection of the spinal cord, as this is a much higher radiation dose delivered potentially to the spinal cord if the spinal cord is included in the radiation field. And this is where the concept of separation surgery came up. When we have a patient which has an epidural spinal cord compression, contact of the tumor to the spinal cord, this needs to be removed, that we get a certain distance of tumor from the spinal cord in order to deliver this high dose stereotactic radiation therapy. And this is the concept of hybrid treatment of separation surgery plus stereotactic radiation therapy to have a very good local control rate, even for the radioresistant spinal cord metastasis or spinal metastasis. And this is what we need to achieve: posterior decompression and as well anterior decompression, anterior removal of the tumor from the spinal cord in order to get the spinal cord free and get the spinal cord away from the tumor away from the spinal cord. But there is, when we use stereotactic radiation therapy, a dose-dependent fracture risk, which in previous studies has been shown to be up to 40%, which is probably an overestimation. It's not as high as 40%, but stereotactic radiation therapy increases the fracture risk of those metastatic spinal tumors. So it means we need stabilization for those tumors in order to avoid a secondary fracture and a secondary necessary fracture correction. Now, how extensive should be the surgery prior to this stereotactic radiation therapy? Are there any predictors of the local control? And this is just a recent study looking at predictors of local control after SRS for spinal mats. They looked at radiosensitive indeterminate versus radiation-resistant tumors, found, of course, radiation-sensitive tumors are superior. They looked at whether the patient had previous radiation therapy or no previous radiation therapy. Of course, without a previous radiation therapy, superior resulted better control. And then they looked whether only an epidural anterior resection is sufficient, or whether an really anterior column debulking, getting more space from the spinal cord to the tumor, does make a difference. And they found that it's better to do a more extensive anterior resection and anterior reconstruction of the spine than just a resection of the epidural cord compression or epidural tumor. So we need more reconstruction of the anterior column in order to get a better control of the tumor, better local control in those patients. Looking at next point, mechanical situation, whether it's a stable or an unstable situation, we have this very nice SIN instability, spinal instability, neoplastic disease scoring system since 2010. It has been nicely assessed in several studies. We have those categories of 0 to 6 where the situation is stable, 7 to 12 we have an impending instability, and 13 to 18 is an unstable situation. So instability is quite clear. Impending instability is a bit unclear, as we do not know how many of those patients will get a fracture if they're not surgically stabilized. But how unstable are those situations, and do we can get a potential recalcification by radiation therapy only? This study looking at over 1,000 spinal mats, looking at different fractionation schemes, whether it's a low number of fractionations, below 10 fractionations of radiation versus more than 10 fraction of radiation therapy, and looking at the recalcification of spinal metastasis after 3 and 6 months. What we find, or what they found, is that there's only about a 30% recalcification of those spinal mats after radiation only, which means there is still a persisting potential fracture risk in those metastatic vertebral bodies, which are treated by radiation therapy only. So this means we potentially need, even for the intermediate SIN score patients, a stabilization of the spine in order to avoid secondary fractures. And this was a study published 2016 looking at different SIN scores, 3 to 12, looking at the intermediate group, 7 to 12, and identifying the fractures vertebral bodies here. When we look at the so-called stable group, there's a quite low number of secondary fractures after radiation therapy only. But when we look at the above 7 SIN scores, there is a quite high rate of symptomatic and asymptomatic spinal vertebral fractures in this group. So the intermediate group seems to be a group which has a high number of secondary symptomatic fractures. And other studies show that there's about a 33% conversion to surgery within 12 months in this SIN 7 to 12 group because there is some fractures. So it does make sense to stabilize those patients with intermediate instability or impending instabilities, as there is a quite high rate of potential fractures. Now, looking at the last point, systemic disease, what the prognosis of the patient is, that there's an ongoing continuous process regarding the prognosis of the patient. As we have more modern therapies, we have more targeted therapies. So those prognosis of the patient is changing faster with more modern therapies than we can assess it with scoring systems. It's the question how much of extent of spinal surgery is necessary or tolerated in those patients. Do we have a necessity of reconstruction and fusion? Which are long-term survivals? In which patients do we only need surgical symptom palliation, which have a small or short life expectancy? And what the urgency of systemic tumor treatment is? These are all the factors which are or influence our decision-making in surgical treatment of spinal metastasis. Finally, the question whether the patient is able to undergo surgery. There are many of those scores which is a problem, as those scores not really predict survival of those patients anymore, as we have so many different therapies and so many different situations in patients. And another problem is that we have missing information in the emergency situation. If we get a patient on an emergency basis with a neurological deficit from a spinal met, we don't have all this information. And therefore, there's one very short score, the Oswestry Spinal Risk Index, which does include just the knowledge of the primary tumor, whether we have a slow growth, moderate growth, or fast growth, or very fast growth, and the general condition of the patient looking at KPS. And this is a quite good scores for a very short evaluation during emergency situations, assessing the patient's prognosis, the patient's survival after surgery. We evaluated this course and showed that this is quite reliable for emergency decision-making for patients with spinal metastasis. Now, finally, looking at surgical treatment, with different options of surgical treatment, when looking at the different situation of spinal metastasis, whether we have a neurodeficit where we need decompression, potential instrumentation, when we have an epidural tumor without neurodeficit, but we might need separation surgery for stereotactic radiation therapy plus instrumentation, whether it's instability only with an instrumentation, minor instability where we can treat with cement augmentation, or pain, which we can treat with cement augmentation or radiofrequency treatment. But mostly it's what we usually use of this posterior instrumentation with circumferential decompression. This is the most commonly performed surgical treatment for patients with spinal metastasis. Now, how should we change this? And there's one other very important point, is we should go minimal invasive. These patients benefit the most from minimal invasive therapy in all spine patients. These patients have the necessity to go on to radiation therapy and chemotherapy quite early to get their treatment for the systemic tumor disease, and they don't have time for any wound healing problem or any secondary surgery. And this is where the benefits of MIS lie in patients with spinal metastasis. And there's quite good data showing that blood loss is significantly reduced, that the risk of transfusion is reduced, that the duration of hospitalization complications are reduced, and all this without any difference in functional outcome and pain for those patients with spinal mets. So MIS, going for minimal invasive procedures, is very important in those spinal metastatic disease patients. And the last point, looking at implants to use in spinal oncology, our standard implant, our titanium alloy implant, but we do know there's a lot of imaging artifacts from the titanium implants which hamper planning and execution of radiation therapy, oncological follow-up, oncological imaging follow-up for those patients on the stabilized segments, and complication management when we're searching for hemorrhage or infection. It's hard to pick those up in postoperative imaging with titanium alloy implants. But nowadays we do have other implants which are carbon fiber reinforced PEEK implants, which do not show these imaging artifacts we have with titanium alloy implants. And you see this here. This is a comparison of a titanium alloy screw with its carbon fiber reinforced PEEK screws on the left side, where you see no imaging artifacts. And we compared this in a group of patients, evaluating the artifacts from those PEEK implants, where the artifacts are much reduced in comparison to standard titanium alloy screws. And the advantage we get from this is that we can have postoperative imaging to pick up complications, to have follow-up, and there's a big advantage for radiation therapy, as intensity planning is superior to the standard planning with artifacts in the imaging. We don't get absorption, photon absorption, or particle absorption by metal implants in comparison to those PEEK implants, where radiation therapy can be better guided and more effective than with titanium alloy implants. So in summary, for spinal metastatic disease, nowadays we use decision-making according to the NOMS criteria. There is an advantage of circumferential decompression in patients with neurological deficits, as this circumferential decompression does improve neurological deficits better than radiation only. We use the SIN score to assess stability. We have the stereotactic radiation therapy which has much better tumor control even for the radioresistant tumors. But when using those stereotactic radiation therapy, we need separation surgery in order to get the tumor away from the spinal cord. And finally, we have radiolucent implants to improve radiation therapy planning and execution. Thank you very much.
Thank you. Thank you for the excellent and comprehensive lecture on spine metastasis. Now we open the floor for questions. Yes, Dr. Hari, you may ask.
Thank you, Professor, for the lecture. Yeah, I would like to ask you about the stability of the radiolucent implant. Is it both the same? Is it compared to the titanium implants? Are they same?
Well, what we do have for the carbon fiber reinforced PEEK implants, we do know from mechanical biomechanical studies that they are the same. The stiffness of the carbon implants is superior to the titanium alloy implants, and there is no material fatigue in comparison to titanium alloy implants. So for regarding inpatient data, there's very few data out now showing that there seems not to be a real difference and not a stability problem. We're just currently looking at our own patients during the follow-up, whether we had any secondary problems or any secondary implant-related problems in our cohort of patients which we treated with radiolucent implants. But for the time being, there's no hint that this might be any problem.
Yeah, thank you. Thank you, Professor.
Sam?
Thank you. Very interesting talk. I would like to ask about kyphoplasty and vertebroplasty, since nowadays that minimally invasive surgery is catching up. So when would you propose that we do this instead of the usual fixation? Thank you.
Well, I do only see a very small role of cement augmentation for those patients with spinal metastatic disease. These are only patients which do have a let's say a pain symptom from an otherwise remained box of cortical bone of a vertebral body. My usual treatment for any unstable spinal mat is to place posterior instrumentation, at least in order to improve stability of this. Only for a really small subset of patients which do have maintained borders of the vertebral body, then I would go for cement augmentation.
Okay, thank you. Thank you.
I think there is a question also in the chat box. Probably we ask a professor to answer it later by typing in the answer, Professor.
Yeah, I have to read it.
Yeah, sure. So we carry on with the next session. Thank you a lot. Thank you very much, Professor Ringer, for the lecture and discussion. We will move on to the next lecture. This lecture is by Professor Dong Dai Ha, Associate Professor and Vice Chief of Neurosurgery, Department of Việt University Hospital, Hanoi Medical University, Vietnam. And he will present to us on surgical outcome of endoscopic assisted microvascular decompression for trigeminal neuralgia and hemifacial spasm. Professor, the floor is yours, Professor.
Dear Chairman and colleagues, today I would like to express my special thanks for all of you to allowing me to be here today to participate the ACNS and EANS African and Vietnam webinar 2023, and it's my great honor to present my talk about the endoscopic assisted MVD for trigeminal neuralgia and for hemifacial spasm. Can you see my presentation?
Yes, yes. Please go ahead.
Okay, thank you very much. Firstly, I would like to talk to you about Vietnam. It's a beautiful country with the mountain north, from mountain north to the center and to the south of Mekong Delta River. I think Professor Kato know very well about it. And secondly, I would like to present about the oldest medical university of Vietnam with 120 years of long history. It's my university is Hanoi Medical University. For my presentation today, I would like to have some introduction about the neurovascular compression. And according from several papers, the incidence with the population in Vietnam is up to is about with the 90 million population. We have about 3,600 patients of trigeminal neuralgia and about 700 hemifacial neuralgia, hemifacial spasm. For the trigeminal neuralgia, all of you know that it's a trigeminal nerve compression is one side of the face, and the treatment option is about medical treatment with carbamazepine, gabapentin. But the surgery is always the solution, the choice with in the case of the refractory cases, and it's a side effect of the medication. And the radiosurgery is good. Radio frequency is good for the patient, but it's a destructive option. And let me show you some symptoms of the hemifacial neuralgia. It's the sudden severe facial pain, and the pain like a sharp shooting or like electric shock. And all the patients come with a complaint about the pain. And the hemifacial spasm is the same thing, but just the compression, the conflict with the facial nerve. And I think all of you agree with the hemifacial spasm is a surgical condition, surgical choice. And you can see if the contraction often start in the eyelid, then may progress with the effect of the cheek and the mouth of the same side on the face. And the patient come with us with always is a young lady, and it's very hard to communicate because they are very shy about it. And let me talk a few points of anatomy. It's a difference between the cranial nerves 5 and 7 at the exit point from the brainstem. The 7 nerve do not have the myelin sheath. So if the cause of the syndrome is from the road entry zone. And I show you some picture from Tetsuo Kano book about the microvascular decompression. Is for hemifacial spasm and trigeminal neuralgia, and you can see the conflicts away from the road exit zone. And some literature review paper in the world about the endoscopic and microscopic in MVD. And you can see now more and more endoscopic assisted and endoscopic and fully endoscopic for the MVD. For the patient positioning, I would like to talk about the technique and the step-by-step of the surgery for the quick review. And for the patient positioning, we prefer the patch belch position. For the skin incision, it's a linear incision, the C shape, the lazy S, and the curvilinear. And we always choose with the MVD, we usually use the linear incision for the mini open. And it's a Fukushima manual of the skull-base dissection. And we do the same thing with the three cut of the first cut along the superior neutral line, and the second cut is along the mastoid bone and the digastric groove, and the third cut is along the margin of the skin incision. The craniotomy, we do the burr and we do the drill. Okay, and it's depend on for the keyhole craniotomy, it's depend on the purpose of your craniotomy. You can go by superior approach, central approach, and inferior approaches. And for the extent of the for the craniotomy and dissection, we do for the extent of the arachnoid dissection, and you can see the dura, open the dura and the magna cistern. I will show it quick. For the, you can do the cutting arachnoid membrane to open the magna cistern and suction the CSF to relax the brain. And now we do the arachnoid magna from the magna cistern. After that, we the dissection of arachnoid membrane. From the inferior, from the cranial nerve, 9, 10, from the pica to superior. For the next step, for the endoscopic assisted, because of the position of the cranial nerve, 5, facial nerve, and 7, it's very deep into the cerebellum pointing angle. Sometimes the view of the microscope may be difficult and it's hard to identify the conflict. So the endoscopic assisted is very useful to identify the true microvascular compression. And now is the closure. We do the closure with the dural closure, replace the bone, close the muscle and the fascia layer by layer, and close the skin very carefully. And now let me show you few cases. The first case is the hemifacial spasm, and we do first by the microscope, and we can see the big vertebral artery, the conflict with the 7th nerve, but we can see more clearly between by the endoscope, and we can I can show you with the endoscope with the 30-degree angle endoscope. We can see very clearly laterally. Okay, you can see, and we can put the part, okay, and the patient with the post-operation very happy. The second case for the hemifacial spasm with the 46-year-old female with the hemifacial spasm for more than 5 years and resistant to botulinum toxin injection. And you can see with the endoscopic, we can see very clearly the ICAR. The ICAR go between the 7 and the 8 at the road entry zone. Okay, and by endoscope, we can do the MVD to separate the vascular with the 7th nerve. The third case is you can see by the microscope, you can see is the bone eminence, and that block the surgical view so the vision of the microscope is difficult to identify the nerve, and we need to retract more the brain. That's why with the endoscope 30-degree, we can do it easier and clearly to see the conflict, and we can do it easier. The fourth case is the trigeminal neuralgia. It's the same thing. With the microscope, we have some difficulty to see because it's a very low from the road exit zone. And with the microscope assisted, you can see easier and more clearly with the loop of the, you can see here. Sorry. Okay, you can see group of the SCA. Okay. Thank you very much for your attention about, and I would like to say thank you a lot for Professor Yoko Kato for organizing such a wonderful webinar today. Thank you very much.
Thank you, Professor Ha. There's a question from Professor Dishot. You may ask your question now, Prof.
Hello.
Atik, please. Dishot?
Yeah. Hello.
Hello.
Sorry, I cannot hear you.
Can you hear me? I'm Dr. Atik. Can you hear me?
Okay, I hear you now. Okay, please.
Okay, Professor, thank you very much for your presentation. I have a few small questions. First question, what is the size of your craniotomy for this endoscope assisted microscopic technique? Size of craniotomy?
Okay, thank you very much for your question. The size for the craniotomy, now we do the keyhole. That means the side craniotomy is small. We just drill, and the side we just do one burr hole. After that we drill, and about the diameter of the burr hole is about 2 centimeter, 2.5 centimeter for the craniotomy.
Okay. Second question is sometimes the transverse sigmoid junction is variable. It does not always coincide with the asterion. What is the key, what is the technique of your landing? Do you use neuronavigation or some kind of software like Amida, or how do you do the perfect bar hole? Just inframedial to asterion?
Yeah, I think it's to identify the asterion and superior neutrali is very important. And sometimes we do the CT scan, the MSCT to see the vein, to see the sinus, to be sure about to do the craniotomy.
Okay. Third question is, what do you do mainly? Transposition, interposition, and what element do we use to do transposition or interposition?
Sorry, transposition and interposition. We do the
offending vessel.
That means the, how can I say, the
offending vessel. For offending vessel, you do interposition, transposition, and what is your technique to do this? There are some offending vessels in hemifacial spasm or trigeminal neuralgia, right? Can you hear me?
Sorry, I don't understand your question. Can you repeat it again slowly?
My question is, for hemifacial spasm, the usual offending vessel is ICA, right? hemifacial spasm.
The ICA, you mean the ICA?
Yeah.
You mean
Or sometimes
artery?
maybe after mobilizing the vessel, how do you fix it? Do you mainly do interposition or?
I get your questions. Yeah, okay. Normally, I don't, for some time, for the big artery, like the vertebral artery, we need to, you cannot move the artery. You have to put the how can I say, the cottonoid between the vascular, the artery, then neural patch, and you put the neural patch with the cottonoid to put it separated, but you cannot move a big artery.
You do interposition, right? Mainly.
Yeah.
Yeah. Okay. Thank you.
Dr. Karimov.
Thank you, Professor. Can you hear me?
Yeah.
Yes. Thank you, Professor, for your lecture. And my question is, in one of your slides, you have shown the positions, the points where you are doing craniotomy. For example, superior, medial, inferior, right?
Yeah.
And what's the indications for inferior and middle craniotomies?
Thank you very much. In my opinion, it's inferior and middle and superior. It depends on your location. For example, for trigeminal neuralgia, we go superior, and for the hemifacial spasm, you go for the middle, and for some lesion from the for the 9, for the 10, for the 11, we go more lower. It's up to you, and you can go and you know before that what you do for each lesion.
Thank you so much.
Last question, Professor Dishot.
Yes. Am I audible now?
Yes.
Yes, Prof.
Thank you. Thank you, Professor, for your nice lecture. In some cases, after microvascular decompression of facial nerve for hemifacial spasms, we have a statistics of some facial nerve palsies. Actually, even after like 5 or 7 days, or maybe more, like 10 days, some of our patients had this kind of complication, despite that the surgery were conducted with no complications. After surgery, patients had fully recovered from the facial spasms. And these kind of late complications, do you have such experience in your series, and what do you think about what is that related to?
Okay, thank you very much for your question. It's a very good question. We have the same situation like you, and that's why I think the endoscopic assisted is very important, because the 7th nerve is always behind the 8th nerve. That's why for some time with microscope it's very difficult to identify the conflict. That's why you have to move out the nerve, and for the facial nerve, when you touch the facial nerve, it's always have the complication, even if the temporary complication, that for the palsy, temporary palsy. But I find that with the endoscope, we can see more clear and easier to identify the conflict, and that's why we reduce our complication about it. I mean, you can see more clearly, and you can do it quick and less complication.
So the tip is not to touch the facial nerve. Yeah.
Yeah, it's a less touch for the facial nerve. Yeah.
Thank you so much.
Thank you.
You're
Thank
welcome.
you, Professor Dishot, and thank you, Professor Ha, for the nice lecture. And just to remind you, Prof, there's one more question in the chat box. You can type in your answer, Professor. You may read it. So we move on to the next lecture by Professor Ngo Man Hong, a professor of Center of Neurosurgery, Win Duc Hospital, Hanoi, Vietnam. A professor will be presenting to us on large or giant cerebral aneurysmal treatment in the limited resource country. Professor, the floor is yours. Professor Ngo Man Hong, you were there just now. Professor, are you still there? I think meanwhile, we may move to the next lecture first while waiting for Professor Hong. May I call upon Professor Tra Tang Hong, Head of Neurosurgery Department of Da Nang Hospital, Da Nang City, Vietnam. Are you here, Professor? Yes, thank you.
Yes.
Yeah, Professor will be presenting to us on anterior intermesuric transcallosal transchoroidal approach to the third ventricle. Professor, you may start your lecture. Professor, thank you.
Yes. Sorry. So far about I would like to thank you, Dr. Professor Kato and Professor He, give me an invitation. So I have an opportunity to share with you what we do in Da Nang Hospital in Vietnam now, and now I share my screen. Sorry. Okay, you can see my PowerPoint.
Yes, Professor.
Okay. Today I present a very classic topic. This is anterior and hemispheric transchoroidal and transchoroidal obstruct to the third ventricle. All of you know that although the intraventricular surgery now is safer and less invasive as a result of the modern technology, advanced in imaging, improving the microsurgical technique, and more of the neurosurgeon now familiar with the complex obstruct, but the intraventricular surgery, and especially in the third ventricle, remain is a major challenge in the surgical field. In terms of the brief history of the intraventricular surgery, then we want to consider as the father of the ventricle surgery, and he has a great vision about the neuroendoscopy. And you know that ventricle surgery now has performed entirely with the endoscope has become a reality. But today I only talk about the microsurgery in the intraventricular surgery and in the third ventricle. You know that the third ventricle is surrounded by many vital neurostructures, and understanding anatomy of this area is mandatory for anyone if you want to perform the surgery in this area. Using anterior intermediary transchoroidal obstruct to assess the third ventricle, we have a two-path, very long, to pass through a very long and narrow corridor from the superior to the deep, including the superior segmental sinus. Sometimes the cortical vein can obstruct our access, force cingulate garrot here, and a corpusculum and pericordial artery. And you can see here the anatomy of the third ventricle. And transchoroidal and transchoroidal obstructs is the way we get into the third ventricle through the roof of the third ventricle. And the roof of the third ventricle here we can see after we get into the body of the left ventricle and we get in the roof of the third ventricle is a complete structure. It's composed of 5 distinct layers, from a deep to superficial. They include the choroid flesher layer, the inferior layer of the thalachoroid, the vascular layer or velum interpositum, the superior layer of thalachoroid, and the last is the phonic layer. In the vascular layer here, we can see the very important structure like the ICV, internal cerebral vein, and medial posterior coronary artery. And before the surgery and during surgery, we have to recognize the vascular before we remove a tumor. And nowadays, the understanding of subcortical weather is very important. Based on the MRI DTI, understanding of arrangement of the body matter tract and their interaction with the parenchymal and or interventricular lesion might have to urge to guide the surgical approach, and the neurosurgeon might tailor the approach to the lesion so as to cause minimize damage to the peri-lesion white matter, and while maximizing the attention of resection tumor. Tumor in the third ventricle account for about 2% of the on intracranial tumor, and most of them is benign and slow growing. There is 2 main categories based on their origin, and the first one is primary and the second one is secondary. The understanding of the origin of the tumor had important diagnostic and surgical implication. In the tumor in the third ventricle, we recognize the various type of tumor. For example, the more common is the astrocytoma, the granulocytoma, and cholestasis, dermolysis, and the ependymoma. The common lesion of the patient with the tumor in the third ventricle is the headache, fatigue, visual disturbance, changing in your personality, and cognitive deficits. The symptom divide into 2 types. The symptom caused by the hyper intracranial fracture, and the symptom caused by the compressive or destroy of the adjacent tumor by structure by tumor in the ventricle. You know that the MRI now is the gold standard imaging for the diagnosis. But with the tumor in the third ventricle, before the surgery, we have performed the angiogram, especially the MRI or MRI, especially the MAV and the CTV is very helpful, and with help to choose the appropriate approach. This picture is a result of the anatomy study in a long time ago, but it's very useful. This study showed that the junction of the anterior septal vein and ICV is the truth of the posterior margin of the foramen of Monroe, and the research showed that in the most of case, 80% of cases, the ICV and ISV and ICV junction localized usually about 6 millimeter posterior the Monroe. Foramen of Monroe border. It means that we can open the foramen of Monroe posteriorly without sacrificing any structure, including the anterior septal vein. However, for complete lesion, tumor involve the middle and posterior region of the third ventricle, sacrifice of the septal, helping it easier to widen the foramen of Monroe and open gap of the coronary flexure. And thereby we can safely resolving the lesion. In our case, we usually do that. We usually sacrifice the septal vein in a nearly all of cases. Here, the picture repeat the common tumor localization in the third ventricle. The tumor at the position region A and C, it means around the foramen of Monroe, and the posterior of the third ventricle, and both can resolve when resolved by the interhemispheric trancorazole and trancoral approach. But the tumor in the B position here, even in the pole, anterior pole of the third ventricle, we cannot result it with the anterior truncal uprock. In this tumor, we can do another uprock like laminar terminalis. To prepare patient before the surgery in the truncal and truncal uprock, I prefer the patient in the supine position with the head rotation, turn on the one side, and next he apply in the slightly flexion like this in about 45 degrees, so that you can see the sagittal, superior sagittal sinus parallel with the ground, and to allow the ground for the gravity rejection of the ipsilateral when the ipsilateral when the rough from the force, and MRI data for neural navigation should be available in on case. The picture saw the classic anterior anti-hemispheric truncal uprock. It's a classic. It's the craniotomy and colostomy and direction of to get the third ventricle around the coronal suture, but depend on the location of the tumor inside the third ventricle, we can changing the play of craniotomy and play of the colostomy, and changing the direction of view from the posterior to anterior, or from the anterior to the posterior to optimize the uprock. So with the help of the neural navigation system, choosing the optimal position of the window become easier. So after we get into the body of the lateral ventricle, there is a four main route to assess the third ventricle. After, and you can see here, the first one is foraminal uprock, the second one is the subcoronal uprock, and third, the truncal uprock, and the last is the inferior uprock. Based on anatomy of the group of the third ventricle, the tenor phonesis between the space between the phonic and the color plexus do not have any vascular structure indexation, so we can safely open third ventricle by this way. This is the truncal uprock. The subcoronal uprock, you can see here. You can see the subcoronal uprock. It's also the uprock through the corridor plexus gap, but its uprock is more laterally, and it passed through the corridor tenor. And there is the very important vascular structure, like I mentioned about the ICV and posterior medial arachnoid artery. So we get by this quite subcoronal uprock, maybe we fail to the risk to damage the very important structure of vascular. This tab summarize the advantage and disadvantage of each uprock. Now I will talk in more detail about the two more commonly used of the four uprock to the third ventricle is the transforaminal and transcoronal uprock. The first one is transforaminal. This advantage for the widen in each case the foramen abnormal is widened already by the tumor, and in case the tumor in the roof of the third ventricle and the tumor easy to the poking or easy to penetration like colorectal. But in many cases we need to open the tending foramen of Monroe posteriorly. Two ways to do that. The first in the sacrifice of the anterior septal band, and in complex in case with the complex lesion, we have to change to the truncal uprock. In this situation, we can say foraminal uprock is the first step of the truncal uprock. Here I can show you the case, the man 60-year-old come with headache, vomiting, blurred vision. On MRI, you can see here is identified the tumor location in the third ventricle around the foramen of Monroe. and it would be the craniopharyngioma. We perform this choroidal opera. Here you can see we get the choroidotomy, get in the left ventricle, identify the growth pressure and dissection and coagulate and cutting of septal vein. And we open the portally of the foramen mammary. You can see the tumor here. We dissect around and get tumor P by P, and tumor totally removed. The patient is recovering well after surgery. The second opera, we will say the tongue corridor opera, that described by Nagata a long time ago, and then use the corridor fissure at the natural route to enter the third ventricle. And after we dissect, we have a space from the posterior border of the fornix, columnar fornix, and reach to the anterior pineal gland. Here is the picture we show you again. Indeed, in the left is the before resection, and on the right, and after resection, you can see we can get a big space from here to the posterior of the third ventricle. We can see one of the structure in around here, like the venous angle here. We can see the ICV on both sides. We can see the floor of the fourth ventricle. The opera also have a limitation. The coronal fissure open posterior just about 1.5 centimeter, because in the posterior, the widening of the fornix in the posterior channel, we cannot open more. And the second is the anterior limitation of the opera is the columnar fornix. The second case will show you the patient, the male, 62-year-old, he come with headache, mild weakness on the right side, memory loss, and difficult to walk. On MRI, we identify the lesion. It's glioma on the thalamus on the left side. It's a protrusion into the third ventricle. And this patient, we perform the surgery using the tongue interior interventory and tongue corridor opera. You can see that with the position I talk about, the brand tissue and the raw from the floor here, and we use the navigation system to choose the optimal direction to perform the choroidotomy. And we do about 2 centimeters of choroidotomy, and we get inside the lateral ventricle. And here we dissect tena, fornix, and coagulate and cut anterior septal vein. And next, we open the choroid fissure from the anterior to posterior and get inside the cavity of the third ventricle. Here you can see the tumor here. And again, we use navigation. And also we use AOM during the surgery. You can see the tumor is soft and not bleeding tumor. The tumor removed by piece. You know that in the neural corridor, like in the third ventricle, dynamic retraction, we use the suction and the bipolar tip at the retraction, very useful. It gives us enough space, enough light to manipulate and help to prevent the complication of the over retraction. And you know, like when we resolve the retraction, when you evoke enough, with the gravity effect, the tumor roll into the surgical field and help us to remove the tumor easily without over retraction. And in this case, we don't try to remove all of the tumor. And again, the navigation system help us prevent the loss of orientation during the surgery. And yeah, here the image in the CT scan of the patient put up, the patient stable, about up, and no new neurological disease appear. Particularly in diffuse gradual glioma, the patient have adjunct therapy with radiotherapy. And another another tool of rock we can use in the third vertical is superarachnoid of rock and junction. But we can combine the of rock in the same operation to increase the efficiency and safety and reduce the complication. In our case, in 3 years we had 25 cases, and more patients with the present with the symptom of the increase in the integral cranial pressure, and more common pathology we get is astrocytoma and craniopharyngioma, and sometimes carcinoma and ependyma also had recognized. And nearly total rejection tumor is just only in 50% of cases. About complication, we recognize almost all of the complication had destroyed on the literature, but luckily it's more the patient is recovery very well in post-op, especially the cognitive deficit, they recovery very good. And but the problem is we have, how we mentioned here, in our condition in the post-op infection, we have the patient death because the post-op infection because of meningitis and ventricular. The patient stay in a long time in the hospital with a lot of antibiotic, and after that the patient died. In conclusion, with our experience, I would say that anterior interhemispheric transcortical rock is the suitable asset to the foramen of Monroe, middle and posterior thirds of the third ventricle. And pre-operative planning is crucial for complications, and dynamic resection significantly reduce the risk for the cortical ischemia and venous infection. Sorry. Thank you for your listening.
Thank you, Professor, for a very nice lecture on the approach to the third ventricle. Because we are 2 hours behind time, I only can allow one question. If there's any question from Professor Tra. Yes, Dr. Atik, do you want to ask a question?
Yeah, one simple question. While you do surgery through transcortical approach, do you face any difficulties to preserve the fornix, or any patient you have that had fornicial injury?
Yes, we have, but in more of case we just go in several case we have injury of fornix just in one side, and the cognitive deficit is slightly, and then the patient the recovery well in the long term follow-up. Yeah.
Thank you.
Thank you for the question, and thank you, Professor Tra, for a very nice lecture. I apologize to Professor Ngo. Actually, you were there just now. So we introduce again Professor Ngo, Ngan Hong, Professor of Center of Neurosurgery, Việt Nam Hospital, Hanoi, Vietnam, who present to us on a large or giant cerebral aneurysm treatment in the limited resource country. Professor, please start your lecture.
Thank you, Professor Yoko Kato, for giving me a chance to present my experience about the treatment of the LAS and ZIANS and ACNS-EANS-North in Vietnam. Can I show my?
Yes, please, Prof. Share your screen.
Everyone, how can I show my?
You can see a green button. Yes.
Okay.
Yes, you can
everyone,
see a screen.
yeah. Okay. So as we know, the LAS and ZIANS and ACNS-EANS-North in definition has from 14 to 24 millimeter in diameter. The LAS and the ZIANS is though is larger than 25 millimeter in diameter. The large and giant cerebral aneurysm account for 5 to 10% of cerebral aneurysm, and the aneurysm, the large and giant aneurysm appears mostly in 40 and 70 years old, but it's occurred for any age, and predominance in female, and in children, giant aneurysm, cerebral aneurysm more frequent than adults. In natural history, depend on this study, 66% of non-treatment of giant aneurysm will die up to 2 years of follow-up, and 18 died in 5 years. If the aneurysm in the posterior circulation, one person under the death in 5 years. So the risk of rupture, the incidence of the risk of rupture is not we don't know clearly, but it was estimated from the 25 to 79%. It depends on the location of aneurysm. It depends on the international study of rupture intracranial aneurysm. The location of aneurysm will demonstrate a risk factor from that. So diagnosis of giant aneurysm and large aneurysm depend based on the DSA. It remains a gold standard, but nowadays CPA and MRA have an increasing role in with more accurate the treatment of large and giant aneurysm based on the endovascular microscopy, microsurgery, and combined endovascular and microscopic surgery. So in Vietnam, as well as I think as well as the low and middle income country, we additionally has a more difficult. Firstly, its cost. Stent and coil are still expensive for almost people in Vietnam. Nowadays, in my country, national health insurance covers more than 18% of population, but the patient has to pay about a finance in hospital. Even that, some people cannot pay for it. The second difficulty in our country is the available of material. We have to import the stent and coil, and sometimes they are not available in stock. We have less option in emergency situation. In patients who did not have option of endovascular therapy, the traditional approach remains the rules. We could take some option like reconstructive club, chopping the aneurysm with ECIC bypass, and combined with endovascular therapy. It means ECIC bypass surgery in the first time, and second time the parents artery occlusion or aneurysm occlusion with endovascular. It's less, it's cheaper than pure endovascular. So I have two example. The case one is there was a 35 years old Highland man. He had a sudden onset of headache and nose vomiting. 3 days after, he had the other episode of headache. So he come to my hospital with a neurological intact and a CT scan, which showed the subarachnoid hemorrhage, and we take the CTA, which show the large and fusiform large of MCA aneurysm. We take the DSA also, and the patient who planned treatment with STA-MCA bypass and clip and chopping aneurysm. So it's my video. So we take the frontal temporal incision, and I dissect and explode the STA, both the frontal and parietal branch of STA. After that, so I clip and remove, and I take the frontal temporal craniotomy, remove the phenolate with bone, and open the dura mater, and split the symbiophysum. After that, I dissect and expose the aneurysm. You can see here there is aneurysm, and continue dissector. I found there's one small brain come from the dome of aneurysm, and I dissect also two branches of M2 aneurysm M1. And I can find you can see that. After that, I take the N2 side anastomosis from the STA to MCA with interactive suture. To ensure if I can sacrifice the vessel from the dome of aneurysm. So in the difficult side, I take the difficult side first, and the easier side after that, I remove the temporal cleft. We don't have ICG angiography, so I just make sure by remove a clip. After that, I take the temporal clip on the M1 and take two clips to reconstructive the aneurysm and vessel. So I have to accept some residual aneurysm here, and there is one small brain with thrombosis. So I have to sacrifice. Continue this section. I found there are two small branch come from the dome of the aneurysm. So firstly, I would like to take the second anastomosis from the STA to this. So I take the clip here, cut up the aneurysm, and after that, I try to remove the clip and found their retrograde from the anastomosis. So I don't think it's necessary to take the second one anastomosis of STA-MCA. I control all of M2 to make sure. and indurate the blood. And there is my schema to reconstructed clip for the aneurysm and M1 and M2, M2, and anatomically from the STA to small branch come from the dome of aneurysm and take the clip here to continue the flow of anatomically bypass. And the patient has no neurologic deficit after operation. The CTA post-op show the good patency of bypass, and the patient has no neurologic deficit. And the case there was a 56-year-old female with mild subacute headache. She came from the peripheral hospital with MRI, showed multiple intracranial aneurysm. So the MRI showed the large ICA aneurysm in the cavernous sinus. So she came from my hospital. We take the DSA and show which show the small ICA aneurysm on the right side and the large cavernous sinus segment of ICA on the left, and we found also the small MCA on the left side. To prepare the bypass surgery, we take the balance occlusive test, and the patient tolerate BOT for in 30 minutes. And when we retract the catheter, unfortunately, the balloon detached. After that, we have to follow up the patient in the sign of intervention of DSA for 1 and half hour more. The patient has no neurologic deficit. After that, we take the second one balloon in the petrosal segment of ICA to make sure there is not flow from the ICA to the brain. And we take also the external internal carotid for bypass if necessary. And after that, the patient come back to work after procedure. 1 hour and 1.5 hours after, she developed left MCA syndrome. We decided emergency surgery. So we prepare the STA and craniotomy. After that, we split the fissure, symbiote fissure, and expose and clip the MCA aneurysm. And after that, we prepare STA 2M2 and take double barrel STA MCA bypass with interrupted suture. The same way, the same technique I learned from the Sapporo Tessinkai Hospital from the Dr. Professor Tanikawa from the Tessinkai Sapporo Hospital, and also the Dr. Professor Tazikawa in Ashikawa Cross Hospital. Congress Hospital. Always in the difficult side and after easier side, and remove the temporal plate. Post-op, the patient has the gastrocomal scale 14 in day 1, recovery her motor deficit in day 5, and year solution of her aphasia day 18. We take the CTA post-op. Unfortunately, I have one good patency bypass and not, and the other one is occlusion. And the perfusion CT 1 month after, which show normally. And follow up 6 months after, the patient has the MRS 0 with no aphasia and neurologic intact. So our result from the 2016 from the 2022, we have 25 large enzyme ICA aneurysm with treatment with microsurgery. We have 12 high flow bypass and sacrifice ICA. 8 of those we take the saphenous grafts, and 4 with radical artery graft. 12 patients with now flow bypass, we take double baron SK MCA for a bypass for the MCA aneurysm, and 1 reconstructive clip. And we have 1 bypass occlusion as the example, the case 2 I show you. So our experience, microsurgery remains a road in large enzyme ICA aneurysm in Vietnam, as well, I think, as well as in North and middle income country. And the decision of treatment is depend on the patient and patient. And the combined the strategy combined with endovascular will be reduce the cost of treatment, and it take the effective less. Thank you for attention.
So thank you, Professor, for the lecture. Can we have one question from the floor? Dr. Joe, Sam, please ask your question.
Fantastic case examples. Professor Ngo, did you use any intraoperative neuromonitoring during your procedures for the giant aneurysm?
Unfortunately, in my hospital, we don't have a monitoring. We don't have ICG video angiography like as well as Doppler. We don't have.
Fantastic result. Very good.
Thank you.
Thank you, Dr. Joe. Thank you, Professor Ngo, for the very nice and fascinating result from giant aneurysm. We will move on to the next lecture by Professor Trang Quang Nguyen, the head of neurosurgery ICU department, Chore Hospital, Ho Chi Minh City, Vietnam, and he will be presenting to us on the management of severe traumatic brain injury. Professor, please.
Okay, so thank you very much for. Okay, sorry, just a moment. Can you see the slide?
Yes, Professor.
Oh, thank you. Thank you. So thank you very much for organizing the seminars, especially I would like to thank you very much, the Professor Yoko Kato, GC, on had the time work and help us in our hospitals in Ho Chi Minh City. So now I have a great honor to present about the topic that is the management of the severe traumatic brain injury. So we know that the patient with the severe TBI is in the deep coma and usually associated with the other injuries. So the treatments must be initiated from the beginning. And during the treatment, so two factors are very important. It must be regularly considered is the respiration and circulation. Those ones affect very, very much about the mortality, also the morbidity of the severe TBI. We can see over here, like from the beginning, we have to start at the scene and during transportation, and then the patient moved to the ER and then ICU. This must be considered. And for management, so we had to follow the ABCD in principle. This one is very important. It will decrease the risk of overleaking injury, especially for trauma patient. You know, because some the severe TBI usually associated with some very severe injuries that even can cause a big problem. And all the patient that, so it must be managed in ICU. First, I would like to present about the AB. This means respiration. Oh, so it's not enough over here. A and B, this means respiration. So first, we had to secure the airway patency, and especially we had to check for the sign of tension, pneumothorax or pneumothorax tensions, and flow chest or cardio tamponade. Those one can affect a lot about the respiration of like concern with oxygen, carbon dioxide, and even it can cause a hypertension. So we have to maintain SpO2 over 90%, PeO2 over 70 millimeters of mercury, and especially carbon dioxide from 35 to 40. In some situation, we know that like severe TBI can cause a raised ICP. So in some situation like that, we have to do short-term ventilation to reduce the carbon dioxide, to try to reduce the ICP. But the important thing is very much be considered is to avoid cerebral ischemia. I'll detail later. And we can use the brain oxygenating monitoring like SpO2 or PbTO2 or near, just for doing the brain oxygen saturation. And also in A and B, so that is respiration, on the patient severe TBI, it must be intubed. And even the patient must be put in mechanical ventilations. And usually we use the different modes. AC, it means acid control, or SMV, or spontaneous. It depends on the condition of the patient. Or we can change from one to another, where it depends on condition of the patient. And even when we start weaning the ventilators. And during the ventilation, we had to regularly consider about the two factors, that is the resistance and the compliance of the ventilators. So it can give it a number over there, because the two factors can help it to recognize or to do evaluation the condition of the resistance of the airway, or as well the condition of the lungs. I think it's very important. So, and now we go to the next part is C. C is circulation. In some study, but I just saw one study in 2017 with the around 13,000 patients with severe TBI. Those patients if they had the hypotension, so mortality is around 20%. And if they have a hypoxemia only, this is around mortality to 28%. But if they have both hypotension and hypoxemia, the mortality is much higher. It's go up around 45%. But if the patient don't have any hypoxemia or hypotension, so only the 5.6% die. So we think that is a very important for the respiration and the circulation, that the affect a lot the mortality and morbidity. So usually we keep the blood pressures MAP from 80 to 90 and systolic blood pressure from 110 to 120, and maintain the patient in a volemia conditions. If the patient have the hypotension, so we can add the vasopressors or norepinephrine or dopamine. And the problem with the blood transfusion, we know that the severe TBI patient usually have anemia. So previously, the blood transfusion indicated if the patient have hemoglobin under 10 and hematocrit under 30%, but study recent guideline is show that because there are some complication in blood transfusion, so we show now we only do blood transfusion when the hemoglobin under 8 grams per deciliters and hematocrit under 25%. In case the patient have the evidence of cerebral ischemia, at that time the hemoglobin must be around 9. Now we go to the next is a D, that A, B, C, and then D. What we do for D? D, we do neuro exam, like consciousness, focal size, and if the patient have the size of the ICP increase or the size of cerebral herniation, or even we have ICP monitoring, it can show the value of the ICP. So clinically, if the patient have the consciousness decrease at least 2 points, or the pupil are dilated and are reactive to life, or the patient in condition of the disintegrate or decorticate. So in that we have to do as much possible to do to manage the ICP increase or even to do surgery. I will tell you later. And now we do the last part of ABCD is E is a poser. So mean we have to do a complete evaluation from the top to bottom, because we know that the severe TBI, like in our report, in our ICU, so many patients have another injury, especially cervical spine. Some studies shows the severe TBI patient have the 4 to 8% of the cervical spine injury, especially concerned with the motor vehicle accident, like in our country. So, and we had to check from the top to the bottom, and now look at the chest, especially concerned with like the flat chest, tension pneumothorax, cardiotamponade is a very, very important, and it's not very rare at all. Parallel organ fibrillation. So we have to check carefully, otherwise we can miss. And sometimes the patient have the big problem with the bone fractures, limb compartment syndrome. You know, the patient have the severe TBI. Sometimes only concentrate on the head injury. So we miss some cases, even like a compact lipid power syndrome or vessel injury. So that we can find out But if we miss some cases, some recovery of the brain, but the patient had a problem with the limb, even to have to do amputation, is very sorry about that. So beside of ABCD, I presented some specific TBI concern which must be considered, like the patient must be at the head in a position and elevated from 30-40 degree to help to reduce the ICP or even to prevent the pneumonia. Okay? And if the patient agitated or fighting ventilators, some increase of the ICP, we can sedate the patient even with neuromuscular blockade. And if the patient have some high risks of seizure like contusion, hematomas, or especially penetrating injury or like craniotomy, so that we have to use prophylactic anticonvulsant. And the next is the electrolyte. You know, in ICU, not very rare, the patient have electrolyte problem, especially hyponatremia. It most often is SI88 and cerebral wasting. So we often seen in our department, in our ICU. So in these cases, increase, we adjust the sodium so fast, it can cause a condition that we say myelinolysis. Like here, it's like that can call here in MRI, it can show here the Benson, the pulse with the osmotic demyelination. And here we can see here 2 telemides have the problem over here. So that's a myelinolysis because the adjust is not correctly of the condition of the hyponatremia. And another one is if the patient have the intracranial hypertension, it's often seen in severe TBI. You can find out for clinical side, or CT scan, or ICMD monitoring. So the last I just mentioned about how to manage the intracranial hypertensions. It's 7 steps. First, the head bed elevation. That is very, very common, right? And we can do sedation, and especially with high dose, it can help to reduce the metabolism of the whole body as well as the brain. It can also help to reduce the ICP. And it's lucky if the patient have the ventricular dilatation in head injury. Usually not so many, right? Not so many, but sometimes we can see it. So that we can do EVD to drain the CSF. The CSF when drained, it can help to reduce the ICP. And if it cannot control, we go to the 4th step. If we had to use the hyperosmotic action like mannitol or hypertonic sellings, okay? And even the next, if we cannot control, we come to the next part is a hyperventilation. But already mentioned before, is a hyperventilation is useful to reduce the carbon dioxide, to reduce the ICP, but be careful, it can cause ischemia. So it's best we can measure the brain oxygenation. It's useful and to adjust the level of the carbon dioxide. And now, if we can control, in some study, it can show some benefit of a hypothemia, but some complication associated. And finally, if all we go to step, and it cannot control the ICP, so we have to do a decompression, decompressive craniectomy. So that all the, maybe we can see in some patient with a high ICP in severe TBI. So conclusion, so we know that the severe TBI usually associate with the other injury. So we should follow the principle, the A, B, C, D, E, it is very important, especially for young neurosurgeon. When contact with the patient, when they see the patient in the ER or even on the way to the hospitals or at the scene as well. I think that's very, very important. Okay, so, and then it must be start from the beginning, not only in ICU, not only in the ER, but always it's from the scene. If we manage properly, so I think the mortality or the morbidity should be less. And we've had to remember two factors that affect very, very much about for the mortality and also morbidity of the severe TBI is respiration and circulation. So thank you very much. Thank you very much. Yeah.
Thank you. Thank you very much to Professor Trang for a great revision and important revision to all of us. So I can allow one question. Anybody want to ask question? Please proceed with the question.
Do I have a question?
Yeah, sure. Please,
yes.
Prof. Please.
Thank you so much for a very comprehensive lecture for management of severe TBI. I have a question. In some institutions, still there is a recommendation of extracerebral hypothermia.
Yes.
Do you have such experience, or what is your opinion about this?
Okay, thank you very much. That's also the problem many doctors ask me. So actually, I don't have much expression about that. We just did a few cases, but for the guideline, you know that usually we can reduce at the 34 or 35 degree. We show a very effective in the ICP. ICP reduced. But the problem when we warm up the patient, sometimes ICP goes up, and especially some complication with pneumonia, heart problem. So especially when we reduce the temperatures, the patient have shivering. So sometimes with the problem the ICP. I don't have much experience, but some study and some report also show that the problem. So, and then in some center they use that one, but some center they don't want to use that. Thank you very much.
Thank you so much.
Thank you.
Thank you, Professor Disha, for the question. So thank you, Professor Trang, for your great lecture. We will move on to the next lecture by Professor Nguyen Min Ah. He is the head of the Department of Neurosurgery, the University Medical Center at Ho Chi Minh City, Vietnam. And he will present to us on multimodality treatment of supratentorial arteriovenous malformation with microneurosurgical embolization, after embolization, sorry. Professor, please proceed with your lecture.
Thank you. Good evening, everybody. Can you hear me and can you see my slide?
Yes, Prof.
I would like to thank Professor Yoto Kato and Professor He invited me to join the ACNS webinar. I'm very happy and honored to be here and to have the lecture. My talk is the multimodality treatment of supratentorial IVM with microsurgery after embolization. Now, my talk include introduction, classification, and clinical presentation and treatment, and some slides say about the result at my center. We use the microsurgery after embolization for IVM treatment. In introduction, you know the IVM is the congenital vascular malformation, include the feeding artery, venous vein, and also the network vessel. A prevalent is general population around 50 to 18, 1 per 100,000. And incidental fry the 0.05 of the PNMRI and annual risk in account around 2 to 4%. And the most common cause is intracranial hemorrhage in young adults. And the treatment we have a lot of methods to treat the basin. Conservative management, microsurgery, the radiosurgery, and embolization, and we can combine all this technique. In the classical classification, based on the AVM, the Speller-Martin grade, it includes the 3 parts. The first, the Snyder side, and the venous. 1 point for the deep venous. For example, internal cerebral vein, present vein, placental cerebral veins, and the third one is the elegant injection of brain. 1 point for the AVM located the brainstem, thalamus, hypothalamus, cerebral pedicle, primary sensory motor language, and primary visual cortex. And how about the basin come to the hospital? The most of the basin come to the hospital have the health risk around the 38 to the 71 of the basin, and between the 20 to 40 year of age. And one important thing in the basin have the first health risk and the second health risk very high rate, around to 10 to 30 in the first year, and after that around the 4 to 10 the second year. And when the basin have the health rate, among of the basin around 20 to 30 have the neurologist morbidity and the mortality rate. Health rate around from the 10 to 40 is quite higher for the basin. And some of the basin come to the hospital because they have the symptom of seizure or headache. And some of the basin have the focal neurological deficit because the basin have the vascular still phenomenon due to the high shunting intra-AVM. It's around the 5 to the 15 of the basin. And the basin have the low CPF in surrounding the brain. That's the reason why we should do the selecting the basin for the treatment. And then finally, we make sure the basin have the AVM, the imaging. We use the CT or MRI, and the AVM located nearly the functional. You should do the functional MRI. And finally, we make definite diagnosis, that is the DSA, and have the planning for the basin treatment. We move to the treatment. When the Aruba study publication, the result of the study said that the increased rate of the complication in the treatment compared with medical management, so that asymptomatic the patient don't have the history hemorrhage. The patient some the symptom, for example, the seizure, headache, or hypertension, you should follow up and MRI scan annually or biannually. But now in the world, the neurosurgeon try to study more. And now, how can we decide for the patient? We divide to the AVM for two situations. The first one in the unrupture, and the second one in the rupture. And still now, unrupture, we can follow the Aruba and some other article I will present later. In the patient have the rupture AVM. Because the patient have the rupture AVM, you have the high rate mortality and mortality, so that you suit the treatment. And we show you the scheme you can follow up the AVM rupture. If the patient have the neurologic stable, we move to the patient neuro ICU and make sure the patient have the AVM by the DSA and try to find the aneurysm intranidal. If the patient have the aneurysm intranidal, you should do the treatment the aneurysm first, and after that we treat the AVM. If the patient don't have the aneurysm intranidal, we can do the treat AVMs sub-acute or the delayed fashion. If the patient have the AVM rupture, the patient have the neurological extremity, you should do the surgery emergency. If the big hemorrhage, you can do the decompression with the IVM recession. If the hemorrhage is so small, you can do the just recession IVM also. And how can we decide for the AVM? The total, we have the statutory, maybe the single or the multimodal therapy for the bone irradiation. As first, AVM characteristic. The second one is operator skill. And the third one is surgical or endovascular accessibility. We choose to evaluate venous strength, and you try to find some high-risk feature such as aneurysm intranidus of the AVM. And you should have the whole information about the whole technique. As first, we talk about the endovascular technique. You know, the fatality rate around 1 per 100% year, and the average rate is 1/7 per 100% year. Also, you had a permanent neurologic deficit or depth around 6.6%, and you know the result arbitration rate just around 15% overall. And that is the reason why the endovascular, you just reduce the size, and you have to plan for the next step for the AVM, for example, surgical or radiosurgical. If the patient have the AVM cannot curable, the endovascular have the palliative treatment for the seizure control, for the stabilization of the deficit. And how about the radiosurgery? You look is similar the result of the result complication, similar the embolization, but the obliteration rate so high. And we move to the surgical resection. And overall mortality rate around 3.3%, morbidity rate 8.6%, and increasing rate in increasing stellar marking, depending on the size of the AVM. And still now, we can, I show you the article from the Professor Michael Lawton. They said that a low rate AVM, and he said that after the Aruba study, the surgery should be regarded for gold standard therapy for the majority of the low rate AVM. And another one is low rate. Most of the doctor, most of the neurosurgeons agree the microsurgery remains highly effective for the low rate AVM. And how about the result of radiosurgery? You can see the result of radiosurgery very effective for the low rate AVM. So you should wonder about the surgery or radiosurgery. But radiosurgery focus on the AVM located in the deep location and deep venous strand, and unfavored for the surgery. And very big challenge in AVM treatment for the high-grade AVM. Until now, we don't have the guideline for the consensus on the neurosurgeon all over the world. Some of the doctors said that you should do the observation. Some of the doctors said that you study embolization plus microsurgery session. It is in my center to do that. And some of the center said that you should do the volume state surgery. And we move to the final part. I talk about the microsurgery after embolization in my center, because the role of the pre-op embolization and after that we do the surgery still now not well established and lack of clear evidence I mentioned before. So that the management in AVM, big AVM is challenging. So that's in my center, we use the pre-op of embolization for reducing inflow, the needed volume, eliminate of the deep filter, and treatment of the high-risk feature, intranidal aneurysm, high flow-son. And we enroll the patient, include the criteria, diagnosis AVM by DSA, and AVM located a supratentorial area, and AVM size more than 3 centimeters. and management by preoperative embolization at least 1, followed by surgery and able to follow up at least 3 months after discharge. And embolization technique, we use the ORNIS. Some case we use the fuel, some case we use the NBCA under the general anesthesia. And the aim of the embolization technique, we focus on the portion of the AVM that difficult to gain access surgical and high flow fistula and intranidal aneurysm, and direct fit the nidus with a maximum possible refer distance, and focus on the deep perforating supplier. And after that, we have we will do the surgery schedule 7 days after the last embolization, because that is to reduce the hemodynamic change. And the IVM surgical principle, right, craniotomy, arachnoid opening, ligation fitting artery, and one of thing when the patient have the embolization before surgery, we easy to see the AVM, easy to recognize the perinatal artery, and you easy to form the consistency of the plan of recession. That is my opinion and my experience about that. And the result, 3 years, I have the 26 patients with the supratentorial AVM, the mean age around the 35 years old, and total 63 fitting artery were applied pre-operate in the 29 session. The most of the AVM size around the 3 to 6 centimeters, and the speller margin around 3 and 4. And the most of them is the nidus is compact. We do the embolization, the 63 fitting artery in the 26 patient, and nidus volume reduction more than 50% before surgery in the 90% of case. As a result, we can compare with another doctor in another article, the similar, the review of the nidus. And we just focus the complication related embolization. So we just have the one, the patient have the new neurologic deficit after embolization, and 2, patient have the cerebral hemorrhage, but they don't have the emergency evacuation. We just have the cerebral hemorrhage on the CT scan. And the result of both of complication, we have the 5 patients have the new neurological deficits, but in 3 months follow-up just around 1, and 4 of them be recovery. And on the DSA, we complete obliteration 100% in the 24 patients, and follow up 3 months later, forward around the 33 and unforward 3 around the 10% of the patient. And I will show you the one case. The patient had the 34 years old, and the patient had the headache and visual acuity. On MRI scan, you can see the AVM located occipital lobe on the right side, speller margin grade 5, and the patient had two times the embolization on this and on the image D at the final embolization before surgery, and the DSA on the image F, the post-operative DSA, the complete the recession AVM. So we can conclusion microsurgery after embolization for brain AVM, a high complete recession rate, relationship high favorite outcome rate, and maybe we accepted complicated rate because the AVM so high rate very difficult for the neurosurgeon, and maybe they consider for the large and complex brain AVM have a treatment indication. Important thing in a teamwork, but coordinate between neurosurgeon, intervention, neurologist. Thank you for your extension.
Thank you to Professor Nguyen Minh Ah for a very nice presentation on AVM surgery. We can take one question, Dr. Atik. You may ask your question, Dr. Atik. Unmute yourself.
Yeah, Professor, it's a nice demonstration of giant AVM management. Very nice presentation. One simple question: in case of giant AVM for embolization, do you embolize the main feeder in one setting, or you take several settings? And the duration of gap from embolization to surgery, how many days you take?
Thank you for your question. The first one, that this AVM, the giant AVM, we do the time embolization before surgery. We focus on the reduction flow and also reduction volume. And the two time for embolization about 1 week, and the final embolization 1 week we do the surgery.
Dr. Atik, is it okay with the answer? Okay, we have one more question, last question. Dr. Karimov, you may ask.
Thank you, Professor. Very informative lecture. And I want to ask about the onyx, or what you use in your embolization, endoscopic embolization. What the material do you use?
Thank you. Because I'm a neurosurgeon and I have my colleague in the DSA team, intervention team, but I know some case they do the onyx, some case they do the field, and some case they do the NBCA. And we have the 3 kinds of the material for embolization.
Okay, thank you so much.
Thank you for the question, and thank you again to Professor Nguyen Minh Ah for the nice lecture. And also I would like to thank Professor He for introducing us with a great lecturer from Vietnam. We move on to Professor Quy Hiang, Professor and Head of Department of Neurosurgery, North Okalapa General Hospital, Yangon, Myanmar, who will present to us on transnasal endoscopic approach to pituitary tumor in Myanmar. Professor, the floor is yours.
Hello, good morning, good afternoon, good evenings. So thanks for the great invitation from the organizing committee to have a talk here. I'm Dr. Chi Lang, and as a neurosurgeon from the North Okalapa General Hospitals in Rangoon. I'm now going to present the transnasal endoscopic approach to the pituitary tumors and how we started the procedures in Myanmar. This is the evolution of techniques, and everyone know how this technique has evolved. So in 2012, I read an article in ACTA on neurochirurgia, and so I read in the Michael Powell's articles. So I sent the email to him, and now with this available, the instruments and surgical tools, I can do my surgeries very well. So I sent the email to him, and so emails to and fro. He came to Myanmar in 2013 October, and he conducted 4 cases in Rangoon General Hospitals and another 4 cases in the Manly General Hospital. This is the photo taken in the OR in the Manly General Hospital. This is the Saturday, Sunday. We went to the very famous tourist sites in Myanmar. It's a Inle Lake where the leg rover has been there. This is the meeting with the neurosurgeons. At the time, neurosurgeons numbers are scanty in Myanmar. We have trouble up Myanmar after visiting the Manly. And so after the 2010, the elections, our health budget is increased. So we can buy some surgical tools So we made a contact with the fellow of International Education of Neurosurgery in the World Federation of Neurosurgery in the Recipe in Brazil in 2011. So I met with Dr. Begin from the New Hampshire, and I asked her help. Anyway, please help Myanmar. And so Dr. Jack Rock has been to us in 2013, February and March. In 2014, November, Dr. Jack Rock and the Lee Sharma from the Michigan, the Hannaford Hospital from Detroit has been to us, and now he conducted 2 cases of the transnasal endoscopic approach towards the pituitary tumors. This is the Myanmar American Friendship meeting in the November 2014. I visited his departments in 2015. Previously, Professor Sosai Munda, as a retired neurosurgeon, has conducted hundreds translateral approach towards the pituitary tumors using intraoperative X-ray on patients after his training from the France. This is the requirement for the endoscopic equipment. This is a reconstruction. Standard is a dural substitute, fibrin glue, Medosal, but our country is a developing country, so it's some difficulties to find the dural substitute and fibrin glue. So we try to control the bleeding with the Sagittal, and then wait for sun movements and sun Valsalva maneuver, and we can control very well. Previously, we used a neurosurgical flap, so in the few dozens of cases, and then we move to the middle Dovnik flap in most of the cases, and then try to put in positions with the Medosal. We have done 300 patients operated in 7 years. Pituitary tumors, apoplexy, craniopharyngiomas, tuberculous lesions, teratoma, and a variety of the sinus, beta sinus pathologies like the tumors, trianomas, and a variety of the traumatic CSF leak and a large meningioma involving the nasal cavity and the young girl. Concerning the reconstruction, nasal subtopelep was as an integral part of the repair in the first dozens of the cases, and then middle Dovnik flap is used more in following cases. This mainly to reduce the nasal morbidity and complaints of the patients on the smile, and the middle Dovnik flap is mostly very fine for the most cases, and nasal subtop flaps is used in some extended approaches. The role of endocrinologists are very important for the optimization of the patients before surgery. I'm not going to show you some cases. It's acromegalic patients. So 57-year-old male, you will see the tumors. It is very difficult to remove the tumors from the transcranially. This is the visual acuity and visual fee. This is the IGF-1 before surgery, and now going down to 43.95 after the surgery. And I'm not going to show you the videos. I use mostly the rings Durex, and now I have to take it out with my tumor holders and try to control the bleeding and suck it out slowly and slowly, remove the tumors, and with a variety of the ring Durex. This is another pituitary apoplexy. You will see at the heterogeneous pictures and the coronal films and the sagittal planes. This is a visual acuity, visual fee after the surgery. It's nearly blind. After the nearly 2 weeks, some vision is improved. In October 2020, vision is improved more on the left side. In March 2021, and that is around about 5 months, vision is improved. So we can say, although the vision is remarkably reduced in the pituitary apoplexy, but after surgery, we have to check with the visual acuity and visual fee, and the improvement noted after the surgery. This is a picture of the patient after the surgery. This is a histopathology. I'm now going to show you the video of the harvesting the nasal middle Dovnik flap by our famous ENT surgeons, Dr. Pomian Tong. So we have to remove the tumors inside the bone, inside it now, and spread out, and now we can put for the reconstruction. This is the spina ostians and right metal technique. I'm not going to show you pituitary macroadenoma surgery in my early surgical experience. At the times, I did these tumor cases slowly and tried to control the bleeding with the suctions, and now remove with the variety of the ring cure slowly, and the rate with the brain positions, these tumors coming out, and suck it out with the tumors, control, pick it up with some tumor holders. So after the surgery, I have to check with the inside of the tumors, and you will see the diaphragm very well with the 30-degree, the endoscope with the curved suctions, and I would like to show you the videos of the pituitary apoplexy. You will see the hematoma mixed up with the tumors, and it is the content gets a little bit the thick compared with the pituitary macroadenoma, and then pick it up with the sums and the crocodiles, and slowly more and more tumors are coming out. So less uplifting of the optic apparatus. This is another the pituitary apoplexy case. You will see the blood, blood one, the tumor mix up with the blood, slowly remove, and now I have to try to hold these tumors with the suctions of the crocodiles. And then use with the ring Turex, and now moving around and remove the tumor slowly. This is a reconstructions video with our middle technique flap. After the surgery, we tried to control the bleeding, and so our country is a little bit, it's a developing country, so I have to save many things. So we have put the middle technique flap and put in position by the ENT surgeons, and then that position was maintained by the Marosaus. This is a pictures taken after the surgery with the ENT surgeons and the neuro anesthesiologists in the Rangoon hospitals. And before moving to North Oklahoma hospitals, we moved to the North Oklahoma hospitals in 2017, and it's now nearly 6 years now. This is his surgery, how we did it with the ENT surgeons and the neurosurgeons. So to compare with the transcranial procedures, injection mannitol, dexamethasone, like the steroids, brain retraction, arachnoid dissections, and the epileptic drugs for the prevention of the seizures are usually used in the transcranial procedures. But in transcranial one, the results are really encouraging, and we have less complication rate compared to the transcranial procedures. Like for this, like the CSF leak, hydrocephalus, tumor recurrence rate is around about 1 to 2%. Thanks for the attention.
Thank you to Professor Yang. I can allow one question from the, please ask your question.
Hello.
You are muted, Dr. Yes.
Can you hear me, Professor?
Yes,
Hello?
I can hear you very well.
Yeah. On simple question, do you do turbinectomy, middle turbinectomy in all cases and take heart flap in all cases, or it is according to tumor size?
So for extended cases, heart flap and for the nasoseptal flap is used, and this is a vascular flap, and it is very, it's a little bit more the increase in passage to prevent the CSF leak. So our mid-turbinate flap is a free flap one, just not a vascular flap, but it is good. But the nasoseptal flap is used more for the extended one. And
okay, do you have any follow-up of nasal quality of life of these patients? Nasal quality following surgery?
Nasal morbidity, more previously, we did it for the nasoseptal flap in all cases, and some nasal morbidity. Some patient has some discharge coming out from the nose with the complaint of my smell is not so good. How can I eat without smell? And these are the usual complaints. So we try to analyze and we try to think critically what is the best for the patients. And I have discussed with my ENT surgeons to choose what is the best for the patients. And mid-turbinate flap it's a very good option for my patients.
Okay, thank you. Thank you very much.
Thank you, Dr. Atik. Thank you for a great lecture, Professor. Hope to see you in person. We have some adjustment to the timetable. I would like to call upon Professor Muhammad Betegi, a professor of neurological surgery from Cairo University, Egypt. He was also a chief neurosurgeon of Children's Cancer Hospital of Egypt. He will be talking on endoscopic assisted treatment of pediatric brain tumor. Professor, the floor is yours.
Okay, thank you. I would like first to thank Professor Yuko Kato for the generous invitation and the privilege, honor to be with you. And thanks for the adjustment since I'm having an important commitment. I hope my screen is visible to you now. I will be speaking about the endoscopic assisted microsurgery for pediatric brain tumors. First of all, I will quote the Bernitsky talk when he said in 1998 introduced the concept of endoscopic microsurgery, in which the surgery is done primarily by the microscope, and in addition to it, we introduced the endoscope in between the surgery, like endoscope controlled, in which you use the endoscope as the primary operative tool. In endoscope assistance, the technique, the medium for surgery is air, and the tool utilized are primarily microsurgical, while in pure endoscopic procedure, it is always the medium water. That's the difference between the endoscope and the endoscope assisted. What are the value of endoscope assisted and what are the value of microscope? So better operative field vision, less brain retraction, better exposure through better illumination. You have wider angles of vision, especially in the skull-based surgeries, the possibility to demonstrate structures from a different angles, meaning you can look around the corner, and less invasiveness by reduction of the approach. These are the endoscopes used. These are a gap endoscope. This is the angled 0 degree and the 30 degree scopes, and that's the holding arm. And these are the instruments for endoscopic assisted microsurgery when we use it through the microscope approach. So there is a debate existing what is the optimal surgical strategy for managing complex brain tumors in children especially. The ideal surgical approach should be given the access to all tumor extensions to allow the maximal and safe tumor excision. As I mentioned, in 1998, Bernitsky introduced the endoscopic assisted microsurgery as a procedure that is virtually assisted by the endoscope. And in 2007, Helwig said that endoscopic assisted microsurgery provides the important ability to look around corners or behind the lesion in questions.
So the choice of the approach, you have to choose an approach that gives you the safe entry, short trajectory, get a tumor access and ability to assess hidden corners, early access to the blood supply of the tumor, and the ability to create a cleavage plane where you can dissect the tumor and avoid injuring eloquent structures. In the endoscope surgery, in the microscopic surgery, there is an excellent in exploring the planes between the tumor and cranial nerves. And it's more familiar for neurosurgeon, wide exposure, confident hemostasis, and you still have a stereoscopic vision that is superior 3D orientation. Surgical microscope, however, cannot still access the hidden structures. And there are some neural elements as the hypothalamus that are not easily assessed in the preoperative radiology, and this could not be possible to be seen by microscopic approach. The surgery for giant tumors with complex extensions, also this mandates accurate assessment for the field boundaries and relation, which is not always feasible by the microscope. So why don't we combine both the microscope and the endoscope? And here we can get simultaneous endoscopic and microsurgical resection of tumors. This is a very novel way to approach such challenging pediatric tumors with complex extensions. How to handle the endoscope while doing a microscopic surgery? In the first image here, we hold in both one hand, I have the endoscope in the right hand and the suction in the left hand, and I use my both hands. In this, I just look in the corners and I cannot do endoscopic resection. Or I can fix the arm, fixing the endoscope and using both hands together. Or you can use the assistant hand and use both hands if you have a confident assistant. Sorry. Yes. This is how the operative field looks like when you can see the main surgeon sitting here, the microscope is here, and here you can have the endoscope where you can see the endoscope on your right hand and the microscope here and the assistants on the right side. So what are the types of surgery that could be done by endoscopic assisted? There are aneurysm surgery, CP angle, intraparenchymal lesions, and the brainstem, cerebellum, intraventricular, skull-based tumors. In this study, I'm showing 71 cases which I did by endoscopic assisted microsurgery, mainly were craniopharyngiomas, chordomas, CPA tumor, lateral ventricular, and forced ventricular tumor, all are in children's age from 0 to 18. First of all, endoscopic assisted microsurgery in craniopharyngioma. This enables more detailed appreciation of the tumor relation to the undersurface of the optic chiasm where the tumor is attached to the hypothalamus and you cannot see it microscopically. Also, tumor residual in hidden corners could be seen by the 30-degree scopes. And sometimes even when you are not able to totally excise it, you can still leave the least small part by endoscope. This is one case who is 13-year-old male, and you can see that's the tumor, the craniopharyngioma, and we approached, I get the approach of the tumor through a terional approach, and you can see left terional approach. That's the left carotid artery, the optic nerve. Started dissecting in the carotid optic triangle first. Though this is done all microscopically, I start creating plane and removing the tumor by piecemeal. This is all done microscopically. Then I introduce the endoscope. You can see the pituitary stalk here. This is a tumor invaded by the invading the stalk. And then I start using my both hands, dissecting the stalk and the attachments. This is the liqueous membrane, and that's the tumor hidden here. I start endoscopically removing these parts that are hidden and cannot be seen by the microscope. This is removed endoscopic assisted through the terional approach. This is sharp dissection, from the stalk and the membrane of Lillquist. Underneath, here is the chiasm above. And you can always check until you are almost totally excised the tumor. And you can alternate shift between the microscope and endoscope every now and then. It needs a learning curve in the beginning, but it is quite easy and familiar. Then hemostasis. And that's the post-operative MRI showing complete resection of this craniopharyngioma. That's another case of a craniopharyngioma. Here, I can show you in this special case of craniopharyngioma where we have excised most of the tumor microscopically, but still when I go inside with the endoscope, I look underneath of the optic chiasm where I can see this small hidden part of the tumor underneath the chiasm. You can see very small tumor that could not be seen microscopically. And this, we started sharply removing it endoscopic assistance. This part could not be seen by the microscope, and it's dangerous to pull without seeing it. This is another complex case of a craniopharyngioma that goes to the CP angle, as you can see in the right side, right CPA, going up to the hypothalamus. And here the approach, either you use two approaches or I did a single approach, right terional, and through the right terional approach, I can go down with the endoscope to the basilar, and I went to the CP angle. So it is easy to do this using the endoscope assistance from the terional approach going back until the CP angle. That's the basilar artery. After the microscopic resection of most of the tumor, can go by the endoscope, looking for the cyst walls. Yes, in this special case, I just want to highlight that in this area, I look first by the endoscope. You can see in this type of craniopharyngioma, it's completely hard and solid, where you can see a rock underneath the optic chiasm. This is a complete calcified part. Getting the endoscope to see if there is any attachment between the underneath of the chiasm where the blood supply comes from and the tumor, and also look around in the corners to see if there is any perforators that are invaded or could be injured by pulling on this rock part, going back and down until the basilar artery to see if it is attached. That's the third nerve. So we create all the dissection planes by the endoscope, find the plane and how safe it is to get this hard part from our calcific part from between the optic and the carotid. This is a 7-year-old male, again with hard calcific part. Same way, went first microscopic. I will just make it fast here. This is all the microscopic part. Start sharply dissecting all around, interoptic, opticocarotid, all triangles until I get out this large calcified part. And after that, I introduce the endoscope. You can see how we hold the endoscope, either from here, like in opticocarotid area, or triangle, or interoptic. And I start alternating in all triangles using the endoscope in one hand and the suction tube in the other hand. And that's how it looks when you look by the microscope, how I hold the endoscope. And that way I am holding the endoscope and looking at the monitor for the endoscope. I'll show the image. This is when I introduce the endoscope after removing the calcific part. This is the pituitary stalk, you can see. And you can check down the optic chiasm, underneath of chiasm with all perforator and blood supply of the chiasm intact. You can look also down here to the basilar artery and the perforators of the basilar. Membrane of Lillquist open. Can look through the whole triangles and check for any residual. That's the immediate post-operative. This is another case of a 4-year-old female who had this huge tumor, and I decided going right terional instead of double approach. And that's how it looks when I went right terional and look by the endoscope back to the third ventricle with the 30 degrees endoscope. You can see the third ventricle and the whole tumor excised, the hypothalamus here, mammillary bodies. All this is through terional approach. So it helps in many craniopharyngiomas to avoid using 2 approaches. What about cerebellopontine angle tumors? It helps in improved tumor exposure, also hidden corner. You can see the cranial nerves, dissect them, panoramic and flexible, safe way. This is one of the cases. You can see this is a prepontine tumor, possibly epidermoid, looking from the images, and I went microscopic endoscopic assisted. I'll show you the endoscopic assisted part. When I introduce the endoscope here, you can see the cerebellum retracted. These are the 7th, 8th cranial nerve complex here. That's the 7th, 8th complex where I dissect endoscopically the epidermoid sharply from it, and then part microscopic. Here I do the microscope, the huge part, or the part that you can see easily, and then introduce the endoscope in between to see the hidden parts and to save the cranial nerves. Here, this is part, then again endoscope introduced. You can see the cranial nerves cleared, the 7th, 8th, and then dissecting sharply until getting from the underneath of the cranial nerve, 7th complex. This is done endoscopic, very minimal. You can go around until you go to the meatus here. Here is the meatus to check if there is any residual inside the internal auditory meatus, and then microscopic view, hemostasis and closure. This is another case also who had an 11-year-old female, trigeminal neuralgia, and we get this prepontine tumor where I used here the pediscope, which is one of the Escolab scopes that is very small and flexible, how you can go through this narrow area. That's the scope, how it looks like. That's the pediscope. The image of the pediscope is not that good like the normal scopes. So I went inside to see that it sounds to be another case of epidermoid, but it's in the prepontine, and then start removing this partly microscopic and partly endoscopic. That's the endoscopic part. This is the image of the pediscope. It looks like this, and the dissection from the underneath of the cranial nerves, going again after removal to check if any residual. And that's the immediate post-operative images, complete resection and resolving the trigeminal neuralgia. What about intraventricular tumor? It helps in inspection of the vascular pedicle, and that's the most important role for endoscope in intraventricular tumor. This is one of posterior third ventricular tumor. I introduced the endoscope first, the trocar, through a mini craniotomy and opening of a dura. I go inside the third ventricle, you find this tumor. I start circulating around the tumor, turning around to see where you can find the vascular pedicle, and then start coagulating the pedicle early by the monopolar, here taking first multiple biopsies for the frozen section pathology, and then start coagulation of the vascular pedicle, and after that I get the whole tumor as one piece from the small cortisectomy. That's the immediate post-operative, and it should to be mature cystic teratoma. Also in cases of fourth ventricular tumor, the fourth ventricular tumor, you don't usually need the endoscope, but some cases it can be of help that you can see the attachment between the cerebral peduncle and the tumor. and this could be sharply dissected first. Here I introduced the endoscope. Down here, that's the brain stem, that's the tumor. And when I went by the endoscope early, I looked around to see, here you create the planes first, microscopically creating the planes, and then introduce the endoscope from the planes. That's an attachment between the tumor and the lower cerebellar, inferior cerebellar peduncle. Here, sharply cutting between the plane of cleavage between the inferior cerebellar peduncle and the tumor. That's the only value actually for endoscope in forced ventricular tumor. Then complete resection, as you can see. That's the postoperative images. Another case of forced ventricular. I will skip this video. It's almost the same. And now, what about the lateral ventricular tumor? Also, it helped in early closure of the pedicle and inspection of the tumor borders. This is one of a lateral trigonal meningioma. I went with a mini cortisectomy. First, I started microscopically creating plane. Then I went with the endoscope, doing coagulation and sharp dissection of the vascular pedicle. You can see here the endoscope introduced. I start sharply coagulating and sharply cutting, and coagulating the vascular pedicle of the tumor all around, detaching the vascular pedicle and coagulation. All this is done endoscopically, and then the removal of the whole tumor as one piece, and then checking for hemostasis again endoscopically after finishing. That's the immediate post-operative. It is shown to be a meningioma. Another case of a choroid plexus papilloma, same way. This is a case of a 3-year-old choroid plexus carcinoma, biopsied somewhere else. We went again, same technique without embolization, and we were able to remove it. All choroid plexus papillomas, the endoscope was very helpful. This is one of the most important cases I want to show. 6 months female patient with this third ventricular choroid plexus tumor, and the vascular pedicle is at the surface. So I first introduced an ultrasound, where I did an ultrasound through mini craniotomy to see the tumor and see the lateral ventricle. And then after that, I did another duplex ultrasound. I identified the vascular pedicle, and then you can see the introduction of the trocar of the endoscope. And then we start endoscopically coagulate. I know now where is the vascular pedicle is. Start coagulation of the vascular pedicle, complete coagulation. And after coagulation, then sharply cutting the pedicle. You can see with the scissors. Here is the scissors, sharply cutting the pedicle, and then coming out with the whole tumor through a small microscopic cortisectomy and microscopic mini craniotomy. I came out with the tumor and the trocar, and then again looking back to see if any residual and doing a third ventriculostomy. That's an immediate post-op, and this helped in short lens stay and was very smooth surgery. What is the disadvantage of endoscopic assisted surgery? Inferior 3D perception of the images compensated with surgeon's experience time, but cannot be set side by side with the microscope. Distortion of image is another issue that should be considered a disadvantage of endoscopic images. Time consuming somehow. I see that this is not a real issue. It adds 15 to 20 minutes extra time to the surgery. The complication that could be avoided, the use of endoscopy during skull-based surgery may correlate with iatrogenic damage of cranial nerves if your handle is not well fixed, or if your assistant hand is not trusted. Also, some reports showed injury of the facial nerve during inspection with endoscope in one of the cases. The risk of using instruments, especially with the 30, 45, and 70, I don't recommend using 70 or 45 degrees. You will lose orientation. With angulated scopes, it's better to start with 0 degree or 30 degree. Take-home message: endoscopic assisted microsurgery of pediatric brain tumor is a promising user-friendly tool that complements microsurgery in the management of these complex lesions. Simultaneous or tandem endoscopic and microscopic approach enables maximum safe total or subtotal resection. The benefits of the ordinary endoscope are added to the benefits of the stereoscopic perception of the microscope to improve the outcome. The possibility of introducing tip of the endoscope into deep area and the use of different angle scopes, discovery of additional information at target, however, is certainly the principal advantage of this tool. These are one of the papers I published in 2021 about the benefits of endoscopic assisted microsurgery in the management of pediatric brain tumor in the neurosurgery focus that could be of help. Thank you very much.
Thank you very much, Professor Bertaghi, for very comprehensive and a lot of details in how to handle endoscope. I would like to request Professor Takeo Goto, who is currently the co-chairman of WFNS Neuroendoscopic Committee, to give your comment and question, is possible. Professor Goto. Hello, Professor Goto, are you here? Professor? Probably while waiting for Professor Goto, we can get a comment from Professor Yoko Kato, Professor.
Okay, thank you very much. So it's a wonderful talk. So recently the endoscopic procedure is more popular, but you mentioned about so many disadvantages or some complications. So we should be very careful when we use the endoscopic procedures. It was an excellent talk. Thank you very much.
Thank you.
Thank you so much.
Thank you, Professor, for joining us for today. And we move on to the next presentation by Professor Kazumichi Yoshida, Professor of the Department of Neurosurgery, Shiga University of Medical Sciences, Shiga, Japan, who will present to us on management of carotid artery stenosis based on MRI detected interplug hemorrhage. Professor, the floor is yours.
Hello, everyone. Thank you, Professor Liu. And I'd like to show my appreciation for giving me an opportunity to show my work about carotid surgery and carotid vessel wall imaging with MRI. So I made a video in advance, so I'd like to share a screen. Okay.
We couldn't hear the sound, Professor. Could you click on the view option and share computer sound?
Sorry, can you hear me? Or
Yeah, we can hear you, but not from the video.
Okay.
There's a button up there, view option, Professor, and you put there share computer sound.
Excuse me?
You look at your screen above, there's a view options.
View option?
Yeah, there's a button on view option. You click down and you click on the share computer sound.
View option, view option.
On top, a midline on top.
Sorry, I can't find the view option.
ビューオプションと先生、上に書いてありますけど、画面の上の先生の吉田なんとかって緑の右側ですね。
あ、ちょっと待って、一回じゃあ共有停止しましょうか。緑の、これで、ビューオプション、ビューオプション。
もう一度ビデオ出していただいて。
もう一回、はい。
はいはい。
すいません。これで共有しますね。共有して。
で一番上のその緑の先生の吉田和夫、その右側にビューオプションって書いてあります。
や、私の画面でその吉田というのが出てこないんですが。ビューターの
出てないですかね。
ちょっと見つからないですね。
もうこの画面のちょうどトップのその真ん中のところに緑のその隣に
新しい共有ではなくて、
ビューオプションってありませんか？
ビューオプション。すいません。ちょっと画面に出てこないんです。ちょっと別のやつをちょっと準備して、もう一回ちょっとすいません。やり直してみます。
どうぞどうぞ。
一旦停止にして。
So you want to find another one?
Maybe he can send his presentation to Dr. Liev.
Now you see the top of the screen, Professor. There's a view option.
今その一番上のところに。
今聞こえてます？
まだ聞こえてないんですけど、そこにビューオプションっていうのは字が見えませんか？
で、上のパネルのところですよね。
そうそう。先生の矢印がもうちょっと上まで行くと、ビューオプションっていうのがあるんです。そうそう、そのまま上まで。
上が出ない、いかないんですが。
出ない。So he said, he cannot tell needs.
Okay.
喋りますか、先生、じゃあ、このまま。
すいません。ちょっと待って。これどうなってるのかな？ビューオプション。すいません。この上のところですね。
緑の吉田先生の画面を表示していますっていう、右側にあるんですけど。
私の画面上では出てないですね。
じゃあ先生、これ流しながら喋ります？
そうしましょう。画面の、ちょっと待ってください。今なんか、リュウ先生がなんか、そちらから操作し、
Looks like can you do it instead of Yoshida sensei?
Yeah, I'm trying, Prof. No, I can't control his screen, sorry.
If you should take his file, maybe.
Prof, you click on the Zoom, Prof. You click on the Zoom. You go to
Zoom をクリックしてくださいっていう。
You click on share screen. You can see share sound down there. There's a button. When you click share screen, there's a box down there. Share
down.
I
see. Okay, I find it. Okay, I find it.
You just click that before you share the screen.
Yeah.
Yes.
Okay. Detected intraplaque hemorrhage.
聞こえた、聞こえた。大丈夫です。
すみません。ちょっともう一回、じゃあ、ちょっと最初から。
Yeah, you can start from beginning. We can hear it.
画面を大きくしてください。
ちょっと待ってください。もう一回すみません。やり直します。共有で。Excuse me.
Hello, everyone. I'm Kazumichi Yoshida from Shiga University of Medical Science. Before I start my presentation, I would like to show my sincere appreciation for Professor Kato and Professor Demetrius for giving me an opportunity to present my work. Today, I'd like to talk about management of carotid stenosis based on MRI-detected intraplaque hemorrhage. Atherosclerosis is highly prevalent in developed countries, and according to studies from Western countries, approximately 20% of all ischemic strokes is due to carotid atherosclerosis. The number of patients of carotid disease is increasing in Japan, probably due to not only westernization of Japanese diet, but rapidly aging population in recent Japanese society. As this graph shows, while the number of carotid surgery in Japan, those of carotid stenting and carotid endarterectomy is increasing, it is notable that the number of carotid stenting has been soaring high since the publication of the SAPPHIRE study. Due to the development of vascular biology and carotid vessel wall imaging such as ultrasound and carotid MRI, it has been widely accepted that vessel wall characteristics is also very important as luminal stenosis for the risk stratification for ischemic stroke in patients with carotid stenosis. Among the known features of so-called vulnerable plaque, thin fibrous cap with large lipid core, intraplaque hemorrhage, and outward remodeling can be accurately assessed with contemporary high-resolution MRI. In my presentation, I would like to briefly summarize MR signal of intraplaque hemorrhage first. Then I'd like to show some possible clinical merits of intraplaque hemorrhage assessment for symptomatic patients, for asymptomatic patients, and finally, the benefit of CA for so-called should occlusion. Reflecting short T1 relaxation time of methemoglobin, intraplaque hemorrhage shows bright signal on T1 weighted imaging. And among available modalities for vessel wall imaging, MRI is the best technique for detection of intraplaque hemorrhage because of its wide contrast range and high spatial resolution. High signal of IPH decays with time, and fresh IPH show brightly high signal on T1 weighted image, but old organized hematoma demonstrates iso to hypointense signal on T1 weighted image. In other words, temporal change of intraplaque hemorrhage can be diagnosed with MRI, and this may be useful in a clinical setting. Next, I would like to show our data about association between recurrence of symptomatic patients under best medical treatment and intraplaque hemorrhage. This is an observational study for the outcome of best medical treatment in patients with low-grade stenosis but with extremely vulnerable plaques. We followed up 25 symptomatic low-grade stenosis with MRI-detected intraplaque hemorrhage and expansive or outward remodeling. Best medical treatment consists of at least antihypertensive, dual antiplatelet, and statins. And finally, 44% of patients developed a total of 30 ischemic recurrences, including TIA, and the recurrence rate was as high as 46% per patient year. This study is meta-analysis of recurrence risk for low-grade, moderate, and high-grade carotid stenosis with or without intraplaque hemorrhage at its initial presentation. In this study, moderate stenosis with intraplaque hemorrhage has highest risk for recurrence. And interestingly, the recurrence risk is very low for plaque without intraplaque hemorrhage, irrespective of its stenosis rate. On the other hand, plaque with intraplaque hemorrhage carries a significant risk even though low-grade stenosis. These results clearly show the importance of plaque characterization or vessel wall imaging in the management of carotid stenosis. In the next few slides, I'd like to talk about the significance of intraplaque hemorrhage in asymptomatic patients. In recent decades, medical treatment for carotid stenosis has been strikingly improving by introduction of lifestyle modification and multifaceted medical treatment such as antiplatelet, antihypertensive, and statin. Stroke risk under contemporary best medical treatment is below 1% per year and much better than that of NACET and ACAS era. So due consideration should be given for the indication for carotid surgery. Therefore, now we need diagnostic method for truly high-risk asymptomatic patients. SMART-Case study is our ongoing prospective observational study for asymptomatic carotid stenosis with MRI-confirmed intraplaque hemorrhage. Inclusion criteria are medically treated asymptomatic patients with carotid artery stenosis with area stenosis of 60% or over, so it includes low-grade stenosis according to NACET criteria, and the presence of MRI-confirmed intraocular hemorrhage, independent in ADL and with life expectancy more than 5 years, and so on. This table shows the schedule of assessment. The observation will be finished after 3 years follow-up or at endpoint. Primary endpoints consist of cerebral infarction, TIA, or retinal ischemia resulting from carotid artery stenosis. Secondary endpoints are any cerebral infarction or required revascularization. This slide shows the interim results of SMART-K study. Patient enrollment completed this March, and finally 88 patients participated in this study. Average follow-up period is around 2 years, and 8 patients reached primary endpoint. At present, the incidence of ischemic stroke of asymptomatic patients with intraocular hemorrhage is 5.1% per year, and this is approximately 5 times higher than that of asymptomatic patients in general. I hope the final results of SMART-K study will contribute to establish sophisticated management strategy, especially about the indication of carotid surgery for asymptomatic patients. Next and finally, I'd like to discuss prediction about the benefit of CA for so-called pseudo-occlusion by IPH assessment with MRI. As you know, carotid pseudo-occlusion is an extremely advanced sclerotic lesion, and string-like blood flow distal to the plaque is slowly demonstrated by catheter angiography. There have been controversy over CA for pseudo-occlusion. While safety of CA for pseudo-occlusion is reported to be comparable to CA for carotid stenosis in general, several studies have shown that CA for pseudo-occlusion is less beneficial than common CA because reopening of the distal ICL lumen cannot be achieved in about 1/4 of the CA cases. Why difficult in reopening of distal internal carotid artery in some patients with pseudo-occlusion? This slide shows possible natural cause of carotid stenosis. Some studies have reported that intraocular hemorrhage is an essential step in the progression of stenosis, and I think intraocular hemorrhage must occur at completion of pseudo-occlusion. If pseudo-occlusion status continues for a long time, vessel wall of collapsed internal carotid artery becomes organized, thickened, and stiff. Once organized change of the distal ICA is completed, CA cannot recover cerebral blood flow even if performed safely. So in my hypothesis, CA for acute pseudo-occlusion, that is, the recently completed pseudo-occlusion without the organic change of the distal ICA is beneficial. But CA for, so to speak, chronic pseudo-occlusion is ineffective. As I mentioned earlier, temporal change of intraocular hemorrhage can be evaluated with MRI on T1 weighted image. So MRI assessment of intraocular hemorrhage is a promising method to distinguish acute pseudo-occlusion and chronic pseudo-occlusion. I thought that pseudo-occlusion with T1 high signal plaque is acute pseudo-occlusion and is effectively treated by carotid surgery. I reported preliminary results in Japanese journal about relationship between MRI plaque evaluation and postoperative patency of the distal internal carotid artery in patients with carotid near occlusion. This is a representative CEA case for asymptomatic pseudo-occlusion. The collapsed distal ICA is demonstrated in the preoperative DSA, and MRI plaque imaging showed the hypointense plaque and diagnosed to be chronic hematoma. This is elastic Van Gieson stain of the excised carotid plaque. You can see multiple small new blood vessels in the organized thrombus. Although CA is uneventfully performed, sufficient dilatation of the collapsed ICA could not be achieved. This is another representative CA case for symptomatic pseudo-occlusion. This 47-year-old male presented with multiple small infarcts in the right hemisphere, and symptomatic pseudo-occlusion was diagnosed by catheter angiography. Carotid MRI showed a bright signal on T1 weighted image. He underwent RECA on the next day of the ischemic event. Mason trichome staining of the plaque showed fresh massive intraplaque hemorrhage, and the fibrous cap was ruptured at the shoulder, and the narrowed lumen became packed with fresh hematoma. CA was uneventfully performed, and fully recovered distal ICA was confirmed by the post-operative DSA. This table showed summary of 7 cases of CA for pseudo-occlusion. All of 4 patients with T1 high signal plaque were confirmed to have completely reopened distal ICA. On the other hand, among 3 cases with T1 ISO or hypersignal plaque, distal ICA stenosis remained in 2 cases, and asymptomatic occlusion occurred in 1 patient. Prospective larger-scale study is needed to see whether IPH assessment could really help to predict the benefit of CA for pseudo-occlusion. This is my conclusion. Intraplaque hemorrhage is a clinically important feature of the carotid vulnerable plaque. Currently, MRI is the best imaging modality for intraplaque hemorrhage. Intraplaque hemorrhage assessment with MRI could be useful for many clinical issues. Thank you for your attention. Professor Liu, excuse me for taking time due to my problem.
No issue, no problem, Professor. Now we open the floor for question, please.
I have a question.
Yes, please ask, Prof.
Thank you so much, Professor, for your interesting presentation. Actually, it was very new information for us, especially for the intraplaque hemorrhage issue. I've just thought about the use of ultrasound duplex scanning in the in detection of this kind of hemorrhage. Is that possible to use ultrasound with a spatial duplex scanning? Or it is still as a standard MRI is preferred?
Thank you, Professor. This is a very important question. And carotid Doppler can diagnose a so-called soft plaque, not fibrous plaque. But soft plaque consists of two kinds of components. One is intraplaque hemorrhage, and one is a necrotic core. So Doppler cannot distinguish between intraplaque hemorrhage and necrotic core. So MRI is more accurate to diagnose the intraplaque hemorrhage. Okay.
Oh, thank you so much.
Is there any other question? Yes, Dr. Atik.
Excuse me, Professor, thank you for your lecture. And I want to ask that is there any possibility or any risk to occlude intracranial vessels, but after intraplaque hemorrhage?
You mean the such a carotid vessel imaging also used to the intracranial arteries?
Yeah, intracranial arteries. Yeah.
Okay. Now I am also investigating the vessel imaging of the intracranial artery, and now the benefit of vessel imaging for intracranial artery is the very high risk plaque or stable plaque, as I mentioned, and also distinguish the atherosclerotic stenosis and moya disease.
So adding the luminography or angiography to the vessel imaging, we can more accurately diagnose disease or risk for future stroke by medical treatment. So my message is not only luminography, but also vessel wall imaging is very important for vascular surgeon.
Thank you so much. Thank you.
Thank you. Thank you very much, Professor Yoshida.
Thank you.
Enlightening lecture. And we move on to the next lecture by Professor Sanford Su, who is a professor and director of neuro-oncology, cerebrovascular and skull-based neurological institute, Veteran General Hospital, Taipei. He is presenting to us on surgical strategy of paraclinoid aneurysm clipping. Professor, the floor is yours.
Thank you, Professor Benson. Could you hear me now?
Yes, Prof.
Yes, I would like to thank Professor Yoko Kato inviting me to join this webinar. And today I would like to share my experiences with the surgical clipping in the paraclinoid aneurysm. And actually, because of time, I just show some key cases to demonstrate some most important concepts. And for the paraclinoid aneurysm, based on the projection, we can classify this kind of aneurysm into 4 types. The first type is the superior type, maybe also called the true ophthalmic aneurysm. Either they can growing up, compressing the optic nerve, or by the side of the optic nerve. And the second type is the little type. They can growing upwards and actually against the outer ring, so make the aneurysm maybe into 2 parts, so-called the transitional type. And then the third type is the medial type. The aneurysm rising from the medial aspect of carotid, and some people call it the superior hypophyseal aneurysm or carotid cave aneurysm. The last type is the inferior type, and usually this kind of aneurysm is projecting actually below the superior hypophyseal artery, and also maybe into the carotid cave in his inferior aspect. So actually the paraclinoid aneurysm clipping is the surgery of the anterior clinal process and autodural ring because of the correlation of the aneurysm to the clinal process. And this aneurysm arising from the area of the clinoid and has a close relationship to the ring, so-called autodural ring. To approach to this kind of aneurysms, I would like to use pretemporal approach, which means the projection is lower than the traditional terraeonal approach. That means you have to reflect the temporalis muscle further down to the zygoma notch. And sometimes if it is large and complex, you can either to cut the zygoma or do the OZ approach to make the exposure flush with the base of the temporal. And we do the extradural approach to the clinal process. So we have to find the meningoorbital artery within the dural fold. You divided it to expose the superior orbital fissure, and you can find the dural group below the superior orbital fissure. And it is the beginning that you are peeling the dura off the lateral wall of the capital sinus. So usually I start in the cleavage, the dissection using the sharp dissection to find the cleavage plane. Continue the peeling of the dura by blunt dissection until you expose the tip of the clinoid and the V1, V2 trochlear nerve overlying the lateral wall of the capital sinus. And if you want to expose the whole lateral wall of the capital sinus, if the aneurysm is large or complex, the meningeal artery, and to continue the peeling of the dura down to the anterior pectoralis region, to expose the V3 and the GSPN to preserve it. And also you can expose the anterior petrous region. So you can totally expose the lateral wall of the cavernous sinus. And people usually ask how to do the hemostasis when you do the cavernous sinus approach. Usually we inject the tissue between the window between the V1, V2, and also you can inject the tissue into the membrane. When you remove the clinoid, you can inject the tissue into the membrane surrounding the carotid. So you can achieve almost bloodless surgical field during the surgery. And as I mentioned, the aneurysm surgery actually is the surgery around the clinoid. So you need to know the anatomy of the clinoid. The anterior clinoid has 3 attachments. The first one is the sphinal ridge, the sphinal wing. Second one is optic canal. And third one is optic strut. So we can do the anterior clinoidectomy step by step to expose the lateral wall of orbit. And when you drill the sphinal wing, you already detach the first attachment of the clinoid, and you skeletonize in the optic canal to weaken the anterior clinoid. And usually the optic strut is very fragile, so you can mobilize the anterior clinoid by fracture the clinoid from the optic struts. And every important neurovascular structure, when they penetrate in the dura into the cavernous sinus, there is always the ring-like structure surrounding these structures. So for the paraclinic aneurysm, there's when you remove the anticlinoid, you can always find the dura ring surrounding the clinoid. So you have to dissect the ring of the carotid to expose the neck of the aneurysm. So removal of the dorsal distal dura ring is essential in the ophthalmic and little types of the aneurysm. For this case, because of time, I fastened the video. I pushed the dura backward to expose the part of the lateral wall of the cavernous sinus. I drilling the anterior clinoid, as I mentioned. I weaken the optic struts, so you can easily remove the anterior clinoid. And I cut the dura along the cilium fissure down to the base, and I had to cut the dura along the optic nerve, so-called phospholigament, to free the optic nerve. Then I can dissect the outer ring of the dome of the aneurysm to expose the whole neck of the aneurysm. So I free the aneurysm from the outer ring so that I can put the clips. So this is the basic surgical technique for the paraclinical aneurysm. And even for such kind of large aneurysm, it's the same, using the same technique. But remember, the ring always acts like a string. If you don't clean the ring very well, and when you put a clip, then you catch the ring, and also you can strangulate the carotid. In this case, I dissect the ring of the aneurysm, and I put the proximal control, shrink down the aneurysm by coagulation, and dissect the ring of the carotids. Then I put the clip. But when I'm using the Doppler, I found the flow is diminished, and I realized the carotid is strangulated with the compromised flow. So I take off the clip and found I didn't clean the ring very well. So I need to clean the ring of the carotids. Then I totally free the ring of the carotid in the aneurysm. When I put a clip and I recheck the Doppler, and it return showing normal flow. So this case shows if you didn't clean the ring very well, you may compromise the flow and causing some catastrophe to the patient. And for the medial or inferior types of the aneurysm, not like the true ophthalmic aneurysm, circumcise the whole of the outer dural ring of the carotid. So for this kind of case, I removed the anticlinal and found the ophthalmic artery. Then I cleaned the dorsal aspect of the ring. Then I tried to put the aneurysm clip. I found the distal neck of the aneurysm. In such a case, usually you need a fenestrated clip. When you put a clip, you found the tip of the clip is hidden by something. You cannot advance your clip. So when you check the clip in way, because the medial aspect of the ring is hindered by the medial aspect of the dural ring. So you need to cut the ring off the carotid. In such way, you can advance your clip to catch the whole neck of the aneurysm. So this is another case, the medial type of the aneurysm. I drew the lateral wall of orbit, cut the dural fold, healing the dura, and removing the anterior clinoid, and cut a ring, free the optic nerve by cutting the phosphor ligament that set in the outer ring to expose the carotid. I put the proximal control, and because when I put the proximal control, I squeeze the carotid, so I have a space to cut the ring in the medial aspect of the carotid. This is the tip, is some trick to do the circumcision of the outer ring in the medial aspect of the carotid. In this technique, when you totally free the outer ring and you can free the carotid, so when you put a clip, you can easily advance your clip to catch the whole neck of the aneurysm. But you have to be careful to spare, like you see, you have to spare the superior hypophyseal artery, because if you compromise such kind of the perforators, the patient may suffer from blindness after the surgery. So when I put the first clip, I realized I catch the perforator. So I need to readjust. As you can see, the clip, or the tip of the clip should go underneath the perforators. So I need to readjust the clip below these perforators and catch the whole neck of the aneurysm. So another case is, so this is post-op in geography. And another question most commonly asked is, how did you do the proximal control for the paraclinical aneurysm? Most of the people, they may expose the neck region for the proximal control. For such kind of large aneurysms, how I can get the proximal control? The same technique, I expose the paraclinoid region by cutting the ring of the carotids. Then I need to find my proximal control. So I open the Parkinson triangle, as you can see, between the trochlear nerve and the V1. And I try to find the carotids, the intracavernous carotid. And also I found the obtuser nerve just underneath the V1. So when I open the Parkinson triangle, I have the more confidence to deal with this kind of aneurysm. Now I cutting the ring of the dome of the aneurysm. So I try to expose the whole neck of the aneurysm. And you can see a tracheal nerve is overlying the aneurysm. And I put the proximal control, shrink down the aneurysm by coagulation. Then I put a clip, the pilot clip. But when I try to dissect the aneurysm, then I cause a premature rupture. So in this case, since I have already the proximal control at hand, I put the proximal clip in the Parkinson triangle in the intracavernous carotids to diminish the bleeding. Then I can coagulate the aneurysm to stop bleeding. Then I can readjust the clip. To finish the final clipping, of course, I need to free the carotid from the dura ring. And I can readjust to finalize the clipping. So this is sports art in geography. And this is a similar case. I'll skip it. And for even more large and complex is the same. You need to open the Parkinson triangle to localize the intracavernous carotids, to free all the nerves overlying the lateral wall of cavernous sinus. Then you have the proximal and distal control, so you can trap the aneurysm to make it smaller by coagulation and just total occluded the aneurysm by tendon clips, preserving all the perforators. So you have a very adequate exposure to the aneurysm if you know how to expose the cavernous sinus. And even nowadays, I have limited cases of the symptomatic intracavernous aneurysm using the same techniques. But because of time, I would like to skip the video. And for another question is, how did you know the location of the perigonal aneurysm is real intradura, or maybe the aneurysm is just outside the dura? Sometimes when you may face with the situation that the aneurysm actually look like the intradura, but when you expose this area, actually the aneurysm is rising outside the dura, especially when it is the lateral type. The lateral type of the aneurysm is so-called the subclinal aneurysm. If we didn't recognize the possibility of the subclinal aneurysm, when you remove the anterior clinal, you may causing the catastrophe when you remove the clinal and causing the premature rupture. So in this case, I was assigned during the life surgery, and everyone think this is a true ophthalmic aneurysm. When I drew the anterior clinal, and I realized, oh no, this is maybe the lateral type of the aneurysm, because I see some bulging within the anterior clinoid, and also the color is. So I need to scalenize the anterior clinoid, then I can meticulous to make the anterior clinoid like an eggshell overlying the dome of the aneurysm, and I remove the eggshell to expose the aneurysm, then I put the clips to occlude the aneurysm. So when you are in the pre-op images, when you see there's some west belts surrounding the aneurysm, and you have to keep in mind, maybe this kind of aneurysm is lateral type of aneurysm. So when you remove the clinoid, be careful not to cause the premature rupture. Most of these cases, actually, they don't need to be treated. So this is another case. I just want to show when I remove the anterior clinoid, and I realized, oh, this is the lateral type of the aneurysm. So I'm using the small burr of the drill to make the anterior clinoid like an eggshell and remove the bone chips surrounding the aneurysm and try to free it from the ring and put the pilot clip at the weakest point and totally expose the aneurysm. Then finalize the clipping. So people need to know the real location of the aneurysm to avoid the unexpected surgery, because sometimes these aneurysms may causing the catastrophe, like the cases published in the literature. If you don't have any experiences, you may got higher chances to make the catastrophe. So we just analyzed our series based on the past decades. We have more than 200 cases of pericolonial aneurysms, and we compare the pre-op images finding and the real intraoperative findings. We made the optic struts as a reference points, and we found the real outer dural ring. When you see the CDA, usually the outer dural ring is 2 millimeters above optic strut. It means when the neck, proximal neck, and distal neck of the aneurysm is above the 2 millimeters of the optic strut, then the aneurysm is intradural type of the aneurysm. If the proximal neck is below 2 millimeters and distal neck is above 2 millimeters, this kind of aneurysm is transitional. It means the part of the aneurysm is outside the dura and part of the aneurysm is inside the dura. If the distal neck of the aneurysm is below 2 millimeters from the optic strut, then has most possibility that this aneurysm is located outside the dura. So when this kind of aneurysm, maybe you just wait and see, they don't need to be treated. So because of time, I simply just sharing my experience of the surgical in pericolonial aneurysms and just demonstrate some key points when you face with this kind of aneurysm. And thank you very much.
Thank you very much to Professor Stanford. Now we open the floor for question. Dr. Atik.
Yeah, Professor, one simple question. In your series, all the cases are unruptured or you have ruptured cases in your series?
Yeah, actually, the rupture cases only take maybe 5% of my series. Most of my series are unruptured cases.
Okay.
But even for the rupture cases, the principle is the same. You need to find the proximal extradural dissection this situation.
Do you think that in rupture cases it is that? Can you hear me?
Yes.
Can you hear me?
You mean when it is the rupture case, right?
Yeah, yeah. In rupture cases, is it better to take control of neck?
Yes, for the rupture cases, I think extradural approach is very safe because even the aneurysm has a second bleeding, rebleeding is outside the dura. And I already had the proximal control in the Parkinson triangle.
Okay, thank you. Thank you.
Hi, Professor Sam from Malaysia. That was a fantastic lecture. Thank you for sharing. I would like to ask, in today's age and time where endovascular techniques are so readily available, like flow diverters, in which circumstance would you recommend doing open surgery instead of doing these endovascular techniques? Thank you.
Yes, most of the people, they would question me about the why don't you do considering the endovascular approach to this kind of aneurysm. Sure, nowadays we have a lot of devices like pipeline stents to treat such kind of aneurysms. But for me, actually, the vascular surgery is the basics of the skull-based surgery. If you don't know the how to approach such kind of aneurysm, you don't have any chances to push your boundary when you do other kind of pathology like the skull-based tumors. The vascular surgery is the most important basic techniques for the advanced, the skull-based surgeries. So people, they cannot abandon, they cannot give up the basic techniques. Even they have endovascular treatment modalities, that is another options. But actually, it doesn't mean that the surgery is inferior to the endovascular treatment, because if you did a lot of work in the lab, if you are very familiar with the anatomy, if you see a lot of cases from the great mentors, then actually you can achieve a very fair outcomes, which is comparable to the endovascular options. Yeah, but you are equipped with the more advanced techniques to deal with more complex skull-based tumors.
Okay, thank you very much.
Hello, Professor. Yeah, thank you for your excellent lecture. Had good information. I just want to ask you, you mentioned while dissection of cavernous sinus, you will introduce TISL. So can you briefly explain about the procedure? Little bit more about the technique.
I cannot hear very clear because the signals. But can you repeat the question again?
Yeah, during the dissection of cavernous sinus, you said you will introduce the TISL, the glue, so that there will be bloodless field.
You mean the proximal control? You mean
No.
I inject the TCO?
Yeah, for the bloodless field.
Yeah. Usually, I learned this technique from my mentor, Dr. Krish, in the Little Rock of the States. Usually, I inject the TCO into the window between the V1 and V2. And when I remove the anticlinoid, I will make a small dissection. I will open the membranes surrounding the oculomotor nerve, because in the clinal portion, the carotid is always surrounded by the thin membrane. You need to open this membrane, then you can also inject the tissue, because the space is the same as the cavernous sinus. But remember, just push the sphenoparietal vein. You need to using the sucker to compress this sphenoparietal vein when you inject the tissue, because you don't want the tissue to go back into the sylvian vein. Sometimes, if the tissue go back into the sylvian vein, especially in the deep sylvian vein, the patient may suffer from the brain swelling because the venous congestion. So you need to just push the tissue, but the tissue has to go directly into the cavernous sinus, but not to go backwards.
Thank you for the information. Thank you.
Thank you for the question. I think we are running out of time. We are 30 minutes to the next day already in Japan. Thank you, Professor Sanford, for very nice and exciting lecture and tricks. We go to our last speaker for today, Professor Takeo Goto, who is also an endoscopist, skull-based surgeon. And also, again, like I mentioned earlier, he's also the co-chairman of the World Federation Endoscopic Neuroendoscopic Committee, who is now working at the Department of Neurosurgery, Osaka City University Graduate School of Medicine, Osaka, Japan. And he will present to us today on endoscopic approach to skull-based tumor. Professor Takeo, please take the stage.
Thank you. At once, I will share the screen. Okay, can you see my slide?
Yes, Prof.
Okay. Today, I feel very honored to have opportunity to present my work in front of many Asian friends. Today, my topic is endoscopic skull-based approach to various skull-based tumors. Recently, endoscope can offer the panoramic and wide view to deep-seated area, which largely contribute to less invasive tumor removal of skull-based tumors. So today, I will present the two techniques. One is endoscopic endonasal, and the other is endoscopic keyhole transcranial approach. At once, I will show our endoscopic endonasal approach. I'm the skull-based surgeon, so I also use transcranial skull-based approach like this. And I know that most part of the skull-based tumor can be safely resected out by this crash skull transcranial skull-based approach. But if the region located the pure central skull base within this red circle, which connected all neural foramen, surgical resection by the transcranial approach seemed to a bit difficult. But if we observe this circle through the endoscopic endonasal route, the circle looks like this. I mean that the only obstacle to access this area is a bony structure, such as clivus, pterygoid process, and petrous bone. So if we have the technique to safely drill out the old bony structure like this, we can directly access the central skull base. I will show our several cases. This is a retrochiasmatic craniopharyngioma causing the visual disturbance. So I choose the endoscopic endonasal approach. Endoscope, by the endoscopic approach, we can easily access within the circle of wheels, combined with posterior clinoidectomy like this. So I will show our surgical video. Already bone work almost finished. This is a pituitary gland and cella floor. I elevated the pituitary gland upward to expose the dorsum cella and the posterior clinoid process. Then I gently remove the posterior clinoid process. And then I dissect the pituitary gland from the medial wall of cavernous sinus and mobilize the gland to the left side. Then I cut the dura. Now we are within the circle of Willows. So it's easy to dissect the tumor from the pituitary stalk and tumor. Now we can identify the old border between tumor and critical structure. And in this case, we achieve the total resection of the tumor with preservation of pituitary stalk and gland, like this. Postoperatively, all tumor was totally resected out and preserves the pituitary stalk and gland. This is another case of the very large diaphragmacellar meningioma. I think the transcranial resection will be very risky, so I choose the endoscopic endonasal approach to access the attachment of the tumor. I will show our case. I widely drill out the bony structure, and then I cut the dura around the cella floor. And then I mobilize the pituitary gland to the right side. Now this is a diaphragm and attachment of the tumor. So we could carefully detach the tumor. so we can safely mobilize the tumor. Tumor already detached, so we could perform the careful dissection with very clean surgical field, bloodless surgical field. So I carefully dissect the tumor from the surrounding structure. This is an optic chiasm I carefully dissected, and finally all tumor was successfully resected out. But in case of the meningioma, we have to water-tightly seal the dural defect. I prefer to insert the fat tissue to subdural space and put some suture like this. This suture is very effective to fix the fat tissue. And then finally, I cover the large septal flap and water-tightly seal the dural defect. Finally, all tumor was successfully resected out without any deterioration of symptom. This is another case of the lower cranial meningioma. If we choose a transcondylar approach, we have some risk to damage the lower cranial nerve. And also, if we choose the transpetrosal approach, we have some risk to damage the abducens nerve. So in such case, I use the endoscopic transcribal approach. So I widely drill out the bony structure around the lower clivus. I drill out the jugular tubercle, and then I cut the dura. When we cut the dura, most part of the tumor was already devascularized. This is the most large benefit of this approach. This case, tumor was very fibrous and hard, but tumor already devascularized. So it's easy to dissect the tumor from the brainstem. This is a basilar artery, and this is a perforator from basilar artery. This is a tumor ventral side of the hypoglossal nerve, and also we reach the lateral surface of the tumor. This is the abducens nerve, and finally we reach the lateral end of the tumor. This is a tumor ventral side of 7th and 8th nerve. So most part of the tumor was successfully resected out. Postoperatively, about 95% of tumor safely resected out with preservation of lower cranial nerves. So this procedure also very effective. Of course, to apply the endoscopic enonasal approach to skull-based tumor, we have some special technique for safe resection of the tumor. I presented how to remove out the posterior clinoid process to JNS, and how to make the knot outside the nostril, also published to World Neurosurgery, and also how to expose and how to mobilize the carotid artery by the pterygoid process, also presented in World Neurosurgery. So if you have the interest to the endoscopic enonasal approach, please check these papers. And then I will present our endoscopic keyhole approach. At first, I will show the anatomy of the endoscopic keyhole subfrontal approach. Usually, I put the skin incision around the eyebrow and put the craniotomy with a size of 3 centimeters, and then carefully insert the endoscope to the frontal base. The size of craniotomy is very small, but endoscope can offer the panoramic view, so it's relatively easy to observe the paracella area. This is a bilateral optic nerve, and this is a pituitary stalk, and this is a tuberculum sella. Through this cadaveric study, we found out we could drill out the tuberculum sella and also open the optic canal on both sides. So I applied this technique to small tuberculum cell meningioma. This patient is a 70-year-old female, and the tumor caused severe visual disturbance on the left side. So I choose the endoscopic keyhole approach on the left side. The size of craniotomy is about 3 centimeters, and then I carefully insert the endoscope along the frontal base. This is a left optic nerve. Endoscope can offer a very clear view, so it's relatively easy and safe to drill out the tuberculum cell and also open the optic canal on the left side. Then I cut the dura and open the left optic canal, and left optic nerve was completely decompressed at the initial stage of the surgery. And then I start the tumor removal very carefully. I carefully detach the attachment of the tumor. And this is a contralateral optic nerve. Tumor was almost totally resected out like this. So this procedure was very effective to this tuberculum cell meningioma. Postoperatively, all tumor was resected out and her vision was dramatically improved. This approach also very effective to the olfactory groove meningiomas. I also use a keyhole subfrontal approach to olfactory groove meningioma. The size of craniotomy also 3 centimeters. And then I insert the endoscope along the frontal base. Now I detach the attachment of the tumor and also perform the internal decompression. Tumor completely detached, so tumor changes bloodless, so it's relatively easy to dissect the tumor from the frontal base, like this. And finally, all attachment was completely removed, and finally, all tumor was successfully resected out. Postoperatively, MRI show all tumor was successfully resected out. Then I will show the neuroanatomy of endoscopic subtemporal keyhole surgery. Usually, I put the skin incision like this and put the craniotomy with the size of 3 centimeters, and then insert the endoscope. After insert the endoscope along the temporal base, we can observe the trigeminal nerve covering the dura mater. And this is a Kawasaki triangle. Even this endoscopic view, we can expose the Kawasaki triangle and also drill out the Kawasaki triangle. So now we can completely expose the trigeminal nerve from Meckel cave to brainstem, like this. This surgical view is similar of the anterior transpectrosal approach. So I apply this technique to the Petrus apex small meningioma. This patient shows an uncontrollable trigeminal neuralgia after the gamma knife. But the lesion is very small, so I apply this less invasive procedure to remove this tumor. I will show the surgical video. I just put the craniotomy with the size of 3 centimeters, and then I gently insert the endoscope around the temporal base. Now, this is a V3, and I stimulate the GSPN and identify the cause of GSPN. And then I cut the dura, medial side of GSPN, and expose the Petrus apex and trigeminal impression. Now, I fully expose the trigeminal impression, and this is a Kawasaki triangle. So I carefully drill out the Petrus apex. So surgical view is looks like the anterior transpetrosal approach. Now I coagulate and cut the SPS, and then I start the detachment of the tumor. And then cut the tentorium to the medial side. Now I completely cut the tentorium and identify the post nerve. Then I resected out the old tumor. This case, tumor compress the SCA, and also SCA compress the trigeminal nerve, like this. This was the cause of her trigeminal neuralgia. Then I mobilized the SCA of the trigeminal nerve, like this. If we insert the endoscope more deep side, we can identify the sixth nerve like this. And then also we can expose the 7 and 8 nerve. So craniotomy is small, but actual surgical view looks like the anterior transpetrosal approach. So I limitedly drill out the petrous apex and then remove the old tumor safely. I also applied this technique to the dumbbell-shaped trigeminal schwannoma. Patient shows a trigeminal neuralgia. Tumor occupies a Meckel cave, posterior fossa, and also infratemporal fossa. But using the endoscope, we could safely dissect out the 3 parts of the tumor. Our strategy is the same. At first, I put the craniotomy with a size of 3 centimeters and then insert the endoscope. I also stimulated the GSPN and expose the Kawasaki triangle. And then carefully drill out the petrous apex. And then open the Meckel cave. In case of the trigeminal schwannoma, just subcapsular dissection is enough. So dissection of the tumor is not so difficult. So I carefully remove the tumor gently. And this is a normal trigeminal fiber. This is a tumor along the infratemporal fossa. So I use a 30-degree endoscope to get the look-down view and remove the tumor around the infratemporal fossa. And finally, all tumor was resected out. Tumor around the Meckel cave, posterior fossa, and the infratemporal fossa was successfully resected out. I also use this procedure to this case. This is a chondrosarcoma associated with osteogenesis imperfecta. So patient shows a basilar invagination. So the angle of the tentorial edge was very steep. So it's very difficult to see the upper margin of the tumor. So I apply the endoscopic enonasal approach. I carefully retract the temporal lobe and expose the tumor like this. This is a post nerve. Using the endoscope, we can observe the upper margin of the tumor and carefully dissect it out like this. This is the trigeminal nerve. I carefully dissect the tumor from the trigeminal nerve and also resect it from brain stem. And finally, all tumor was successfully resected out like this. This is another case of the petroclival meningioma. During the follow-up, tumor rapidly increased in size, but patient age was very old. So I choose a less invasive procedure to remove this tumor. So I apply the also subtemporal keyhole approach, and most part of the tumor was successfully resected out like this. Then I will show the endoscopic keyhole interhemispheric approach. This is a falcotentorial meningioma. But if we use the endoscope, we can easily identify the attachment of the tumor along the falx and the tentorium. So I also use the same procedure. I put the patient to the lateral position and put the craniotomy with the size of 3 centimeters, and then insert the endoscope. This is the falx. I coagulate and cut the falx, and also start the internal decompression. Endoscope can offer a very clear and wide view around the deep seat area, so we could safely dissect it out from the brainstem and also deep venous system. So finally, all tumor was successfully dissected out through the endoscope. This is another case of the tumor. The size is very large, but the concept is the same. So I choose the same procedure. I skip the surgical video, and also all tumor was successfully resected out. I published the surgical technique and anatomy to World Neurosurgery about the subfrontal keyhole approach, and also published the surgical technique and anatomy of the interhemispheric keyhole approach. So, of course, we have to master several techniques, but endoscopic, endonasal, and transcranial surgery can be very effective procedure for removing the various kinds of the skull-based tumors. Thank you for attention.
Thank you very much, Professor Goto, for your excellent lecture and interesting cases that you have shown to us. Dr. Atik, you may ask your question.
Yeah, thank you, Professor. Thank you very much for your extraordinary presentation. Basically, I am so fortunate that by the help of Professor Ryoko Kato, I had the opportunity to visit your center last week and observe your few cases. That was a very nice experience for me. This is basically the era of minimally invasive surgery. So what do you share some tips for the young neurosurgeons, how they can build them up? Because this is advanced level surgery. One cannot start and do this kind of surgery. There should be some steps. So would you please give some suggestion for the young neurosurgeons, how they can build a stepwise to do critical cases like this? Thank you.
Thank you for good question. Of course, today I present a bit advanced technique to endoscopic skull-based approach. So I want to talk to the young neurosurgeon. At first, it's better to learn the basic micro-surgical technique. How, for example, open the Sylvian fissure or resect the tumor very carefully under the microscope, and then minimize the surgical field, and then start the endoscopic procedure is very safe technique to learn the technique. I think to learn the endoscope, it's better to start apply the pituitary adenoma or latoke cleft sheath as the first step case. And then if you're familiar with surgery of pituitary adenoma, then move to the more advanced stage, like the chordoma or chondrosarcoma, epidural tumor. And then finally go to subdural region, like the meningioma or craniopharyngioma. So step by step advancement is very important for safe surgery for the patient. Thank you for good question.
Thank you very much.
Thank you for the question, and thank you again, Professor Goto, for the nice illustration of all cases, all difficult cases that were done well. And I think we reached the end of today's webinar. We almost time to the next day in Japan. So without further ado, I will we call upon Professor Kato to give her closing remark, Professor.
Thank you very much. For almost 8 hours, we learned a lot. So today, our webinar is ACNS and EANS, and also the North Africa. So I think a bit still some gap in between the continent or the countries. But I think in the future, for ACNS, through many occasion or chance, you can minimize the gap. Maybe you can transfer to the younger generation, and also that you can teach the other countries, the doctors. Finally, the Dr. Koto Sensei and Yosha Sensei, thank you very much for your nice lecture. Almost Egyptian or some other countries doctors has already gone. And also I visited with Koto Sensei so many places, Africa and also the Vietnam. So Vietnam countries people are very clever, so they learned very enthusiastic and also very I think hard work to learn, and they can have a good skill and knowledge for the surgery. Yeah. I think in the future, I think everybody, the very experts taught you a very basic thing is to learn the anatomy, and also the Koto Sensei said, of course, the endovascular or endoscopic surgery is good for the minimally invasive for the patient and also the doctors. And also, but the fundamentally, he says that under the microscopic the procedure or skill is maybe apply for the endoscopic the surgery in the future, I think. Finally, thank you very much for co-host the professors and also the ACNS educational team. Thank you very much for till almost the next day. I want to finish.
Thank you. Thank you.
Yes, today's webinar.
Professor. Professor He, are you still here, Professor? Professor Dong He? Yes?
Yes.
Yeah.
Okay. Thank you very much, Professor Kato and Professor Liu. And I'd like to say many thanks to all the view on the speaker. And we have an excellent webinar. It's long webinar, but it's very useful for us as the Society of Neurosurgery in Vietnam. And we don't have enough training and education in Vietnam, and that's how the webinar like that is very, very interesting and very useful for everybody in Vietnam. We hope to get to another webinar like that in the near future. Thank you, everybody.
Thank you, Professor He. And last but not least, we will hear from Professor Chokumbi. Professor, your closing remark, Professor.
Thank you very much for organizing this and for bringing all of us together. It's been a very valuable manual for teaching skills and advancing knowledge. And on your behalf, I'd like to thank all the presenters and express appreciation to them for attempting to push the envelope and to show us what is possible. I look forward to more of this, and hopefully this collaboration would advance neurosurgery in underserved parts of the world. Thank you.
Yes, thank you.
Thank you so much. Thank you.
Thank you. Just for your information, we will have another webinar in the month of November. Hopefully all of you can join us again. And with that, I think it's time for us to say bye-bye. And thank you very much. Arigato gozaimasu.
Thank you very much. Bye-bye.
Bye. Bye. Professor Kato.